I will start again. So good morning again and welcome back to the Pisa Sleep Award that this year is celebrating Dieter Riemann and his wonderful work about insomnia and about the European Insomnia Network. And I am Laura Palagini. I am a psychiatrist from the University Hospital of Pisa and also a part of the sleep group here in Pisa, together with Michelangelo Maestri, who is a neurologist of the University Hospital and an important part again of the sleep group in Pisa. And we are going together to discuss this morning the complex association between sleep and mood with a lot of terrific researchers, so stay with us. Before to start, some instructions for speakers. You are invited to ask questions by raising hands and talk directly. And for participants, please write your questions on the DNR part and we will read them for you. And so let's go and start for this section of this morning with a great friend of our sleep group in Pisa and a full professor of neuropsychiatry, child neuropsychiatry at the University of Genoa, that is Lino Nobili. And he is a part of the board of the Italian Association of Sleep Medicine and was in the board of the Sleep Research Society with Dieter. So please, Lino, let's discuss one of the most important topic for us that we are psychiatrists, that is the importance of sleep during adolescence. So, Lino, please. Let's discuss your presentation.
Good morning to everybody, and thanks for the invitation at this meeting. It's always an honor for me to participate in the Pisa Sleep Award. I'm Lino Nobili, a clinical neurophysiology, child neuropsychiatrist, and the title of my presentation is Sleep and Psychiatric Disorders During Adolescence, an Opportunity for Prevention. So the first point is adolescence and mental health. This is really a big issue. Indeed, mental health conditions account for 60% of the global burden of disease and injury in people aged 10 to 19 years. And half of all mental health conditions start by 14 years of age, although most cases are undetected or untreated. Depression is one of the leading causes of illness and disability among adolescents, and moreover, suicide is the third leading cause of death in the adolescent population. It is extremely important to address adolescent mental health during adolescence in order to prevent further disorder in adulthood, and this is really something very crucial. Okay. It's important to say that, as you can see here, during adolescence and even before, many psychiatric disorders emerge. And here you can see that the development of different cortical structure is not really homogeneous. In particular, the developing brain is characterized by a high degree of neuroplasticity, and this probably is ecological advantages, although such a high degree of neuroplasticity can make the developing brain particularly vulnerable. In particular, perturbation to a methylene system can disrupt the refinement and cortical circuits, and this can also have long-term consequences for both cognitive and also emotional function. And there are research studies showing that exposure to stressor during the development, especially during early life, can shift the timing of prefrontal and subcortical development. Moreover, many studies have shown that while robust structural changes occur within specific area in infancy and childhood, the refinement of the connection between the different structure between different brain regions is really a crucial moment in adolescent development. And moreover, finally, we say adolescence reflects a peculiar sensitive windows during which different circuits and different circuit level formation are highly sensitive to the environmental changes. For example, if we consider the development of the prefrontal cortex with respect to the development of the limbic region, as you can see, this is not really homogeneous, and there is a kind of decoupling between the limbic regions with respect to the prefrontal cortex. There is a predominance of subcortical regions over the prefrontal areas, and this promotes heightened sensitivity to both emotional and appetitive aversive, I would say, emotional salient cues, for example. So if it's such a, I would say, this decoupling, this unparalleled evolution of the two systems is probably again ecological advantages, because and is really an opportunity for the adolescents, because it can increase academic motivation, can increase the sensitivity to social connection. On the other hand, can also be a condition that favor a pathological trajectory in the evolution of the mental health of the adolescents. So increased risk of drug experimentation, risky sexual behaviors, and so on. So there is a kind of prevalence of bottom-up afference with respect to the top-down control from the prefrontal cortex. So this can really impact the emotional equilibrium of an adolescent. And it's extremely important to underline that this circuit is the circuit that is always involved in psychiatric disorder. We know that persons suffering from schizophrenia, depression, post-traumatic stress disorder display structural and also functional anomalies at the level of this circuit between the prefrontal circuit, the hippocampal, the limbic system, including the amygdala, and so on. So this is really a peculiar hub that is involved in many psychiatric diseases. Let's now move to sleep and circadian rhythm in adolescents. I have only one slide because probably this morning you have heard other talk on this topic. Just only to underline the fact that during adolescence we have a marked reduction in slow wave activity, the spectral power in the low frequency band, and this is in parallel with the reduction of the cortical gray volume, especially over parietal and frontal regions. So this reduces the homeostatic pressure of sleep during adolescence. But moreover, we have also a physiological shift of melatonin. There is probably a physiological reason for that, although there are also external factors that can influence this delay. However, the delay that we have in the peak of melatonin during adolescence is something that can really predispose the subject to sleep deprivation, because, however, the timing of the school is always remain the same, of onset of the school remain the same. So the other point is, are adolescents sleep deprived? And if they are sleep deprived, which is the impact of the sleep deprivation on adolescent behavior and mental health? Adolescents are probably sleep deprived, and they represent the population that has much more sleep deprived than the others age group. In this very recent paper published on Nature Human Behavior, involving more than 1 million people, is a systematic review and meta-analysis going in deep analyzing the single subject data, it's clear that more than half of subjects in the age from 14 to 70 years reporting sleeping less than recommended by the American National Sleep Foundation. That means that sleeping less than 8 hours, and also almost about 20% sleep less than 7 hours. This is mostly related to the fact that they go to sleep later and they wake up at the same hour. So which is the effect of this deprivation? We have some experimental studies that have been conducted using, for example, fMRI, showing that when an adolescent is sleep deprived, so there is a reduction in also in the production of slow wave activity, there is an increase of activation of the limbic system. So the bottom-up activation is extremely predominant with respect to top-down control from the prefrontal cortex. So the amygdala, when we are sleep deprived, is much more activated in front of an emotional stimuli or in front of a test that try to assess the risk, the risky behavior of a subject. So there is also a reduction in the connectivity between the prefrontal cortex and the amygdala. There are many studies, this is one of those, showing, for example, that adolescents that report poor sleep exhibited greater risk-taking, and there is a less recruitment of the dorsolateral prefrontal cortex during cognitive control, a greater insular activation, and a reduced functional coupling between the dorsolateral prefrontal cortex and the affective regions, including the insula, the ventral striatum, that are all involved in the reward processing. But these are experimental studies. This is a field study published on JAMA Pediatrics 3 years ago, conducting a very large population of adolescents, showing it first that only 30% of this population of adolescents reported 8 hours of sleep. But here on the right, you can see this graph showing that there is a kind of exposure-response relationship between the number of hours that the subjects sleep during the night and a series of risk-taking behavior, including driving. Consider that in the USA, adolescents drive at when they are 16 years old, tobacco use, alcohol use, marijuana use, risk sexual activity. As you can see, the less adolescents sleep, the more is the risk of risk-taking behavior. So it seems, although this is not really, we have not a demonstration of the causal relationship, there is clearly an association between sleep deprivation and risk-taking behavior in adolescents. And this is another study, again, showing that sleep duration on school nights is also correlated to depressive symptoms. The less adolescents sleep, the more we can find higher score in the depression scale. And also here, if we compare adolescents sleeping less than 7 hours with those sleeping more than 8 hours, as you can see, there is an increased risk of many symptoms of depression and anxiety. And even more, when adolescents sleep less than 6 hours, there is also an increased risk of suicide ideation and suicide attempts. And now let's move to insomnia. So before we were speaking about sleep deprivation, now we really use the term insomnia, sleep disorders, and mental health in adolescents. Again, taking into consideration the same study that I showed you at the beginning, the one published on Nature Human Behavior, as you can see here, during adolescence, there is a great increase in the percentage of subjects suffering from difficulty in initiating sleep and difficulty in maintaining sleep, especially in the female group. So you can see this is really the population where we can see the highest level of difficulties in falling asleep and maintaining sleep. And moreover, if we consider young studies conducted in young people that are at high risk of psychosis, sleep problems are really widespread, with estimate of prevalence that exceed 75%. So, but the main important question is insomnia or sleep disorder predictors of mental disorder in the general population? This is a systematic review showing, this is more in the general population. This is a review from the group of Professor Riemann showing that insomnia is a risk factor for depression, anxiety disorder, alcohol abuse, and psychotic disorder. So insomnia is really a predictor for the future also of the depression, anxiety, and other manifestations. So it's extremely, as author says, it's extremely important to include an extensive sleep evaluation during the diagnostic approach to subject at risk of psychiatric disorder, and not only. This has been described in the general population, but there are also data showing that this is true also in adolescents and young subjects. This is a study published on JAMA Network Open very recently, again showing that disturbed sleep and depression are extremely linked, and insomnia seems to be a risk factor for depression also in this population of very young subjects. Again, in the same, similarly to the previous study, in this recent systematic review and meta-analysis that has been published on Sleep Medicine Reviews, it has been shown that not only insomnia, but also other disorders, such as hypersomnia or circadian disorder, increase the risk of psychiatric disorder, also severe, such as depression, bipolar, schizophrenia. So although authors clearly underline the fact that this association seems to be at the moment modest, but it really, however, consistent. So they really underline the importance of assessing sleep disorder also during childhood, even before adolescence, in order to prevent, or at least to reduce the risk of psychiatric disorder. I believe that this would be also extremely important to assess sleep disorder, because the presence of the sleep disorder can also give us some information regarding the trajectory of the possible psychiatric disorder that could start and develop. And also this, I think, is an important observation that there is an association between sleep disturbances and suicidal ideation in adolescents, as has been shown in the systematic review. So again, this is important. It's important because we can treat sleep disorder, and if we treat sleep disorder, we can probably reduce the risk of psychiatric disorder or of a situation like the one of suicide. Indeed, as it has been really a very elegant way in showing in this picture from a paper of Professor Riemann, insomnia whose causes are very different from genetic, early stress during infants, neurobiological mechanisms, and so on, personality characteristic. However, at the end, insomnia creates an emotional dysregulation, and the emotional dysregulation probably also acts in a vicious circle, favoring psychopathology, thus maintaining insomnia, and so on. So the emotional dysregulation can be really then a factor, increases extremely the risk of psychiatric disorder, like in this case of depression. So it's important to say and to be able to recognize if treating insomnia could be really also effective in reducing the risk of mental disorder. We have not so many data on this issue. However, again, we have this systematic review showing that if we treat insomnia, this is in the general population, if we treat insomnia, we can reduce the risk. We can reduce symptoms of depression as measured, for example, by the Hamilton's questionnaire or by the Beck Depression Inventory Scale. And from the group of Daniel Freeman from Oxford, they published a couple of years ago this is a pilot study showing that the treatment of sleep disorder in young people that have an high risk of psychosis can be effective in reducing the risk. And indeed, that there is, I think, a study that is now running from the same group. It's a protocol where the main aim is treating sleep problems in order to reduce the risk of psychiatric disorder. And this is really the main goal. It's really the main goal also because we can probably reduce the risk, for example, of suicide, as it has been shown in this study published in the American Journal of Psychiatry. This is a study not involving really young people. However, there were some population from 18 to 60 years old. But the main message is that if we treat insomnia, and we are effective in treating insomnia, in this case, insomnia was treated with the controls released zolpidem. If we increase sleep quality, we have also a reduction in the score of suicidal ideation. And this is a very important therapeutic effect that we can have achieved. So in the future, I hope that there will be other studies conducted also in young subjects and in adolescents in order to see if we can really change the treating sleep disorder or recognize it very early sleep disorder. We can prevent or, however, identify very precautiously the direction of the evolution of a possible psychiatric disorder. So I want to conclude again with this sentence from a paper published in Lancet Psychiatry by the group of Daniel Freeman from the Department of Psychiatry of the University of Oxford, that intervening on sleep at an early stage may be a preventive strategy for the onset of clinical disorder. So it's important that also psychiatrists give sometimes when they make the clinical assessment to also sleep characteristic of the patient and try to also modify from sleep hygiene to other approaches, however modified, and to change the sleep disorder in this population. I thank you very much for your attention.
So thank you, Lino, for this wonderful, wow, for me, for your presentation. And I mean, it is so important. So we are waiting for some questions, but I have a lot of questions. I will start with one question. Then we have Michelangelo and Leila and Pierre and so on. So first of all, I'm asking to you, so what we can do? We are people that we are involved in a lot of different sleep societies. So what we can do all together to prevent these sleep problems during adolescence? We can change in this way the trajectories, for example, of psychiatric disorders. What do you think?
First, thank you for your comments. But Laura, sincerely, I don't think we can really say definitive things because we have not many big studies showing how can be the evolution of a psychiatric disorder if we treat a sleep disorder in a patient. However, more and more we have literature showing that sleep disorder also in very early infancy can be really something, a kind of biomarkers for a possible trajectory also in the development of some psychiatric disease. So I think that we are obliged as scientists and clinicians to try to go more in deep in the phenotypes of this kind of disorder. This means that we have to study more this kind of sleep. So also, I think we need also to assess which kind of alteration of sleep. So could be also, we need, it's probably not doable to make PSG for all patients suffering from insomnia. However, I strongly believe that we need to know much more about which kind of insomnia, because now we know that there are insomnia that is more REM related, insomnia that can be associated with the non-REM deprivation, and so on. So there are many aspects. And if we are able to characterize the phenotype, and then we can also really personalize the treatment, we could probably see and try to answer to your question. And I think that if we, in my experience here now that I'm working since 3 years with adolescents, sometimes with very severe disorder, you will really always see that sleep disorder, sleep alteration started months or years before. So at least sleep alteration is a window to for an early detection of a possible evolution in a psychiatric disorder. So we have to work on that.
Okay, we have a lot of questions. So Leila.
Thank you so much for that very beautiful and clear talk. Since the idea is to be a little bit provocative here, I have kind of two questions. One is that when I work with patients in the clinic and adolescents in particular, they have a hard time sticking to a lot of the sleep hygiene rules. So for example, using the bed only for sleep, well, the bed is usually their only place to hang out alone, without their parents, and, to have their time. And then, and so like a lot of the sleep hygiene parts can be more challenging with the adolescents. And another thing is, are they perhaps more resilient to sleep deprivation? So sometimes I see them, they say, oh, I have sleep problems, I can't sleep well, but no, I'm not willing to change much in my lifestyle, and no, I want to keep my cell phone next to my bed, and so on. And I think, there might be a component where they're able to deal with this heavy sleep load, where as adults, we feel overwhelmed if we're sleeping 3 hours too less 5 days a week. And somehow these adolescents are, maybe because they're younger, their brains are younger, they're able to push through these extreme periods of sleep deprivation, not meaning that they wouldn't fall asleep if they're driving a car and so on, but somehow they're able to tolerate it well in some aspects. And do you have any ideas on?
Thank you, Leila, for this comment and question. I agree with you that try to modify sleep hygiene in adolescents can be really tough, really difficult. However, if you look at the paper that I also included in my presentation, the one published in Human Behavior, Nature Human Behavior, you see that adolescents pay the price. So they think not to pay the price, but they are sleepy. They are sleepy. So they do not really they are not able to estimate that sleep deprivation create a negative effect on their behavior. So it's clear this is something I think also ecologically needed. It's something that probably is always adolescents that sleep less and the behavior, but the effects of sleep deprivation are there also in adolescents. So this is very difficult to explain to them. But if you go in deep in the analysis of data, you see it seems that they say, okay, I'm able to stay awake. And this is true. I remember also when I was adolescent, I could stay awake all the night, and then I was strong. But indeed, I paid the price. I'm sure I paid the price. And also data clearly show this. So you can pay the price by being sleepy or by modifying your, I have to say, your mood. And so and then the adolescent is not able to realize that his mood could be better if he could apply a better sleep hygiene, because his adolescent is always a rebel. He needs to be a rebel. No, he needs to be a rebel. This is ecological determined, and I agree with them in order to be rebel. But they need also to understand that it is not safe for them.
Yeah, I mean, I absolutely agree. They pay.
So it depends what you have in front. You can have. It's important for you. There are some patients where they can do everything. Some adolescents with their bed. We can work, stay in bed, look at television, and they sleep well. And the others that have more difficulties in doing that. So there are adolescents that are more prone to to take a very bad direction if they alter their sleep hygiene. This is what I mean.
Yes. I mean, I absolutely agree that the price, and you know, going back to your talk, I think it's this underdeveloped, you know, prefrontal cortex that they, you know, they don't really have it goes along with the risk taking that they don't think about long-term consequences. Thank you so much.
Thank you to you.
Oh, thank you, Leila, and also for your presentation yesterday. It was terrific. I like it a lot. So, Pierre, do you have a question?
Yeah, very short question. Thank you. It was a very interesting talk. A quick question about differences maybe that are observed in these researches comparing acute and chronic sleep deprivation. Is there differences regarding the neurodevelopment or the neuroplastic adaptations in use? And linked with this question, in adolescence, there are also often suffering from sleep phase delay, which is another main cause of sleep deprivations. And is there differences of effects between sleep phase delay or insomnia?
Well, I think for sure there are differences. I think there are differences in the phenotype if you are insomnia or you have a phase delay. Very frequently, as you say, adolescents have a phase delay, and then this can provoke a sleep deprivation. If you look at literature, you have studies that show the effect of, for example, acute sleep deprivation, and this is evident immediately, changing the top-down and bottom-up direction of the limbic and prefrontal cortex. This is clearly evident also after acute deprivation. But I think in clinical practice, what is important is more the chronic effect of sleep deprivation. Then, in my opinion, there is, if you have an adolescent with a psychiatric disorder or mood dysregulation, the acute deprivation can be the one that can really lead to a behavior that can be dangerous. I'm thinking about, for example, suicide. When you are really sleep deprived, you can not be able to really recognize it to be, to say, rational about also your feeling. So acute sleep deprivation can be a dramatic trigger in a patient suffering from chronic deprivation and with some predisposition for depression, for example.
Wonderful. I totally agree with your, point of view, and thanks, Pierre, for this so important question. I have another question, and then there is Michelangelo that want to ask you something. You know that one of my topics is the association between early life stress and among early life stress, insomnia, and mood disorders in adult life. So do you think that by targeting insomnia or sleep disorders, in some ways, we can prevent from the effect of stress on the brain during neurodevelopment?
This is really challenging, and I hope so. Because because we can really work on sleep. So I think sleep alteration can be a part of the important part in the development of psychology in children. For example, what we are running now here, we have a project for early preterm infants, for example. They are really at risk for autism more than the other population, and also other psychiatric disorders. And there are data also showing, the data, if you think about the data of Bloomberg, showing that alteration of REM sleep can be also very important for the development of cognitive development. So I think that we need to run some large study in order to see, to give an answer to your question, because it would be great if changing sleep or recognizing very early sleep alteration, we could really impact on the evolution. So I don't think we can really have a definitive question, but I'm just really, I think that confident that we could really work on this area.
Yeah,
next year.
It could be. Yeah, it could be an area that we can study together, I hope. So I think Michelangelo has a question for you.
Yes, I have a question from the audience. Now, thank you, Lino, for the communication, for your wonderful data, your wonderful talk. And after, if it is possible, I have to ask you something. Then, first of all, there is a question from the audience. Andrea Bazzani asked if you think that an early detection of specific sleep alteration might guide in the differential diagnosis of mental diseases, considering the perspective of different neurodevelopmental trajectories.
Yes, I think so. It's the same question of Laura.
Less,
so
yes.
We need to create a really different phenotypes. So the child that have difficulties in falling asleep, and then this is a trajectory. The child that have many awakenings, and now we know that there are also some probably strong neurobiological difference. There are also the study that was recently conducted by Oliviero Bruni and Raffaele Ferri, trying to really differentiate the phenotype of insomnia. And so, yes, I think that we can individuate the children that are more prone to enter into a transaction towards an anxious disorder, and other that are more prone to go towards a mood alteration. So in this sense, so we are going back to the old school, because if you remember well, the research in the field of sleep was at the beginning strongly also supported by psychiatrists. If you remember, the REM hypothesis related to depression was very, and now we are going back, probably understanding much better, I would say even more. We are now probably the possibility to create also a link between REM alteration, dreams, depression, so going close to Freud and to the really neurobiology of sleep. So this is the main objective, I think. Try to connect all the different theories about this, and give our aim is to give the biological really basis of all these theories. And so Riemann is working on this since many years, and so.
That did a terrific work. And
also the recent paper published by Heusbau Sommeren related to REM alteration as a really the biomarkers of some types of psychiatric disorders. So this
and this the REM instability of insomnia.
REM instability and so on, no? Yeah, absolutely.
Yeah, sure. Wonderful presentation and kind of inspiring discussion. So there are some other questions coming. Otherwise, we can move on. Do you think we can move on?
Yeah, I think so.
Thank you so much, Lino. It was wonderful. It was wonderful.
Bye. Thank you. Thank you to you. Bye-bye.
And so let's move on with one of our friends. It's Dr. Lukas Frase. He's a psychiatrist and sleep physician at the sleep laboratory of the Psychiatric University Medical Center of Freiburg. He is a part of the DITER lab. So let's move on with his presentation. That is, the idea is that maybe targeting depression by targeting insomnia, it could be a way to target depression. So let's discuss this with Lukas.
Buongiorno, dear colleagues. I'd like to thank every one of you for your interest and attendance in this conference, and the organizers for giving me the opportunity to present today and speak about treating depression by targeting insomnia via pharmacotherapy. My name is Lukas Frase, I'm the attending psychiatrist and sleep physician at the sleep laboratory at the Psychiatric University Hospital in Freiburg, where it's my pleasure and privilege to work with Dieter Riemann on a daily basis in our sleep laboratory. The relationship between insomnia and depression has been known for a long time to be complex and bidirectional. Two examples of this I want to show you at the beginning. One is the study by Michael Perlis and colleagues, and they demonstrated that if you look at patients with recurring major depressive disorder, that you can see onset of insomnia symptoms up to 3 weeks prior to relapse into depression. Second interesting finding, commonly known in depression, I want to briefly highlight, is the relationship between affective symptoms of depression with prior sleep and the improvement of symptoms or the decrease of depressive symptoms, so to speak, following sleep deprivation, and sometimes worsening of symptoms in the morning following sleep. So we have the relationship of insomnia and depression during the depressive episode, as well as in between depressive episodes. A recent meta-analysis therefore showed again that if you diagnose insomnia, the odds ratio for the risk for expressing depressive symptoms, for getting a major depressive disorder in the future is highly increased to an odds ratio of 2.8. Insomnia therefore has been defined as an independent predictor for depression. During an ongoing depressive episode, patients typically speak about difficulties in sleeping, about an increase in awakening or early morning awakening, and those findings can also be seen using polysomnography. The patients with depression commonly express a disruption in sleep continuity and reduction in sleep depth, as well as an increase in REM pressure and REM stability. Those findings are somewhat similar to the findings in insomnia, but not exactly the same. If we look at pharmacotherapy, on the other hand, almost all agents used in the treatment of insomnia target the ascending arousal network. Here we have cell groups in red depicted that use monoaminergic transmission to induce wakefulness by activating the brain cortex. And we have cholinergic cell groups depicted in yellow that have the same effect on the thalamus. Together, they keep the brain in a state awake, which is then stabilized via orexinergic transmission depicted green here. During sleep, all those activating cell groups are inhibited by GABAergic transmission from the ventrolateral preoptic area depicted in light blue. And in addition, in darker blue, the melatonin signal signals the onset of the shift from activity to sleep. If we look specifically at antidepressants, the main sedating antidepressants we use in clinical practice target this pathway, and the strongest sedating effects are described for anticholinergic agents, for example, trimipramine, doxepin, or amitriptyline. The second main pathway for sedating effects are antihistaminergic effects, as we see in trimipramine and doxepin again, in addition for mirtazapine. But also adrenolitic effects, as seen in doxepin, and anti-serotonergic effects, as seen in trazodone, can explain sedating qualities of the chosen medication. Of special interest, I want to highlight that doxepin is the only substance that has antihistaminergic, adrenolitic, and anticholinergic effects, therefore having various pathways coming together for the strong sedating qualities. Doxepin at the moment is the antidepressant with the best evidence for use in insomnia, and is therefore the only antidepressant that is recommended by the current AASM guideline on pharmacotherapy of insomnia. If we go back to remember that insomnia is considered a predictor for the next recurrent episode of depression, then we can look whether those medication is capable in relapse prevention, and the common review again summarized that almost all commonly used antidepressants are in fact capable in relapse prevention, and the substances I just showed you on the last slide all have a relative recurrence risk reduction of around 2.0. As a first conclusion, I want to state and want to bring into the discussion with you the statement that in patients with comorbid insomnia and recurring depression, pharmacological treatment of insomnia with sedating antidepressants might prevent relapse of depression and should therefore be considered even in the absence of effective symptoms, which is slightly different than the common recommendations we formulate in our guidelines. For the last part, I want again come back to the concurrent occurrence of insomnia and depression and want to show you two studies. The first one is an exploratory analysis of Cipriani and colleagues that looked at potential effect modifiers in antidepressant treatment of major depressive episodes. And while most findings were as to be expected, one finding of special interest to me was that insomnia, concurrent insomnia at the time point when we choose the medical agent, highly significantly reduce the effectiveness of pharmacotherapy by decreasing the difference between antidepressant and placebo group. The medication group was mostly completely comprised by SSRI or SNRI treatment. There was one study with mirtazapine intermingled, but my understanding these effects are mostly due to serotonergic agents. The authors concluded that insomnia at onset on treatment might decrease the efficiency of SSRI treatment in depression. Second study in this direction I want to show you is from Japan. The study in outpatients with major depressive disorder, where patients either received mirtazapine or SSRI, and all patients were treated with benzodiazepines in addition. Benzodiazepine treatment appears to be a very common treatment protocol for major depressive disorder in Japan, as I understand. Then the authors looked whether it was possible to decrease or discontinue benzodiazepine treatment during the following weeks. And they described a very clear and highly relevant difference between the mirtazapine and the SSRI group, with mirtazapine almost leading to full discontinuation of benzodiazepine treatment, while most patients receiving SSRIs still needed to get additional benzodiazepines. What I want to bring into discussion is the second conclusion point, therefore, is that when selecting medication for depression, comorbid insomnia during the time frame when we decide which medication we should use might influence the effectiveness of the chosen agent, for example, by diminishing effects of SSRI treatment, and should therefore be taken into account when choosing a specific pharmacotherapy regime for major depressive disorder. With those two conclusions and talking points, I want to finish my presentation, and thank you all again, and looking forward to the discussion.
Thank you so much, Lukas, for your presentation. I mean, it's so important. It seems that by targeting insomnia, we may improve at least unipolar depression. While waiting for some questions, I have a question for you. So it seems that doxepin is a kind of the best antidepressant for doing this job in depression. But in Italy, we don't have, I think we share this problem with other countries. So what do you think, what do you suggest the best instead of doxepin? And what do you think, you know very well that according to international recommendation for insomnia treatment, among pharmacological options, we have melatonin, at least in Italy, 2 milligrams, prolonged release, or sedative hypnotics. So what do you think about targeting insomnia with these drugs in unipolar depression?
Yeah, thank you very much for the interesting questions and follow-up. For the first part about antidepressants, I think that while the data suggests that doxepin we have the most experience for treatment effects in insomnia, I would expect similar effects for comparable antidepressants. And for example, trimipramine at least shows a somewhat similar receptor profile. And I would expect similar effects for trimipramine treatment. If you look at depression and insomnia combined, then I really think that the antidepressants there make a strong case for getting to use more in insomnia treatment than we dare to recommend at the moment in the guidelines. For melatonin treatment, I'm not too convinced that I would expect strong effects on depression, on unipolar depression. I would not really recommend for this indication, but I see a case for melatonin in bipolar depression. But I don't want to speak too much about bipolar depression before listening to the follow-up talk that will soon start here. And for the last question to benzodiazepine receptors or agonists, I'd like to highlight that benzodiazepines on their own might induce the depression-like state because of their really not only sedating but inhibiting qualities on various brain cycles. So I would be careful with benzodiazepines in long-term treatment in patients with a risk for depression because it might have negative effects as well. If we speak about acute crisis treatment, for example, with suicidal ideation or something like that, it's a complete different case, but then we target depressive symptoms if we are honest and not independent insomnia.
Okay, thank you so much for your answer. I think that anyway, melatonin could be very good for unipolar depression too, because anyway, they have, as bipolar patients, they have problem with the, clock gene expressions. And so by treating insomnia with melatonin, we can address maybe insomnia and circadian disorders even in unipolar depression. But it is just my experience. Let's discuss them later also with Pierre. Pierre, please.
Pierre, please.
Pierre,
please.
Yeah, thank you very much. Absolutely agree with you, Laura, that both for treating insomnia, maybe some circadian rhythms, but also to help to decrease benzodiazepines, melatonin could help in this population, and these are the guidelines we made with Italian and French societies. I had a question for you, Lukas, and thank you. This was very, very interesting talk. We also meet a problem in clinic, which is that some antidepressants induce insomnia. And for example, for resistant patients we are using monoamine oxidase inhibitors, such as phenelzine, which is inducing insomnia. And this is very difficult in clinical practice. And what do you suggest as treatment adaptations to treat these symptoms?
That's actually a tough question because those patients most of the time had a lot of pharmacotherapy in between different episodes. So as I know those cases from clinical practice, most of the time medication is really complex. I think in our hospital with patients that are already on MAO inhibitors or some third or fourth line treatment, they usually had most of the common antidepressants in the past anyway, without strong effects. So in those patients, we most of the time then fall back on sedating antipsychotics like quetiapine or something.
Okay, but for instance, for these particular patients, and there are a lot who are treated with monoamine oxidase inhibitors and had insomnia. What are your preferred combinations? Is there antipsychotics? Is there other treatments?
So we don't really have evidence, I would say, for those patients, and we don't have clear recommendations. In general, I always try to formulate recommendations, for example, in my medical notes or something like that, targeting the symptoms of the mental disorder to prevent healthcare providers from challenging the recipe if it's for insomnia. But if you speak about sleep disturbances in the context of severe mental disorder, then you have a broader spectrum of alternatives available. And of course, in the first case, I would try combining it with antidepressant medication. We don't use monoamine inhibitors in our hospital too much. The patients that are treatment resistant like that, we usually use ECT or other stimulating non-pharmacological options more at the moment. So we don't have that much experience here. Probably I would use quetiapine in this case.
So let's work on clear recommendations on this topic, right? All together. I mean, it's going to be, we need more clear recommendations on this important topic, right? So that's the point where we start. Anyway, I have another question, okay? For Lukas, I was wondering, I mean, since REM dysregulation is, a key feature is of both insomnia and depression, unipolar depression at least. What do you suggest to target this, REM dysregulation? Is going to be the way in which the treatment can be effective, right?
Yeah, it's again a very interesting topic for medication in insomnia and depression. From our experience, our data in our sleep laboratory, we see a lot of depressed patients in the sleep laboratory as well. And it's very clear that the strongest REM sleep suppression, REM sleep disturbance comes from venlafaxine or other serotonin, noradrenaline reuptake inhibitors. And the second most effects we usually see under SSRI treatment in our sleep laboratory data, which kind of makes sense because our clinical experience, for example, with venlafaxine is also very good in treatment of depression. However, I would be somewhat careful with really trying to suppressing REM sleep too much with medication, because on the other hand, we see a lot of rebound phenomena following strong REM suppression. So while I'm convinced that the REM modulating aspect is a really integral part of the workings of those medication in targeting depression, I wouldn't try to stress the effect too much, because I think then we come in the direction of REM sleep rebound, possibly even during the day. That could also induce further problems. So I'm convinced it's a very important topic. I'm not quite sure if we can formulate concrete guidelines from this.
Yeah, sure. So we have to work a lot. And I have also another question.
Dieter.
Okay. Dieter?
Sorry.
Maybe just a brief comment.
Yeah, sure. Okay.
I have a lot of scientific experience with trimipramine going back to the 1980s. And the sensational thing about trimipramine was that it was at that time the only antidepressant not suppressing REM sleep. First, we thought this is a bad thing, but there's a pilot study published in 1987, and we looked at the polysomnograms, and it really seemed to smooth out REM sleep, where before we'd seen a lot of also fragmentation of REM sleep. In the depressed patients, we now saw very stable REM periods. And I guess I would really like to do more research into that, but unfortunately, trimipramine is such an old drug that nobody has a patent there anymore and nobody is interested to finance this. But I could imagine this to be very interesting to do more research into that.
Okay, so let's do it. Christopher, just want to come for a comment, please.
Hello, thank you, Laura.
Hello.
I just want to comment that we work a lot with patients with depression and insomnia, and I would like to emphasize that I personally think that for those patients, CBTI or adapted versions are the first-line treatment and not pharmacology. And we are currently working on a program that we call Become Your Own Sleep Expert, which is an adapted version of CBTI that we implemented in the clinic for patients with acute psychiatric disorders. And we demonstrate that this is feasible even in the acute psychiatry setting. And I mean, we use a lot of medication too, but still I would like to emphasize that I think it is very important to not only use medication or hypnotics, but to move the idea forward that we can use CBTI and we need adapted versions for those patients as an treatment add-on.
Yeah, sure. Hey, wonderful. I want to see this. I mean, it's so interesting to apply this way to treat insomnia in acute phases. So I want to learn how to do. Thank you, really, for your contribution. I have just a last question. There is someone else that want to discuss something, and I have just a last question for Lukas. You know that in a recent paper, we are kind of hypothesizing that insomnia could be a kind of marker of disrupted neuroplasticity in mood disorders. So do you think that by targeting insomnia with CBTI or drugs, can we in some ways repair or recover the problems with the brain plasticity in mood disorders?
So in general, yes, I would think that in most patients, at least, plastic changes should be inducible and should be reversible as well, with various therapeutic regimes, with learning, psychotherapy, as well as with medication. If we follow a model of increasing plasticity, for example, then perhaps we need to leave the path of only sedating for improving sleep. Because if we only try to sedate and inhibit the brain, I would be skeptical that it helps a lot for inducing new plasticity pathways. So if you follow that model, maybe it would be more feasible to use activating antidepressants during the day, for example, or some regime like that. If we, but it would be a kind of a change of treatment regime regarding pharmacotherapy. Then.
Really, thank you so much for your contribution. I mean, it's really important. From here, we have to work a lot, right? We have to start in international collaboration about what we need to have clear indication, maybe in depression. So thank you again for participating to the Pisa Sleep Award. Looking forward to meet you again in another in-person meeting. Michelangelo, do you have another some question? Okay, so
I think we can move. Yeah.
So let's move on with a really good friend and a terrific researcher. Let's discuss in this today about the association between insomnia and circadian disorders in bipolar disorders. So I want to invite Pierre Alexis Geoffroy. I hope I didn't, Italianize your last name. And he is an associate professor of psychiatry at the Paris University and at the University Hospital of Paris. He is a co-director of the French Sleep National Research Network and a terrific research on sleep and circadian dysregulation in mental disorders at the French Institute of Health and Medical Research. So thank you really, Pierre, for being here, and let's discuss insomnia and circadian disorders in bipolar disorders. Thank you so much.
I'm very pleased to talk about insomnia and circadian rhythm dysregulation in bipolar disorders. At the Pisa Sleep Award Virtual Symposium, I would like first to thank Laura Palagini and the organization of this symposium for inviting me. I'm Pierre Alexis Geoffroy. I'm a psychiatrist and sleep physician at Paris University and Bichat-Beaujon Hospital. I have nothing to disclose related to this presentation. And the first message I would like to address is, as you know, sleep complaints are one of the main criteria defining a depressive and a manic episode in all international classifications. And indeed, one of the reasons is that sleep complaints are core symptoms of the depressive episode, as observed in this work, which evaluated the prevalence of sleep complaints in participants with major depressive disorders between the two waves of the nasarc. And in this study, we observed that during a major depressive episode, 92% of patients had insomnia and or hypersomnia. And only 8% had no sleep complaints at all. So the rule is to have sleep complaints during depression. And the also interesting message of this study was that both sleep complaints may exist in an individual suffering from a depression. Here is the actogram of a patient who wore an actigraphy on the non-dominant rise for 21 days that objectively assess his sleep-wake cycles in ecological conditions at home. We can easily observe a clear change of the cycles when depressive symptoms appear, including a longer sleep duration, even if some of the days could be associated with insomnia. We can also observe a higher variability of sleep-wake cycles between days. So there is no need to enter into numbers. Just a quick look at the actogram can easily make the diagnosis. Whereas there is this validated criteria to diagnose a major depressive episode, it is absolutely clear in clinical practice that there is an infinite number of clinical presentations. And for instance, a patient could meet with sinus rumination or sleep onset insomnia. Another patient could meet with irritability, racing thoughts, fragmented sleep, nightmares, and suicidal ideations. A totally different patients could add weight loss, diminished interest in all, sleepiness, or a weight gain, hyperphagia, impaired concentration, loss of energy, fatigue without sleepiness, and a sleep phase delay. Another woman could meet a feeling of worthlessness, guilt, early morning awakenings. And finally, patients could have a seasonal pattern with, as you know, is photoperiod changes that induce manic or depressive episode with chronological disturbances. So all these very heterogeneous presentation could explain our suboptimal treatments and lack of specificity. And so to better capture and organize this tremendous variability in symptoms, there is a clear need to better characterize these alterations. And for that, Jean Malley and colleagues proposed the ACE model, which is a return to essential domains as described by Kraepelin, which are the activity, the cognition, and the emotion. And with John Gottlieb, we propose to add the sleep-wake cycles dimension, which is a cornerstone alteration of mood disorders, clearly missing from this model. And indeed, we think that this is a primary domain. So primary domain could be defined that as a domain occupying an integral, so primary position in the pathophysiology, phenomenology, historical accounts, and evolution of episodes in bipolar disorders. And these alterations are well known and ubiquitous in bipolar disorders and distinct from the other domain. And the subgroups and the vital information that could be captured could be the sleep physiology, including the quantity and quality, the wake performance and quality, including alertness, sleepiness, and fatigue, which are three very different domains. And finally, the biological rhythms, including circadian, seasonal, and menstrual rhythms. Here is a study who examines the sleep disturbance during a 5 years follow-up in bipolar disorder. The iterating point is that, as you know at the bottom of the figure, is that even during remitted phases, patients are still suffering from sleep-wake cycle disturbance. And only 17% had no sleep or rhythm disturbance, which are of very different types. So the rule is that even during remission, patients are still suffering from these disturbances. And this is a very important point because during many decades, we thought that treating the mood episode will help treating the sleep disturbance efficiently. And we know that no, it is incorrect. And numerous studies examine this sleep disturbance during the remitted phases of patients, which can so be considered as trait markers of bipolar disorder. Here is a summary of all these studies, and it has been reported an hypersensitivity to rhythm disturbances in patients, such as seasonal changes, but also shift work, pregnancy, jet lag, sleep deprivation, etc. Actigraphy studies also help to report that during remitted phases, patients had longer total sleep time, poorer sleep efficiency, longer sleep latency, and more wake after sleep onset. Patients also met with higher rhythm variability, which is really a trait marker of bipolar disorder. The polysomnography observes that a shorter rapid eye movement sleep, REM sleep latency is observed with a higher density of REM sleep. The melatonin secretion also has alterations and is proposed as a trait markers. And patients also have higher representations of melatoninergic hypersensitivity to light. Finally, a genetic vulnerability has been observed both for several core clock genes, but also for melatonin receptor and synthesis genes. The sleep-wake cycle disturbance is also an important prodrome of mood episodes. And a systematic review of these prodromal symptoms reported by patients show that more than 80% of these patients are able to identify prodromal symptoms. And among these prodromal symptoms, the most robust ones were the sleep disturbances, and the median prevalence, for instance, were 77% in manic episode. So this is an easily symptoms or prodrome that could be reported by patients. And these sleep disturbances are also predictive markers of conversions to mood episodes. And a very recent systematic review of prospective and retrospective studies reported that sleep disturbances frequently appear at least 1 year before the onset of bipolar disorder. And the prospective studies, which probably are more accurate, reported that these prodromes are present 3 to 6 years before the conversion to bipolar disorders. And the symptoms appear during childhood and adolescence. The decreased need for sleep was predictive of manic episode, insomnia of both manic and depressive episode, and hypersomnia rather more to bipolar depressive episode. So all these findings help to build a new models for the bipolar disorder, which include complex and multi-directional relationships between sleep and circadian rhythms alteration in both the causes and consequences of mood episodes. And mood episodes may be both dependent on molecular clock disruptions with clock genes alterations, or independent of molecular clock disruptions with light signaling alterations with both mechanisms altering circadian rhythm entrainment, including so the inability to adapt to environmental changes such as light, sleep homeostasis alterations, and monoaminergic alterations. These findings pave the way to more personalized chronotherapeutics, which act on these different targets and levels, such as the cognitive behavioral therapy for insomnia, the interpersonal and social rhythm therapy, the wake therapy, the melatonin, the light therapy, or the dark therapy. And the first practice recommendation from the ESBD about the chronotherapeutic treatments of bipolar disorders has been recently published. And you can see in green that some of these chronotherapeutics benefit already from recommendations, for instance, for bright light therapy or sleep deprivation during acute depression, the dark therapy during acute phase, or the EPSRT during acute depression. It is impossible to enter details for all chronotherapeutics, but we can have a closer look to bright light therapy as an example. These figures summarize all the parameters that should be considered to have an efficient light treatment, and the physiological effects depend on these light parameters, in turn acting on all depression subtypes, the seasonal but also the non-seasonal depressions. Of interest, there are many features that can be used to personalize light treatment and at this individual level, such as the chronotype, the seasonal pattern, the unipolar or bipolar disorder, the titration or the increasing duration. Maybe you should slower increase your light treatment in case of bipolar disorder to avoid manic switch, the presence of insomnia, of sleepiness, the duration of symptoms, the maintenance treatment, the combination with other drugs or other chronotherapeutics, etc., etc. And here is an example of a very personalized treatment, and it has been shown that light treatment, depending on the chronotype and starting 7 to 9 hours after the dim light melatonin onset, is twice more effective. So in clinical practice, it is easier to assess this chronotype with an auto questionnaire, such as the morning eveningness questionnaire, rather than, of course, measuring the melatonin concentration in blood, urine, or saliva. And depending on this total score on this scale, there is a suggested timing of start treatment. The feasibility of this timing proposition is better in short or normal sleeper, more difficult in long sleeper. And so in patients suffering from hypersomnia, you could start later and advance gradually. There is still many unknowns to better personalize the light treatment in bipolar disorder. For example, what and which dose, which duration, the irradiance level, what escalation, morning or midday exposure, what is the tolerance. And we so propose a study to evaluate in patients with bipolar disorder and non-seasonal depression what are the characteristics of this light administration to better codify the duration, the escalation, and the exposure at morning or midday. And our criteria are the dependence on the tolerance, defined as hypomanic symptoms, with a design from an intra-subject dose escalation of the efficacy of this therapy, and in 2 groups exposed either during the morning or at midday. As a conclusion, the sleep domain occupies an integral or primary position in the pathophysiology, phenomenology, historical accounts, and evolution of bipolar disorder. The assessment of the sleep domain in this very heterogeneous population may lead to more personalized chronotherapeutic strategies. And as you have seen, there is many clinical features that can be used to personalize the chronotherapeutics at the individual levels. But of course, there is still many unknowns with the promise of a true precision medicine. Thank you for your attention, and I would like also to thank all the great collaborators working with me on this topic. Thank you very much.
Thank you so much to you, Pierre, for your participation and for your great talk. I totally agree with your model, with your idea that sleep could be a pillar, an important domain in mood disorders. So thank you for this model. And I have some questions waiting for the questions from other. I hope they want to discuss this topic. First of all, how do you suggest to personalize the melatonin treatment in unipolar and bipolar depression? I mean, what are the evidence in bipolar depression, at least?
Thank you very much for this question and for your very kind words. Yes, in fact, the scientific literature about melatonin is complicated because most of studies used melatonin as a traditional treatment. For instance, the chronotype is rarely taken into account, and this is really important for future researchers to consider the chronotype. But if we summarize and with numerous colleagues who are here from the Italian societies and from the French sleep societies, we just published international guidelines about the use of melatonin, and what we recommend, thanks to the literature, is that the prolonged release melatonin from 2 to 10 milligrams about 1 hour before bedtime could be efficiently used to treat insomnia symptoms when this is present during a mood episode, a depressive or a manic episode. The sedative effects of melatonin is increasing with the dose, so the melatonin dosage could be increased. As Lukas just reminded before, the melatonin also could help to use less benzodiazepines, so this is interesting. And in clinical practice, some patients have sleep phase delay, very severe sleep phase delays in clinical practice, and so the melatonin could be used to help regarding the circadian rhythms. So in clinical practice, maybe a question could be how to characterize these rhythms. It is difficult to evaluate the melatonin secretion in clinical practice. So there is very easy scales like the morning eveningness questionnaire, Horn and Osberg questionnaire, which is very easy. And there is, as I just presented in my slides, there is a table with recommendations for administrations of light, and the same could be done for the melatonin use.
Wonderful, thank you. Also for mentioning our work, wonderful work all together, Italian French societies. And obviously I have a lot of questions on this topic. One of these is how do you suggest, you know very well that CBTI is the first line treatment of insomnia. So how do you suggest to combine CBTI with the chronotherapeutics in bipolar disorders?
Yeah, thank you very much for this question. And I was absolutely agree with Christoph Nissen and his intervention just before. We are using a lot CBTI in clinical practice, in group or during individual. It is many of our patients are still depressed during this group. It is also absolutely feasible during a group session. And this is very effective and can be combined with other chronotherapeutics, with light, with melatonin, with lithium, which is also for me a chronobiological agent. So these chronotherapeutics are efficiently used together. We need more studies to study these combinations clearly. And the CBTI, I think, yes, the CBTI is also acting on the homeostasis process, but in my experience in bipolar or mood disorder patients more generally, the comportamental aspects of the CBTI is clearly very, very effective. 90% of the patients are treated only with the comportamental aspects of the CBTI and the educational aspect. The cognitive aspect could be useful, of course, in some patients who are still resistant, but it's very effective and very quickly in 3 or 4 visits. Clearly, there is already some effects. So the CBTI, in fact, could be proposed to all patients and combined to all kind of drugs.
Yeah. So we have to study this combination in the clinical practices. It's going to be really interesting. We are doing that, but we have to study the effects of this combination on mood and sleep system, right?
Yeah,
so
and what are the the clinical response predictors of these different chronotherapeutics?
Yeah, focus on them. I think it's going to be a wonderful combination for suicidal risk. So we have to prevent. I mean, Lukas, Christoph, do you have comments? Otherwise, I have another, sorry, but it's a topic that I like so much. And so what's about the combination again with the light therapy, and what is the pathway through which light therapy could affect mood and sleep system? And about chronotherapeutics, do you think that lithium may regulate mood throughout the sleep system? It's a kind of a stupid idea that I have. I don't know if it's stupid or it could be nice.
Yes, this is a very interesting question. Thank you very much, Laura. I think we don't have yet all the responses on these questions. What has been very interesting in last years is that we evidence from a physiological level that there is direct neural tracts from the retina to emotional regulation brain areas, such as the periabenular nucleus, the amygdala, the orexinergic neurons, the VLPO about CPAP. So there is direct connections, and we know that the light effects on mood are not only through the synchronization of the biological rhythms, but there are also these direct clinical effects. So in summary, there are light effects from retina going to the suprachiasmatic nuclei. So this is the suprachiasmatic nuclei dependent pathway, which is acting on the biological rhythms and then acting on mood. But also there is more direct neural tracts to emotional regulation areas. And this is really, really interesting. This is explaining why light therapy at midday is acting as is efficient, and also why in previous studies we made, the correlation between the antidepressant effect and the correction of biological rhythms was poor. The antidepressant effect was observed, but the correlation with the synchronization was poor. So we are understanding, and these are very, very recent works about lithium. In fact, there are many old publications. The first one were in the 1950. So it's a very old research. Yeah. And the action of lithium on biological rhythms has been observed from the Drosophila to humans in more than 10 species. So they are very known. There are different levels, and clearly lithium is a chronobiological agent. Is used a lot in Italia by you and your colleagues in combination with other chronotherapeutics with very beautiful studies. So I think this is really interesting. But the lithium action is poorly known. Lithium acts on everything, so it's very difficult to understand the physiological effects. It's easier for light to understand.
It's easier. Yes, so another point to study. I have a question coming from our group. Francie is saying, thanks for the interesting presentation. Obviously, it was great. What could be the recommendations to use melatonin as a chronobiotic to treat a phase delay in bipolar disorders? Should it be given before the dim light melatonin onset, as in delayed sleep phase disorders, or on the other hand, it is better to use a fast release formulation or a prolonged release formulation?
This is a very, very good question. If clearly treating the sleep phase delay in patients could improve the depressive symptoms. So the recommendation for a sleep phase delay is, as you know, to give a very low dose of melatonin 4 to 6 hours before the dim light melatonin onset, so 4 hours before bedtime. Most of the time in clinical practice, we also are looking for the sedative effects of melatonin, and so melatonin could be used as in its prolonged release form at bedtime, 1 hour before bedtime, and so the effect on biological rhythms clearly is lower or absent, but the soporific helps to fall asleep, and so this is also effective. So my answer will be, if there is insomnia symptoms or an insomnia complaint, maybe start with the prolonged release form. If there is not a complaint of insomnia and you just want to help on this sleep phase delay, you could start with an instant release form before bedtime, 4 hours before bedtime.
Wonderful. Thank you so much for your contribution. If there are not other questions.
And maybe just a quick word to say, because it is often a question, the two can be combined. The melatonin at very low dose for 4 hours before bedtime, and then the prolonged release form then. So just,
that right. Thank you for this important, ending of the discussion. And thank you so much, Pierre, again. Hope to see you really in person sometimes. I don't know, in the future, and here in Pisa, obviously. So thank you again, and please stay with us because we are moving on with Christoph Nissen, and he's going live, and he is from the group of Freiburg, obviously, and he's a psychiatrist, and now he's the managing director of the University Psychiatric Service of Bern University Hospital, obviously. And thank you for your discussion. It's so an important topic. Go on with your presentation. Thank you, Christoph, for being here.
Thank you, Laura, for the invitation, dear colleagues. I'm very pleased to have the opportunity to talk to you. The title of my talk is Auditory Closed-Loop Modulation of Sleep-Slow Waves to Treat Major Depression. I serve as a consultant for Janssen, which is not directly related to the content of this talk. The aim of this talk is to use sleep research as a window to the brain in major depression and to continue this old line of research with new concepts and new methods. In the first part of my talk, I will present some own data on two prominent hypotheses, the synaptic homeostasis hypothesis of sleep-wake regulation and the synaptic plasticity hypothesis of major depression. And in the second part of my talk, I will integrate those into a synaptic plasticity model of therapeutic sleep deprivation in major depression. I will start with the sleep hypothesis put forward by Giugno, Tononi, Chiaracirelli, and colleagues. And this hypothesis posits that during daytime wakefulness, there is an overall strengthening of synapses through synaptic potentiation, which ultimately results in saturation and comes at a price, namely energy costs and spatial costs. And the hypothesis further posits that it is during sleep, during slow wave sleep, and maybe due to slow wave sleep, that there is synaptic downscaling and a restoration of network functioning. And this hypothesis has primarily been derived from animal studies. And the aim of the study that I will present briefly was to translate this idea to humans. And to this end, we used non-invasive indices of plasticity in humans in the absence of direct measures, 20 healthy participants in a repeated measures design after one night of normal sleep and after a night of sleep deprivation. And we demonstrate indirect indices of net synaptic strength after sleep deprivation based on TMS indices of motor evoked potentials and increased EEG theta activities. So together this indicates increased cortical excitability, maybe related to increased overall synaptic strength after sleep deprivation. And maybe more interesting at the same time, the opportunity to induce novel associated plasticity, LTP-like plasticity in the human brain is intact after a night of normal sleep, as indexed by this increase in motor evoked potential amplitude after a paired associative stimulation protocol, whereas the same protocol after sleep deprivation does not result in this increase of the signal, but even to LTD-like plasticity. And this goes along with decreased memory encoding after sleep deprivation, which is yet more unspecific than the TMS signal. We summarized this idea in this model with the old homeostatic process S idea, which maybe relates to overall synaptic strength, as Tononi and colleagues propose, and the restoration after nighttime sleep. And the idea that we visualize here in red is that there is an optimal window for the inducibility of associative synaptic plasticity, with healthy participants in this figure reaching this optimal window during daytime wakefulness. And the idea that is visualized here is that those healthy participants with extended periods of sleep or sleep deprivation shifts out of those window of optimal inducibility, maybe due to saturation, as has been demonstrated, for instance, by Vlad Wiatkowski in an animal model. The synaptic plasticity hypothesis of major depression posits that here in the normal state, there's intact synaptic transmission from the presynaptic to the postsynaptic side, facilitated by numerous neurotrophic factors such as BDNF. And in the depressed state, there appears to be a lack of synaptic transmission and a lack of overall synaptic strength, and various antidepressant treatments, such as pharmacological interventions, but also electroconvulsive therapy, physical activity, and other treatments result in an increase of synaptic transmission, and it is just over time, namely 2 weeks, which corresponds to the clinical response, that there is a restoration of network function. And again, this hypothesis has been primarily derived from animal studies, and we wanted to test this in humans with depression and controls. And consistent with the hypothesis, we found in patients with major depression, 27 patients versus 27 controls, that in patients in the depressed episode, there is a decrease of inducibility of LTP-like plasticity based on the paired associative stimulation TMS protocol, with intact inducibility in healthy controls and partially occluded inducibility of LTP-like plasticity in those patients in the acute episode. We reinvestigated those patients after 3 months, and based on the clinical course, we defined remitters, those who demonstrated clinical remission, and we observed a restitution of the signal here, so as an index of intact LTP inducibility in those who remitted, whereas this was not the case in patients who were still depressed. And just as a control, to demonstrate that this is not just a trait marker, but state dependent, this is data from the depressed episode, and there's a selective restitution of the signal in patients that remitted, which identifies this signal as a state dependent marker and a potential mechanism and treatment target. In the next part, I would like to integrate those findings in a synaptic plasticity model that is visualized here. And in brief, this model posits that compared to healthy controls across daytime wakefulness, there's a lack of plasticity or synaptic strength in patients with major depression. And the idea is that whereas healthy participants shift out of this window, this optimal window of associative plasticity, sleep deprivation in patients with major depression shift those patients into a more optimal window. So we propose that there's an interplay of homeostatic aspects of plasticity and associative plasticity with sleep deprivation, restoring this initial deficits in patients with major depression. This is first data that is in line with the model. It's not, of course, does not provide sufficient evidence to really conclude that this is true, but it's at least in line with the model. And namely, we observed an intact inducibility in patients with major depression who responded to therapeutic sleep deprivation, whereas there was no intact inducibility of LTP-like plasticity in those who did not respond. There's an important control condition lacking, namely an investigation prior to the therapeutic sleep deprivation. So this data does not allow to disentangle whether this is a state-dependent process or just a trait marker of those patients. We are currently trying to construct, if you will, an antidepressant nightcap, and the idea there is that we don't use complete sleep deprivation, which is quite demanding clinically, but that we use new techniques that have been developed by numerous other groups to selectively suppress sleep slow waves and to impact maybe processes of synaptic plasticity. And we currently use out-of-phase stimulation, but also various other protocols that might be more effective. This visualizes the idea that we use constant tones, and we completed a pilot phase in healthy participants with constant tones and demonstrate that this is not very effective in suppressing slow wave sleep. And we are currently using randomized protocols which appear to be the most effective, even more effective than the out-of-phase stimulation protocols. We are currently completing a pilot study in 24 healthy participants, and we observe a reduction of slow wave sleep based on this fully automatized protocol. And the next step will be to translate this to patients with major depression, and I hope that I can show this data very soon. And with this, I would like to thank numerous colleagues. I particularly want to thank Dieter Riemann today as my long-term mentor. I also want to use Lukas Frase as my former colleague in Freiburg, who I just saw before, and numerous others. And I would like to thank you for your attention.
So thank you really, Christoph, for being here and for your terrific presentation. It's so, inspiring. I have a lot of ideas in my mind. Ugo is here for a question.
Hi, Chris. Thank you. Thank you so much for your great presentation. And I have a very quick and technical question. The quick and technical question is, what about the auditory stimulation during REM sleep? Do you have any evidence that it might help? Because there is plenty of room for induction of slow waves there.
Hi, Ugo. I'm very happy to see you. I remember that at the last meeting, your child was born and we went on your boat to the sea.
To sleep deprive ourselves. So if you want, we could do virtual regattas now, but it's not the same thing.
But with regard to your question, we have absolutely no data on auditory stimulation during REM sleep, and to my knowledge, there is very few, if any, data on auditory stimulation that specifically target REM sleep. Most groups center on sleep slow waves and record sleep slow waves with the opportunity in closed loop algorithms to target specific phases of those waves, like down states or up states. Some have used techniques to modulate sleep spindles, but to my knowledge, there's not much on REM sleep. And in a broader sense, I might also mention, of course, that the entire model that I presented does not or exclude REM sleep from this hypothesis, and it does not take into account circadian factors. So it's certainly very reductionistic with that regard, but we wanted to have a model that provides the opportunity to derive testable hypotheses, but I fully acknowledge that we ignore other potentially related aspects such as REM sleep or circadian aspects.
Yeah, I mean, my question was, as we try to be provocative to some extent, it could be a nice way of depriving REM sleep and really boost slow waves. So I totally agree with you that there is little in the literature. Maybe there is something with different kind of stimulation in the animal model, and I'm sure Vlad ran some experiments in this sense. So maybe you can combine in your model, which is, I mean, a very logical model, it makes perfect sense, also a sort of REM auditory deprivation, try to, I mean, boost slow waves also where there is room for boosting slow waves.
Yeah, thank you.
Wonderful. Thank you, Ugo. We have Vlad also. Thank you for good morning.
Hello. Hello, thank you. Thank you, Christoph. So I also remember a few years ago, our previous meeting. Good to see you again. So I have a kind of mechanistic question. So the link between plasticity and depression and the relationship of sleep, so that is hugely interesting, but we know very little about the underlying mechanisms. So here I have kind of two sides of the question. One is whether we should be focusing on synaptic mechanisms or these new ideas about white matter plasticity, for example. Do we know anything about white matter plasticity in this respect? And second part is that, so you related process S with synaptic plasticity, but clearly the relationship is still tentative, and we have many other potentially very promising underlying mechanisms of process S, which are completely unrelated to plasticity. Can you comment maybe and maybe elaborate on mechanisms behind the associations that we are talking about?
That I fully understand your perspective, and a sort of important way to think about research is the idea of translational research, which basically brings the idea forward that you understand mechanisms based on basic science studies and based on, for instance, animal models, and move this step by step forward to clinical applications. And my take is that this is a very important line of research, but my take is that this is also a very, very slow line of research from a clinical perspective. And the way I think about it is the idea of what some people call a reverse translation. That is, that we take some concepts derived from animal studies as I try to mention, that we do something in the clinic. And what we do is, for instance, we try to develop this algorithm to automatically suppress sleep slow waves and test whether this has some treatment effects. And from a clinical perspective, I might comment that I wouldn't care about the mechanisms somehow if it's effective. And we might then go back and try to further understand the mechanisms. But I fully acknowledge that there's a kind of wide gap between the basic science knowledge and what we do clinically. I mean, we try to relate, but there's no like hard evidence to really support those concepts. But still, from a clinical perspective, I would bring this idea forward that we do something in the clinic and try and then go back and forth.
Wonderful, thank you. I think Dieter wanted to say something, right?
Hold on a second. Yeah, I wanted to comment on the issue of auditory stimulation during REM sleep. We just have a paper out. It's in press and it can be viewed in sleep. And the idea was not to suppress or to stimulate slow wave sleep or REM sleep, but it was a ERP, event-related potential studies. Thus, we played stimuli during the whole night to insomniacs and to good sleepers, and more than 10,000 stimuli. And these were not very massive stimuli. We didn't want to disturb sleep very much. But the major difference we found was in REM sleep, in phasic REM sleep, with respect to the P2 wave. The P2 wave was reduced in insomnia compared to good sleepers. In phasic REM sleep, which we interpret as a change in information processing in the insomnia, and further pointing to a role of REM sleep for insomnia and for sleep state misperception in insomnia.
Wonderful. Ugo, do you want to comment? I have seen your rising hand.
No, the hand was raised before, but thank you so much. I think this is a very interesting room for investigation, also because it has been unexplored, and as always, Dieter Riemann inspiring. Also, so thank you.
Yeah, he's always opening new spaces and new routes. Yeah, wonderful. Thank you. Do we have our other comments, or? I think it's okay. We can move on with Michelangelo.
Yes, if we have no further comments, we can move on to the next speaker, which is Filippo Sean Giorgi from University of Pisa, professor of anatomy and neurologist, and we'll speak about locus coeruleus and sleep. So we can start with the talk of Filippo. Please start with. It's a pleasure to me to introduce Filippo, which is from our university and now is starting.
Good morning, I'm Filippo Giorgi from Pisa, and in this presentation I'm going to talk to you about the potential role of locus coeruleus and cognition through sleep. Now, as you well know, locus coeruleus is the main noradrenergic nucleus of the brain. It is placed right below the floor of the fourth ventricle, the level of the pons, and a specific feature of its neurons is that each one of them actually project extensively to the whole cortical mantle and to many subcortical structures. And noradrenaline released by noradrenergic neurons of locus coeruleus actually play a key role in several functions of the brain. And in particular, it has been shown that they promote a state of vigilance and they affect somehow the sleep-wake cycle. They play a key role in memory encoding and retrieval, and they play also a key role in alerting and orienting to novelty, as it has been shown repeatedly by Aston Jones among adults in the last decades. Now, apart from its functional physiological role, the locus coeruleus actually has been the object of several studies in neurodegeneration, and there are evidences, some of which starting to be generated already more than 30 years ago, which showed clearly that the locus coeruleus is degenerated severely in Alzheimer's disease. However, most of the earlier studies actually were performed in patients with advanced AD stages, and in which the diagnosis of AD had been done by an old classification criteria. And actually the counting of the cells in the brain postmortem were performed without precise serological methods and in a very few number of patients. But a key study was done a few years ago by the group of Sarah Kelly and colleagues who clearly showed in a population of subjects which had been followed up during their life and whose brain were looked at after death, that locus coeruleus was clearly degenerated in patients who developed Alzheimer's disease, and even more interestingly, that it was already clearly degenerated in terms of loss of Th-positive neurons, already in the stage of amnestic mild cognitive impairment. And very interesting was also the observation that they were able to correlate the number of healthy neurons with the scores at different neuropsychological testing that the patients had performed during their life. And there was a strict correlation between the number of locus neurons and the performance in these scores. Now, actually, this evidence by Kelly et al. Was adding to previous evidence by Brack et al., who had extended their initial well-known Brack-Tau staging classification of Alzheimer's disease, which Brack had performed in the early 90s, when Brack himself did an extensive study less than 10 years ago in more than 1,000 brains, by which they could show that actually before stage 1 of classical tau pathology of Alzheimer's disease, in which neurofibrillary tangles accumulate in the entorhinal cortex, actually in stages A, B, C, 1A and 1B, pre-tangle stages, it was possible to find in subjects which are still cognitively intact a dramatic accumulation of pre-tangles phosphotau pathology at the level of the locus coeruleus indeed, years before of the occurrence of the first neurofibrillary tangle at the level of entorhinal cortex. And this pre-tangle pathology actually started from the cell body and emergency cone of the axons at the level of the locus coeruleus and the dendritic neurons, and then it extended up to the terminals which are connected with the entorhinal cortex. So it was shown that actually in Alzheimer's disease, the first nucleus to be affected by tau pathology was indeed the locus coeruleus. Now, that being said, of course, the involvement of locus coeruleus in AD might by itself be sufficient to justify at least some of the functional and symptomatological alteration which you can find in these subjects. But there are several data which have been developed in the last year, which have shown that actually the locus coeruleus degeneration is not just an epiphenomenon, something which concurs to the symptoms occurring in Alzheimer's disease, but it rather might indeed be key also in the pathogenesis of Alzheimer in terms of increased accumulation of tau pathology, A-beta pathology, and neuroinflammation. And this has been shown repeatedly by experimental studies performed in animal models of Alzheimer's disease, in which by lesioning by a specific neurotoxin for locus coeruleus neurons, which is the SP4, the locus coeruleus of these animals, it was shown that actually the burden of amyloid plaques in transgenic mice of Alzheimer's disease was dramatically increased after LC lesion, and that these phenomena were likely to be related mainly to an anti-inflammatory role of the locus coeruleus, which was lost when you administered the SP4. Now, it is very exciting that in the last years, we have been able the scientific community has been able to find a way also to estimate in vivo in patients during their life the integrity of locus coeruleus indirectly by MRI, by T1 specific sequences, which show the accumulation of neuromelanin, which is selectively and specifically accumulated at the level of a locus coeruleus apart from the substantia nigra. So by this approach, actually several studies have been performed by different tools, by different approaches, starting from the early years of this century. And actually, the studies have culminated in a recently created ad hoc consortium in neuron led by vets with the precise scope of defining some rules, some guidelines to describe the locus coeruleus by MRI in patients. Now, a few years ago, we were funded by the Italian Ministry of Health, indeed, to perform an LC MRI study in a population of subjects which are affected by ED or by MCI and by healthy controls, which were followed up for quite a prolonged period. And we developed an ad hoc tool which allows to estimate the LC volume and the LC neuronal density. And we were quite happy to find out that actually the data which had been obtained by Kelly on post-mortem brain were reproduced by MRI LC study in patients, in which we could show that in Alzheimer's disease you have a specific dramatic reduction of the volume of the locus coeruleus, and incidentally this is even greater in early onset Alzheimer's disease with a high specificity and sensibility in terms of diagnostic as assessed by a ROC curve compared to controls. But even more interestingly, we were also able to show that actually in converters MCI at follow-up to Alzheimer's disease, there was a higher loss of locus coeruleus neurons compared to non-converter MCI. Now, that being said, which might be the triggering mechanism by which the locus coeruleus degenerate in Alzheimer's disease? Actually, there are a number of reasons, of intrinsic reasons of locus coeruleus neurons which might explain why this happens. But whatever it is the triggering initial step, as I already said, what it happens is that eventually there is a strong tau-related pathology at the level of the locus coeruleus indeed. And to get to one of the subjects of this meeting and of this presentation, actually some very, very exciting data were provided quite recently by the group by Zhu and Bezi, who showed that in a mouse model of tau pathology, but also in the littermate wild-type animals, if you induce a strong sleep disruption to these mice, you are able to induce a dramatic locus coeruleus loss, which occurs already in wild-type animals, but which is dramatically increased in animals transgenic for a tau pathology. And you can see how visible is, even without serological counting, the dramatic loss of locus coeruleus neurons. And this is accompanied by an increase of neuroinflammatory changes at the level of the locus coeruleus, as shown, for instance, by GFAP increased accumulation. Now, this evidence actually was adding to classical studies by the group of Giulio Tononi and Clara Cirelli, who showed already several years ago a very interesting phenomenon, which is that if you lesion by DSP4 locus coeruleus in rats and you induce sleep deprivation to these animals, actually in animals in which you have previously induced a NORAP depletion by DSP4, you have a complete loss of the slow wave sleep rebound, homeostatic rebound of the following night. And of course, you know much better than me as a somnologist which implication this might be, because you know better than me how important is the rebound in slow wave sleep after sleep deprivation in terms of memory forming and so forth. And actually, it was indirectly shown by the same group years before, who showed that if you lesion locus coeruleus, you prevent selectively the expression during wake of several genes which are key in memory formation and in synaptic plasticity. So to make a very quite long story short, in conclusion, I showed you some evidences by which LC is severely affected by tauopathy and Alzheimer's disease, and already years before the onset of the symptoms in these patients. We know that sleep disruption, now by experimental data, may impair LC integrity by itself by increasing tau pathology burden specifically within the locus coeruleus. And so it might be tempting to speculate that there might be a vicious cycle by which a locus coeruleus lesion might impair sleep-wake, which by itself might concur to the impairment of locus coeruleus, and so on and so forth. Now, LC progressive alteration concurs likely to AD pathogenesis and to cognitive impairment. And the fact that LC might be estimated in vivo in patients through MRI, and together with other parameters, including sleep-wake features, it is possible that in future years, LC-MRI might concur to form a composite biomarker in AD. Now, of course, we couldn't mention some other intriguing aspects, such as, for instance, the potential role of norepi on sleep-associated lymphatic flow, which, as you well know, is clearly involved in Alzheimer's disease pathology and in the link between sleep and Alzheimer's disease. Thanks a lot.
Thanks a lot, Filippo, for your wonderful presentation. You're still going in collaboration with the neurology unit here in Pisa and your work about locus coeruleus and so on. There are some questions from the audience. One from Professor Santamaria, which want to thank you for the presentation and ask about locus coeruleus and arousal, because he well known that it degenerates and we should see more often excessive daytime sleepiness in this patient when we see more or less more insomnia, sleep fragmentation. I would think that the two symptoms, the process goes together, but maybe you can add something about these things, of this point of arousal and sleep fragmentation related to locus coeruleus.
Yes, thank you a lot, Michelangelo. Thank Laura. Thank to Enrica, of course, for inviting me here. Actually, I apologize for, there was a slide missing, which was showing that all these data, of course, the in vivo data have been obtained in the neurology unit when I was still up to a few months ago working there, and with the collaboration of all the colleagues of the memory clinic, as well as with the CNR here in Pisa, who helped to develop the MRI sequences. Now, coming to the question, it's a very interesting question, thanks a lot. Of course, as I briefly mentioned, there are a huge amount of literature concerning the potential role of locus coeruleus in arousal. Actually, that's one of the most often quoted role of locus in concerning the alert, orientation to novelty, and of course to arousal. Now, the big problem in humans, of course, is how to describe this connection. And surprisingly, if you go through the literature concerning the locus coeruleus and also the studies by Foote, by Aston Jones, which have been quoted repeatedly in the literature, in the current literature concerning a strict link between the locus coeruleus and arousal, actually I was surprised to find out that the classical picture in which you see that the discharge of the neurons of the locus coeruleus recorded by an intracerebral electrode increases actually during arousal, and novelty orientation in monkeys actually was based on an abstract showed at the Congress several years ago, because there are not so many actually direct links. So, and a very exciting perspective might be, of course, the one of measuring by functional MRI the activation of locus coeruleus. But So far, unfortunately, there have been a huge debate among neuroradiologists and neurophysiologists involved in locus coeruleus studies, by which it is very difficult to make sure that the bold increase that you see at the level of the pons during arousal increase is indeed related only to locus coeruleus activation, because unfortunately the locus coeruleus is very tiny, and so the number of voxels, as I showed you, involved in the increase in the bold signal is so small that it might be probably associated to the involvement also to other nuclei which are very close to locus coeruleus. So to answer, so far we do not have any clear way to directly connect the proper functioning of locus coeruleus in humans and in patients in particular to an impairment of arousal, but many people are trying to address this issue.
Yes. Thank you for the answer. There is a question from Vlad Wiachowski. So please, Vlad.
Yeah, thank you very much. Maybe just a quick comment on what you just mentioned. I think there is reasonably convincing evidence that optogenetic stimulation of the locus coeruleus in mice does precipitate a
the connection.
So there is some evidence that locus coeruleus contributes to that.
Yeah,
and then a question I have is, have you looked at? Yeah, sorry, go ahead, please.
No, the problem is in monkey. I don't know if you agree that we do not have in more closest species to humans in which it is more appropriate to measure arousal and alerting and orientation to novelty. So far, as far as I know, it has not been demonstrated clearly. But in mice, absolutely, with optogenetics, there are very exciting data. Yes. So please.
Okay, and then I have a different question. What do we know about the relationship between locus coeruleus activity and sleep spindles? I think there is some research about selective activity of locus coeruleus during spindles or at the beginning of spindle events, which somehow contributes to offline information processing. And I don't know if you have any comments.
I'm sorry, I'm not such an expert in sleep field to be able to comment precisely on this. But that's a very good question, of course.
Yeah. Filippo, I have a further question, since you have just introduced the problem, but not maybe a comment is interesting in this field, about the interaction of locus coeruleus and the lymphatic system, in particular about amyloid. You speak about tauopathy more than amyloid, but probably the interaction between locus coeruleus and lymphatic system during sleep and, of course, during wake, but maybe in this field during sleep are interesting, even if there are not many data, I think.
Yes. Well, actually, thank you for allowing me to make a specification. Now, I mentioned tau pathology because, as you know, in the classical literature concerning Alzheimer's pathology, there is this idea that amyloid pathology actually precedes tau pathology, and tau pathology is what eventually lead to the neuronal degeneration that you describe by showing brain atrophy at the late stage of Alzheimer's disease. Now, actually, the literature on the involvement of locus coeruleus indeed was actually one piece of evidence which in the last years actually reverted this point of view, by which, as I say, it might be that an early pre-tangle pathology occurs subcortically, then the degeneration of locus coeruleus, but also, of course, of other structures, of cortical structures, actually induces an amyloid accumulation, which eventually leads to a self-perpetuating cycle by which amyloid accumulation leads to neurofibrillary tangles. Now, that being said, you are absolutely right. There is, as you probably know better than me as somnologist, there is a very exciting field which is emerging concerning the role of the lymphatic system in the washout of that amyloid during sleep, in particular during slow wave sleep, which has been showed by Xi in 2013 in mice. And it has been confirmed also quite recently on a paper on Science by, I think, Fultz, who was able for the first time to show by bold fMRI that the fluctuation actually of the lymphatic flow and so of the removal of toxic species actually increases during night. And it is associated, we were able to show, also to a pulsation, a pulsatility of the blood vessels in the brain. So they were suggesting that there is actually an increase in the flow from the extracellular fluid up toward the vessels, which is accompanied by an enlargement and an increased flow of the vessels. Now, which is the link with the adrenergic system? Actually, it might look counterintuitive because, as you well know, the tone, the functional tone of an intact locus coeruleus during sleep actually decreases. And indeed, in the paper by Xi, they actually tested which might be the role of norepinephrine in the increased lymphatic flow during slow wave, and they gave they talk about a cocktail of noradrenergic antagonists, and they were able to show that actually this was further increasing the lymphatic flow and the washout of beta amyloid. But I, and of course not only me, think that actually it's very different what happens during a functional reduction of activity and inactivation of intact norepinephrine axons during the night, and what happens in the presence of a degeneration of locus coeruleus and a complete lack of noradrenergic terminals. And furthermore, and that's the last minute of my answer, there is a great amount of data which are very interesting, most of which have been collected actually several years ago, which have linked strictly the norepinephrine terminals with functional integrity of the so-called neurovascular unit, which, as you know, is very important not only for the clearance of toxic species, but for the maintenance of wealthy neurons. So this might be another aspect which is quite interesting.
May I make a quick comment from my side as I am a psychiatrist? Just recently, I don't know what do you think about that, Filippo? I mean, about mood disorders, we know that neurodegeneration could be a factor because you know that mood disorders, they are chronic, they can relapse and be so recurrent a lot of time. So we are thinking that neurodegeneration, neuroprogression could be a factor. So we wrote a kind of review about the potential role of insomnia in neurodegeneration, neuroprogression in mood disorders, because insomnia could be linked to the accumulation of neurotoxin protein, to neuroinflammation, to activation of stress system, to the oxidative stress, and so. What do you think? Is a kind of a strange idea, or it could be?
The whole story, of course, concerning an important role of locus coeruleus in depression and anxiety. So sure. And in fact, actually, the first question that the referee made us concerning data which we submitted on was which was the depressive state of these patients, because that might be an indirect manifestation of locus coeruleus alteration. And I don't think so far there are not studies, as far as I know, in which systematically the locus coeruleus integrity in vivo in humans has been correlated with depression, nor in which there have been stereological evaluation post-mortem in these patients. But as you know better than me, there are clear evidences, for instance, for a shrinking and atrophy of limbic structures in depressed patients post-mortem. And there is a huge amount of data which show that locus coeruleus indeed is particularly densely projection to limbic structures, and it exerts a strong neurotrophic effect on these structures. So that might be another small brick providing an indirect evidence for that.
Thank you. Wonderful. Thank you so much.
Another comment, Filippo, but sleep deprivation and sleep alteration per se can alter locus coeruleus. So locus coeruleus is sensible to sleep alteration? It's like a two-way process, in your opinion?
Yes, yeah. I mean, we are speculating a lot.
Yes, of course, we are speculating. But
for instance, it would be interesting to have opinion also from other of the speakers of this section who touched this aspect. I mean, the evidence I showed you was very well published and are very sound data, but they have been obtained in mice. But they have clearly shown, actually and surprisingly, that if you sleep deprive mice, you induce a cell death at the locus coeruleus. So one of the potential hypotheses might be that you trigger a self-perpetuating vicious cycle by which you increase the degeneration, the burden of tau pathology in the locus, then the locus function worse. It impairs sleep. Okay, actually, there is still a quite big debate concerning the precise role of locus coeruleus in sleep cycle, but it might be that it concurs to sleep fragmentation, that it is shown to occur, as you know better than me, in Alzheimer's disease, and so this further increase this vicious cycle. But of course, these are all speculations.
Okay, thank you very much. We have to move on, and then we go to the last speaker of this session, so David Schreier from Department of Neurology at the University of Bern. So we can start with this last speaker.
Hi, my name is David Schreier. I'm a medical doctor from the neurology department at the Inselspital University Hospital in Bern. And I would like to thank the organizers for inviting me to this event, which finally can happen even virtually, and to talk about sleepy brains. First, I would like to start with the question, what is sleepiness? So for me, sleepiness is still quite a good definition is from this book edited by Thorpe and Pierre in 2011, but it's a lot of text which I would like to go through with you in more detail. So sleepiness is the normal biological drive for sleep, and sleep is needed to correct this. Excessive sleepiness is the inability to stay awake. There is a high propensity to fall asleep, and particularly in situations that are inappropriate, interfere with activities of daily living and can be harmful. In addition, the ecological value of sleepiness is to inform the individual that functioning is compromised. So overall, sleepiness is an indicator of sleep need with the purpose to get the brain the sleep it needs, which is related to the question, why do we need sleep? But this is a different topic. And to prevent harm. So functioning is compromised, and not only prevent harm to the brain, but also prevent harm to the body. Let's say you're falling asleep while driving and which might result in an accident. This would also harm your body and not only your brain. So from a biologically speaking, sleepiness is something good. However, the perception in the society, there is often a connotation which is or can be negative. For example, let's say someone is sleepy in school or at the university, it can be, people might think, or the teacher might think that it's a lack of discipline. Someone did not go to bed when they should have. So they are not disciplined with this rhythm. So it's their fault that they're sleepy at the moment and cannot concentrate. There is also, particularly in this matter, for example, there can also be long sleepers, which might go to bed at appropriate times, they think, but they do not sleep enough because they're a long sleep type. There is a sign of drug abuse can be or associated with it, medication overuse. However, there is also the possibility of side effects. So, for example, if you need to take antihistamines in spring, then you might feel more sleepy, and this is a side effect. And but might be associated with someone else seeing you somewhere on the train, might think about medication overuse or something else. Sleepiness can also be a sign of disease, insomnia, central disorders of hypersomnolence, sleep apnea. There are a lot of other sleep-wake disorders, various other diseases, which might result in sleepiness. And there is only rarely it is associated with, let's say, positive emotions. So for example, if you know that someone just became a parent, so you can say, yeah, they're doing their best. The child is waking up during the night, so that's why they're sleepy at the moment, but they're having an exciting time and so on. Or in certain environments, those heroic actions, let's say you put an all-nighter just to finish a project, or to generally you're in a job where they require a lot of dedication and work, long working days. Then they might say, oh, he or she is working so hard because they look sleepy. You can also discuss whether this is a positive emotion or not. I would also like to quickly talk about similar terms. So from my perspective, from a neurological perspective, those are not exactly the same. So sleepiness, I already said, I believe is the biological drive to sleep. Vigilance is more the ability to maintain alertness and focus attention over time. And fatigue is time on task performance decrement. Classical example is if it's coming for when we talk about peripheral fatigue, that you hold this pen, for example, and it is not a problem, but the longer you hold it, at some point it's getting heavy. So this is the time on task performance decrement, because your arm will drop. And you can have the same concept you can apply to mental fatigue or central fatigue. Tiredness, the lack of energy and motivation, which is not really exactly the same as the drive to sleep, the biological drive to sleep, which we would say is sleepiness. And drowsiness as a variant of sleepiness, so a state in between wakefulness and severe sleepiness. I would define it like that. Now, the big question also, how to measure it. And I would like to start out with the two-process model, which I think almost everyone is familiar with. So that's established by Borbet in 1982, and you have process C, the circadian process, which is fluctuating over days, or over the day. You can see here the amount of hours, and then the homeostatic process S. And the difference between those two, which you could define as sleep pressure. So that here you can see, for example, the sleep pressure is higher than here. And that's why you can ask yourself also, well, is sleep pressure the same as sleepiness? Can we measure sleepiness simply by trying to measure sleep pressure? And in this study from Lim and Dinges from 2008, which is a sleep deprivation study over 4 days, and the PVT was performed. And you can see I try to draw in this process C and the process S. And you can see that performance of those sleep deprived, because those here are the controls, you can see that the performance impairments in the PVT, so the milliseconds, the long reaction times, they're mostly relating here to where the sleep pressure is the highest. So the difference between process S and process C is the highest. So you could say, well, maybe this is how we can measure sleepiness. You can see the same also to be applicable in a newer study from this year with the KSS and the PVT. So those here are the minor lapses, not reaction time, but the concept is the same. And you see this increase or performance decrement, and then kind of it drops again. And you can, the same as here, and you can also see this to be true in the sleep deprived in the KSS. So the subjective sleepiness with higher scores here, which are dropping or decreasing afterwards again. However, I would say that sleep pressure is not exactly sleepiness. And one example to illustrate that, it's an older study, but I think it's a good example. It's a study from 1998 from Rayner and Horn. And you can see here that's also, again, the KSS, with here being low scores and awake, and here high scores and very sleepy. And you can see that there was an increase in this condition of sleepiness, and then afterwards at this time point, so start of treatment, there was either some air applied, so some fresh air, or a radio was turned on. So those kind of countermeasures when while driving and maybe or trying to countermeasure sleepiness. And you can see that there is quite an instant response, so quite an instant drop in subjective sleepiness. So therefore, I would say that sleep pressure can be more looked at as an underlying sleepiness or a baseline. But there is an influence of intervention, so fresh air we saw, or there are also other forces like such as intrinsic motivation to stay awake, which can vary quite a lot in certain situations or individuals. And this adds to the complexity of sleepiness. So there can be a rapid fluctuation with high temporal sensitivity to certain extrinsic or intrinsic actions or events. And it might be difficult to measure because there is such a multidimensional interplay between the underlying sleepiness, you could say, and other factors that play into on top. And I try to illustrate how you can try to measure sleepiness. So there is subjective sleepiness, objective sleepiness. There are a lot of different categories, a lot of different tests and approaches. I do really not have time to go into detail to all of them, and I would like to focus more a bit here on the electroencephalography, the EEG, and those related tests. So in the EEG, there are rapid transitions in the wake-sleep or sleep-wake transition zone. And so you can see here, that's the time axis, and that's wakefulness, that's sleep, which as a rule of thumb, you can also say faster frequencies are more in the spectrum of wakefulness and slower frequencies in the spectrum of sleep. And you could see that, for example, this is not really a straight line. This should be more a wave as a fluctuation. But you can see that there is a quick, at this time point here, there can be, for example, someone just stays awake, or there might be a quick change, a quick dip into sleep, which you could call a microsleep episode. The same concept applies also for when you're sleeping. You might sleep through, or at some point there might be an extrinsic, for example, a noise, or something intrinsic, something else, and you might have a quick dip, you can say, into wakefulness, which would be an arousal. So those are rapid transitions. And this is why when we talk about these more rapid changes, which might be more difficult to measure than the underlying sleep pressure or sleepiness, we were focusing also in our recent studies in the past few years on microsleep episodes, particularly in the maintenance of wakefulness test, because I think this is a really good test because you're spending a lot of time in this wake-sleep transition zone. And you can see a microsleep episode here in the EEG on occipital channels, and in the frequency spectrum, you can see this corresponding alpha drop, so a slowing in the frequency as well. And what we did, that's just one part of the study, that in the MWT, we were looking into 42 patients with at least one microsleep episode. And you can see here, that's the x-axis, the time axis in the MWT trial. And those are patients, so each line is a patient, and they're sorted according to the ASM sleep latency, but all those circles are microsleep episodes. So you can see that a lot of microsleep episodes are preceding traditional sleep onset. And we also tried to look into when here at 0 there is the first microsleep episode. And you can see that between the first microsleep episode, around 50% of patients fall asleep or have a traditional sleep onset within those 5 minutes, you could say, interval. And you can see, but that there can be quite a big difference as well. So most of the patients did have sleep onset very soon after the first microsleep episode, so which might be an indicator of sleepiness, you could say, and sleep onset. And we also tried to look into that more about with the relative cumulative duration of microsleep episodes. So that's in this time period, the relative time or the cumulative duration of microsleep episodes in this time period in relation to the duration of the time period. It's a bit complicated. And here we didn't really find this pattern which we might have expected, where you just see a very high proportion of microsleep episode duration, then dropping afterwards when the interval is longer. So to conclude, sleepiness is in general, you could say, is a result of neuro or protective mechanisms. And sleep is essential. I think we all agree on that. Sleepiness is a complex construct which is not easy to define. It is multidimensional, also requiring multidimensional assessment. So the choice of tests are depending on the question. And in the end, it's just very fascinating, I find. And here are the people I would like to thank the most and contributed to also our studies, for the invitation and also for the funders, but also the whole team. Thank you very much.
Thank you for your wonderful presentation. The argument is really complex. Sleepiness is so complex that it's difficult to say something in a few minutes. So thank you. And we have time for a few questions since we are quite late, but I think some questions should be done. I see Ugo Faraguna, who is raising his head.
Yep.
Please, Ugo.
Yeah, very quickly. Thank you so much for your presentation. There are a lot of questions. I have two questions. One is very technical, one is not technical at all. So the technical question is, you base the definition of microsleeps on occipital derivations, of course, for obvious reasons, based on the alpha rhythm. But did you look at the frontal derivations? What did they do during this microsleep? And this is the technical question. The non-technical question is provocative, if you wish. Do you believe that there is only one kind of sleepiness or more than one?
Okay, great question. So to the first question, in our study so far, yes, we looked into occipital channels, but also in the beginning with visual scoring, we also, I tried in the beginning also to identify the channel where the microsleep episode starts. And this is sometimes really difficult because you can have sudden changes and you might have an indicator of onset on one channel, but then disappearing again. So this is very difficult. And also in the frontal channel, sometimes with the eye movements, it can be more tricky as well, because particularly we defined those microsleep episodes also with eyelid closure of at least 80%. So when you have those eyelid changes, it is difficult, but definitely this is something we would want to look into in future. So this is to the first question, and the second question was
about if there is one sleepiness or more than one.
Yeah.
But I think it's not a quick question. It's a long. I would say it's a congress. It's not a question. Okay.
You can answer yes or no.
Okay.
Well, I mean, I can try to give you a quick answer. So I mean, my mentor always used to say, you can imagine sleepiness as being an elephant. Depending on which direction you look at it, it is completely different, you know. And I think you have, because of the complexity also, that's why I said, depending on the question, you have to choose the test. So depending on which aspect of sleepiness you want to investigate, you need to choose the corresponding test. But it is very, there is, you can define sleepiness in many ways.
I strongly agree. I have a further question about other things. I mean, you can use also polygraphy to define sleepiness. So I've tried to correlate microsleep with other biological markers. I mean, are we sure that the EEG is the real gold standard for microsleep? And moreover, are there consequences in daytime function of the microsleep? What do you think? What do we believe about that?
So first of all, yeah, we do. I mean, in sleep at the moment, we also define it mainly by the EEG, but particularly microsleep episodes. I mean, depending on, we have to be aware we have surface electrodes, so we do not have deep brain electrodes. So you might not pick everything up, which you see there in the scalp EEG, and depending on where the microsleep episode is, because that goes into the concept of local sleep, you might not pick it up, but maybe it is related to performance impairments. So that means I think there are different definitions or how you can assess microsleep episodes. So by the EEG, by performance also, and also sometimes related to subjective perceptions. And the consequences is, I mean, we have a lot of, already heard a lot of discussions about biomarkers. So the quantification of sleepiness is due to also the complexity of sleepiness is something extremely difficult. And I do see a potential there that we can use microsleep episodes, ideally a combined definition and approach with combined tests, to try to see whether those could be biomarkers of sleepiness. And that would have a great potential, in my view, for, first of all, diagnosis. So because maybe there are different patterns depending on the origin of sleepiness, but also for monitoring treatment. Because so far we use, for example, in narcoleptics, sometimes there is the MSLT and the NWT being used. But this is a very rough measure overall, I would say. So I do think, yes, there's a lot of potential.
Another, I may say, more technical question. Do you think that it would be useful to use a 24-hour EEG recording to see, at least during wake time, of course, microsleep in real life? It could be useful to use that kind of measure, or it would be too many technical problems because it's difficult to recognize microsleep maybe in a 24-hour EEG ambulatory recording? I mean, or do you think it would be interesting to do that?
I think it would be very interesting to do that. From a methodological point of view, there are some challenges still, because what we did, for example, also in some other studies, is that we assessed microsleep episodes in a driving simulator. And there we saw kind of certain changes. So our also automatic detection, which we developed in those studies in the MWT, they didn't work always as well in the driving simulator, because there were also more microsleep episodes with open eyelids. So you can just basically look, I mean, I cannot prove it, but looking at the individuals, you just see that kind of how they start to stare and glance, you just can see basically that you think that they're asleep at this moment, but you cannot prove it, and the EEG is not the same as when the eyelids close. And 24 hours recording EEGs, for example, in epilepsy patients, this is something which is done very frequently, right?
Yes, I was thinking about that.
Yes. So there are also studies which have actually used long-term EEG recordings and looked at microsleep episodes which occurred throughout the day. But I still think that the challenge is also that different situations and conditions, microsleep episodes might not look exactly the same. So this is the main challenge, I think.
Of course. Thanks for your talk and your answer. Laura, I think we have to
I want to
close the session.
David, it was great. Thank you so much. And I want to thank, obviously, all our speakers. They were so great, and everything was inspiring. And so also, I want to say, I'm sorry, we have 10 minutes late. We are 10 minutes late, but
we have a lot of discussion, a lot of questions. So
it was nice. It was really interesting. So for my side, I will say goodbye. I want to see you in person in Pisa again next year, maybe.
Now we have the lunch break, and we see each other at 2:30. With the lecture of Dieter Riemann and all the presentation before the Laudatio and so on. So now we go to have the break, and then we will see you at 2:30 for the Dieter Award
finally. For the winner. We are waiting for him.
And we hope to see you in Pisa next year or again in presence. So see you later.
See you later. We are waiting for Dieter. Bye-bye.
Grazie.
Irene, bye-bye.
Dear colleagues, dear friend, welcome to the 14th edition of the Pisa Sleep Award. We would have loved to host you, the speakers in Pisa, but the current restriction prevailed and forced us to connect remotely. The Pisa Sleep Award was held for the first time in 1994 as a joint initiative of Professor Piero Prasarzarulo and Professor Luigi Murri during the SRS Congress in Florence. It takes place every 2 years and is sponsored by the Department of Clinical and Experimental Medicine of the University of Pisa. The purpose of the Sleep Award is to acknowledge a scientist whose career has been devoted to the study of sleep physiology and disorders, and whose contribution has represented an outstanding advance in sleep medicine and research. This event is also a recognition for the role of sleep research in Pisa, from Galileo Galilei's studies on sleep-wake cycle to the pioneering research conducted by Professor Giuseppe Moruzzi starting for the 1950s. The clinical application of this research have found a fertile ground in Pisa by clinical neuropsychiatrists, so that one of the first clinical sleep laboratory was developed. Progressively, higher clinical structures and researchers have also become interested in sleep, and currently in Pisa, numerous institutions are dealing with this subject from multiple perspectives. The transversal approach of sleep medicine has therefore stimulated the interdependence between basic and clinical practice to enhance the ability to transfer new knowledge to patient care and well-being. The scientific committee of the Pisa Sleep Award consists of both institutional figures and scientists actively engaged in sleep research with the national and European scientific society dedicated to improving this field of study. The committee is composed of the president of European Sleep Research Society, Professor Walter McNicholas, the president of the Italian Association of Sleep Medicine, Professor Giuseppe Prazzi, the director of the School of Medicine of Pisa, Professor Riccardo Zucchi, research coordinator of the Italian Association of Sleep Medicine, Professor Lino Nobili, dean of Sleep Medicine Center of the Neurological Clinical of Pisa, Professor Piero Sazzarullo as co-founder of the prize, and Professor Luigi Murri as honorary president. Over the year, the committee has assigned the prize to figures of absolute international scientific importance, with attention to an equitable distribution between basic and clinical research. In the past edition, the recipients were Michael Jouvet, Elio Lugaresi, Alexander Borbeli, David Parks, Torbjörn Axted, Perez Lavie, Giulio Tononi, Irene Tobler, Claudio Bassetti, Mario Giovanni Terzano, Pierluigi Parmigiani, Pierre Maquet, Tarja Porkes-Kanen, and we are pleased to announce that the Pisa Sleep Award Committee has selected Professor Dieter Riemann of the University of Freiburg as the winner of the 14th edition of the award. I will now leave the floor to Professor Giuseppe Plazzi.
Thank you very much, Enrica, and thank you to all the friends of the organizing committee to have invited me. I welcome to all of you, all the participants, on behalf of the Italian Sleep Society, the Associazione Italiana di Medicina del Sonno, and also on behalf of the European Sleep Research Society, since I am part of the board. And I want to thank again Professor Murri and Professor Sazzarullo too, who launched several years ago this prize that is the most important Italian prize on the field of sleep medicine and sleep research, but I think also one of the most important in Europe and in the world. And before leaving the floor, the virtual floor, to my friend Lino Nobili, I want also to congratulate personally with Professor Riemann for this very prestigious achievement. Thank you very much to all of you. Thank you, Lino. Switch on the...
Okay, do you hear me now? Okay, thank you, Giuseppe. I have pre-recorded my laudatio, but I'm here live, so I think it's better to say directly. And dear colleagues, conference chairs, members of the organizing honorary and scientific committee, speakers, and everyone attending this 14th edition of the Pisa Sleep Award, it's really a great honor and pleasure for me to introduce the magistral lecture and to deliver the laudatio for Professor Dieter Riemann, who has been selected as the winner of the Pisa Sleep Award this year. Professor Riemann is a clinical psychologist and certified behavioral therapist. He's professor of clinical psychophysiology, and since 2013 is head of the Department of Clinical Psychology and Psychophysiology of the Center for Mental Disorder at the Medical Faculty of the University of Freiburg in Germany. He's also head of the sleep lab of the department. Since 2015, Professor Riemann is a visiting professor at the Nuffield Department of Clinical Neuroscience of the Oxford University. And from 2006 to 2008, he has been also adjunct professor of psychiatry at the University of Rochester and Medical School in New York. From 2007 to 2013, he has been a member of the American Psychiatric Association's working group on sleep disorder for DSM-5. And now Professor Riemann is editor-in-chief of the Journal of Sleep Research. He has been the treasurer of the European Sleep Research Society, and during that period, I was also in the European Sleep Research Board, and I had the opportunity to appreciate his considerable organizational and not only scientific skills, as well as human qualities. Indeed, there was always room for humor, empathetic understanding of others, and time to have fun. Indeed, Dieter is also an intellectual, high cultural, a great reader of books, but also a good cook and lover of swimming and music. Going back to the past, in 2009, Professor Riemann founded the European Insomnia Network within the European Sleep Research Society. The work of this network, which he coordinated, led to the production of the European guidelines on the treatment of insomnia, which comes to the conclusion that CBTI should be the first-line treatment for insomnia. As a consequence of this recommendation, the European Academy for Cognitive Behavioral Treatment of Insomnia was created, and Professor Riemann played a crucial role on this process. Professor Riemann is a truly outstanding scientist, recognized worldwide for his many pioneering research contribution to sleep research, especially in the field of insomnia and the relationship of insomnia with psychopathology. But the important thing to note is that although Professor Riemann has been a pioneer of research in these fields, he is still very active today, and his studies and scientific hypotheses are always forward-looking. Professor Riemann's main research goal throughout his life has been the understanding of the mechanisms at the basis of insomnia, including psychology, neurobiology, etc., the effects of insomnia on body and mental health, the effects of psychoactive drugs on sleep, and in particular the relationship between insomnia and psychiatric disorders such as depression. Moreover, also aspects related to the diagnostic, epidemiology, therapeutics of insomnia are part of his research activity. Professor Riemann started working on this topic as a student at the Max Planck Institute for Psychiatry in Munich in the late 80s, before moving to the University of Freiburg. We cannot count the number of times Professor Riemann has been the subject of awards of invitation for keynote lectures, including the one at the World Sleep Congress in Canada very recently. Professor Riemann published more than 350 peer-reviewed manuscripts. His studies and theoretical models represent a critical benchmark for the research in the field of relationship between insomnia and psychopathology. But Professor Riemann is also a great teacher, I believe, who has managed to create a school, a strand of research that extends far beyond the students of his university. This is also related to his tremendous enthusiasm for research, and I'm fully confident that he will continue with major scientific achievements in the next year. I will not go into detail about the scientific aspects of Dieter has produced over the years, as his next magistral lecture will reveal a significant part of it. So now it's time to listen to you, Dieter, and again, congratulations for all what you have done in the field of sleep research and sleep medicine. And we will expect still a lot from you. Thank you very much, and I think we need to give an applause.
Lino.
Bravo.
Thank you very much. I'm deeply moved, and I feel really deeply indebted to the award committee for choosing me. I would never have thought that I would once get this award, and I'm totally happy, I can say. I'm really deeply moved. Thank you so much.
We are also happy, Dieter.
Yeah, thank you to you for everything you did.
Yeah, first of all, let me thank you for taking part in this event and also for selecting me for the Pisa Sleep Award. It's really a very great honor, and it's a pleasure to be here and to give this Pisa Sleep Award lecture. I've looked at the list of predecessors I had, and I have to say this is a really very reputable group of scientists and sleep medicine specialists. So again, I feel very honored having been awarded the Pisa Sleep Award. So today, in the next 45-50 minutes, I'm going to talk about the link among sleep, insomnia, and depression, trying to give you an overview of this topic, because this is what has dominated my research life the last 35 years. So I do report no conflict of interest with respect to this lecture, and I have two learning objectives here. The first thing is I would like to convey the message why sleep is important for mental health. And the second objective is why insomnia treatment could be a so this is the agenda I have for my talk. There are 5 topics here, and I'll start with a brief history of psychiatric sleep research, which will be followed by a few slides about REM sleep, the function of sleep in general. I talk about insomnia and hyperarousal, one of my major research interests. You'll hear a little bit about a meta-analysis we performed about mental disorders, And I would end my talk by highlighting the clinical relevance of all of these issues. So this is a little bit about the brief history of psychiatric sleep. This sinister-looking gentleman is Emil Kraepelin, Professor Kraepelin, one of the founder fathers of modern psychiatry, especially biological psychiatry. And he already talked about the relationship of sleep problems, insomnia, to depression. So he said here, people with depression have problems to fall asleep. It takes them a long time, or they wake up frequently. Let's jump in time for 60 years. This is taken from well, it's not a new study. It's from 1969, a study in, I think, around 1,500 inpatients in a mental hospital in the US. And they were just asking people who were diagnosed with depression, who were in the hospital, what kind of symptoms do you have? Not surprisingly, you see here that people who are depressed have depressed mood, 100%, but also to the same amount, 100% complain. Insomnia, this is far more than other symptoms like suicidal ideation or dual mood variation. So it is known for a very long time that somehow mental health, mental illness, and especially depression and insomnia are coupled. Okay, but this didn't play a huge role in clinical practice, well, let's say up to the 70s or 80s of the last century. And in 1953, REM sleep was discovered. We hear a little bit more about that later on. And the first polysomnographic studies were performed in patients suffering from depression in the hospital. And you all are probably familiar with the standard polysomnogram, or PSG as we might say, of good sleepers: non-REM sleep, light sleep, deep sleep, REM sleep. And what was striking, and that is especially due to the group of David Kupfer in Pittsburgh, first to study this phenomenon, to study sleep and depression, was, okay, we have a sleep continuity disturbance. People with depression wake up quite early. This is a typical early morning awakening. Sleep in depression is less deep than normal sleep. There's less slow wave sleep. And that was the most surprising finding, there is a dysregulation of REM sleep. REM sleep occurs earlier. So we have a shortened REM latency in depression. And for quite some time, it was thought that this might be a biological marker for the endogenous melancholic subtype compared to the neurotic subtype. This was not confirmed in later studies, but this gave the initial impetus. Another finding already in the 70s described and in the 80s was that what do antidepressant drugs do? They do suppress REM sleep. They correct this imbalance. So if you take a classical antidepressant, a REM sleep doesn't occur so early anymore. Okay, that was the empirical side in the 70s, but there were also very exciting discoveries coming from basic research. And one was the so-called Hobson-McCarley model. Alan Hobson, Bob McCarley, both from Harvard, both neurophysiologists and psychiatrists, did a lot of animal work, especially in cats. They analyzed non-REM and REM sleep. What they found was that there is a reciprocal interaction between aminergic and cholinergic cell groups in the brainstem, regulating or underlying this typical cyclic pattern of non-REM and REM sleep. And so it was not surprising that Bob McCarley hypothesized that the early onset of REM sleep, as shown here, this sleep onset REM, might have something to do with a disturbed balance or with an imbalance between aminergic and excitatory cholinergic neurons in the brainstem. They performed lots of experiments, our group as well, and they were able to show, and we were able to show that, for example, cholinergic stimulation sleep leads to an early onset of REM sleep, also in normal sleepers. Okay, so there was a combination here between empirical findings from clinical practice and basic sleep research, giving a model for what might underlie these changes in depression. And apart from this, there are some other exciting findings about sleep and depression. And this is discovered due to some German psychiatrists in the 60s, Pflug and Tölle, and they were able to show that, interestingly, a night of sleep deprivation might improve mood in depression. In many severely depressed patients, we have this diurnal variation of mood, early morning low, afternoon improvement, and then there comes sleep, and mood is decreased again. If you sleep deprive people with depression, you may see an improvement of mood. Unfortunately, just for one day. And even if you have a brief nap, if you let people with depression nap in the morning, they may show this relapse into depression. So another exciting finding, because this is totally counterintuitive, that sleep deprivation might be clinically useful for people with depression. There's only one thing they long for, and that is sleep. They want to get restful sleep, which they don't achieve. And interestingly, if you ask them not to sleep for one night, mood even improves. And that finding nicely fitted into another very major theory of sleep-wake regulation, so-called two-process model of sleep and sleep deprivation. Obey and Words Justice formulated it already in 1982. You're also familiar with that. Usually our sleep and waking is determined by a circadian process, process C, and by process S, which could also be formulated as a sleep drive. And what they hypothesized here then was that they said maybe the decreased amount of slow wave sleep we see in depression reflects decreased sleep drive. And like here, the curve like here in comparison to the normal curve. And if we enhance sleep drive by sleep deprivation, we correct this imbalance. And maybe this is the cause why sleep deprivation has such a positive effect on mood, because it corrects this deficiency of process S. So this is one view of looking at, and these were very exciting times. These highly interesting clinical findings, polysomnographic findings, sleep deprivation findings, and on the other hand, these two models of sleep and sleep regulation. There was a drawback to all of this already in 1992, when Ruth Benker published her first meta-analysis on sleep, polysomnographic sleep in mental disorders. What she did is she summarized all the literature done in different mental conditions, affective disorders, anxiety disorders, schizophrenia. And she was able to show that there is a kind of transdiagnostic value for sleep continuity disturbance. This would be sleep onset latency problems, nocturnal awakenings. So they are not specific for depression. Slow wave sleep reduction occurs in other mental disorders, but she also showed that though on the one hand, REM sleep disinhibition is most frequent in affective disorders, depression, it also occurs in borderline personality in schizophrenia. So it's not a highly specific marker which you can use for depression. Though this finding took a little bit wind out of the sails of especially sleep research in depression and other mental disorders, but I'll show you that there's a rebound there in the last years. Now, let me make a jump, say a few words about REM sleep, regulation, we heard already about, and the functions of REM sleep and the functions of sleep. Now, this is taken from the science paper Nathaniel Kleitman, the first description of REM sleep. And I try to go into a little bit more details and explain you some of the aspects of REM sleep. Now, this is just taken from our sleep lab, REM sleep, and you all are aware that the rapid eye movements are the phenomenon which are responsible for the name REM sleep. So let's have a closer look at these rapid eye movements. I've shown you a brief film here from a documentary film, Wide Awake by Alan Berliner, where he filmed his little son And just go ahead, just have a look at the eyes, and then you see the eye movements.
When he is sleeping, I am at peace. I filmed Eli sleeping when he was about 2 months old.
See the respiration?
Very shortly after I put him to sleep, his face went into a smile.
More irregular in REM sleep?
Babies actually smile in sleep before they smile in wakefulness. And he's actually in REM sleep while this is happening.
Look at the eyes now.
He's dreaming. Somehow his brain is practicing what just might be the most important survival skill of all.
And you see it comes once again, a smile.
Something that's going to strengthen the bonds of love and attachment with his parents.
And it works.
You see, yeah, you see how it works.
And
So I'll stop it here. So the point is, newborns have 50% of REM sleep of their whole sleep time, and they smile during REM sleep. And you see the rapid eye movements here. What else is so special about REM sleep? We have a low voltage EEG. That corresponds nicely to the fact that the REM sleep state might even be a more active state concerning brain glucose metabolism than the wake state. This is taken from the first PET study, an emission tomography study published by Pierre Alexis, and this is REM sleep in humans, and you can see here the yellow dots. These are the more active than wake state areas. This is the pons, the amygdala, the thalamus, and the cingulate cortex. That is to say that not only the pons are active, but the amygdala, which has a lot to do with emotions, but also the cingulate cortex. And probably this explains why we are dreaming in REM sleep. There has been a very influential theory about REM sleep function, linking REM sleep to emotional brain function. And this is depicted here, this comes from Matthew Walker and his group from, and he hypothesizes that in REM sleep, emotions are somewhat desensitized, which is possible because there's no adrenergic tone or input during REM sleep. The locus coeruleus is silent. This is a very fascinating theory, and it would suggest, considering the situation in depression, for example, that something is wrong with REM sleep in depression, because in depression, usually you wake up more depressed than you go to bed. And one has to say it's a fascinating theory, and one has to say there are lots of findings in favor of it, but there are also findings not further. Third most impressing characteristic, muscle atonia. And we did a research project, art project with a photographer. Several good sleepers during their REM sleep, and the idea was that these would be portraits without any pose. And I think you will agree with me that you rarely see people with such a relaxed expression on their faces. This is not always so relaxed. Interestingly, we may be able to have brief movements during REM sleep, or sometimes even gross movements. This is just from a film I took from YouTube about a little cat, which is probably in REM sleep and has some muscle jerks here. Maybe the little cat dreams of following it, chasing it. She wants to run away, and these are some kind of motive movements. And you see what cat mother, I assume it's cat mother and not cat father, will do, and how to end this maybe nightmare. Okay. But there is a serious condition behind that, and this is REM sleep behavior disorder. Many of you will be aware. Let's just show you a brief film from our lab about somebody who was more or less pulled in by his wife to have his sleep. You don't see the E, but it's REM sleep, I can assure you. And the subject is actually acting out dreams. And this can really lead to even very violent behaviors. And what the interesting thing about this condition is that we now know that is an early indicator. I stop it here now, but you see, can be talking, can be violent movements. It's a very early indicator of neurodegenerative disease like Parkinson's. So that's why neurology is interested so much in that. About the functions of sleep in general, probably saving energy, metabolic. Lots of theories now focus on information processing and memory consolidation, and they give both slow wave sleep and REM sleep a certain. So the idea is that information learned prior to sleep is stored or consolidated. This is, for example, a theory also going back to Jan Born and others. And the idea is that there's a replay of information, for example, during slow wave sleep, from the hippocampus to the cortex, which is reflected in slow waves. Another theory, also influential and I think not contradictory, states that probably sleep is very important for synaptic and cellular homeostasis. This is depicted here, and it would say that sleep serves to decrease the net strength in synaptic strength during sleep. Otherwise, our heads would explode in connections between synapses. Last but not least, probably the newest theory, which says sleep is something like a garbage truck for the brain. Authors here, under the leadership of Nedergott, suggested that the restorative function of sleep may be a consequence of neurotoxic waste products, like beta amyloid. And these accumulate in the central nervous system, and sleep helps to clear out this neurotoxic waste. Interesting theory and interesting findings coming from epidemiology suggests that if you look at insomnia, restless legs, sleep apnea, they all increase the risk of dementia. And that would support the theory that sleep is something like that. Maybe a word about the function of sleep. I think we should not expect that one day we will have just one homogeneous theory. What is the function of sleep? I guess that probably sleep has more than one function, and the functions are probably not mutually exclusive. So finishing this chapter at this point, here is a summary of what my group and what I think relationships between sleep and mental health. And we think that sleep is extremely important for the brain and for mental health, is related to emotional functioning, to cognitive functioning, to is reflected in neurobiological alterations, and also is necessarily entwined with circadian and homeostatic processes. Now let's come to insomnia and hyperarousal. DSM-5 suggested a shift in paradigm with respect to the diagnosis of insomnia. The old dichotomy, primary versus secondary, was given up, and the new category of insomnia disorder, insomnia disorder. We also have this now in the ICSD-3, and as far as I know, this will also be reflected in. So what are the criteria here for insomnia? A sleep problem, difficulty initiating sleep, maintaining sleep, early morning awakening. It has to cause clinically significant distress or impairment on several areas. It has to occur at least 3 nights per week for 3 months. And it's not better explained by another sleep-wake disorder, by another mental disorder, or by another organic somatic disorder. That is to say that these criteria allow a lot of more flexibility with respect to comorbidity. it invites not just to diagnose a so-called or supposed underlying disorder, which was the general psychiatric thinking. If you have depression and insomnia, it's depression. Insomnia is a symptom. But in cases where the insomnia is present beforehand and is dominant, whereas during the depression, you could comorbidly diagnose a depressive episode plus insomnia disorder. Is this frequent? Yes, it is quite frequent. This is from the slide I show you here is from the European Insomnia Guideline, and here we summarize some studies with of good quality, and the epidemiology of insomnia reflecting something like insomnia disorder. And you see there's a big mixture here. France is leading with 19%, 1/5 of the population. Interestingly, Germany here only has 5.7%. I really wonder about this figure because it's always thought to be that Germans have so much anxiety, but it doesn't seem to reflect, at least on the sleep side. So you see, there's a variability over European countries, but I guess that most epidemiologists working in the field would agree with me when I say worldwide, approximately 10% of the adult population are suffering from chronic insomnia disorder. Insomnia disorder is nothing new. As I said before, Kraepelin talked about it. We know that ancient Greeks had to deal with it. And here is just a quote from the 19th century from the British Medical Journal, mentioning also hyperarousal or overarousal. And what the author says here, Dr. Sawyer, that there is toxic insomnia due to alcohol, tea, tobacco. It ceases upon the removal of the cause. There is psychical insomnia from continued excessive mental strain, grief, anxiety, worry. You can treat it with bromides. I wouldn't recommend that because the threshold between a therapeutic dose and the lethal dose is very small. And again, there's one sentence here I would subscribe to. If it's serious, it must be stopped at once. I wouldn't subscribe to the issue here to stop it by hypnotics, and especially preferably with opium. But there was a standard treatment of insomnia in the 19th century and before, and I think opium was rendered illegal somewhere in the 20th century around the First World War. But if you took on that treatment, probably you had two problems. After a few weeks of treatment, you had insomnia and you had opiate addiction. So careful. Now there are some very good and well-known models. Insomnia, how chronic insomnia develops, this is maintained. I'd like to mention here the so-called Spielman model. Art Spielman from New York suggested this, the 3P model. Precipitating. So there are predisposing factors, personality, genetics. Together with Laura Palagini from Pisa, we published a few years ago an overview article, and there's good evidence suggesting the involvement of genetic factors in the cause for developing insomnia as a predisposition. There are precipitating factors. These are stressors, daily life stressors, work-related or whatever. And this brings you over the threshold if you have a predisposition. And this is something which almost everybody encounters once in a lifetime, that you have maybe troubles to fall asleep. Usually this goes away after 2 or 3 days. But what makes people to chronic insomniacs? And that's really the new thing with Art Spielman. He suggested there are perpetuating factors. And he said these are behavioral factors within the individuum. And he suggested that especially long times in bed, napping during the day, alcohol consumption, and so on play an important role here. And he suggested sleep restriction therapy. And just here, there's also already a jump to the clinical side of my talk, but this is the effects of sleep restriction. This is an insomniac sleeper. see quite irregular rhythm, especially on weekends, and the gray areas reflect wake times. So this is sleep onset latency. This is nocturnal awakening during sleep. What happens if you restrict time in bed? These wake times disappear. It's a very effective therapy. It does not prolong total sleep time, but it changes sleep efficiency. And many patients are totally surprised that this counterintuitive suggestions, treatments, shorten time in bed works so well. But I'll come back to that later on. There are other models. Another famous one is by Charles Morin, this circular model, saying, when we consider insomnia, we have arousal on several levels: emotional, cognitive, physiological. We have dysfunctional cognitions. We worry over the sleep loss, we ruminate, we have maladaptive habits, disturbances of mood, irritability, fatigue, performance problems, social discomfort. And these different areas also ask for different behavioral treatments. But I come to that later on. Now, let me give you an impression what it is like to be. This is also, again, from the same documentary we saw before. This is Alan Berliner with Wide Awake, and he describes his own situation. Oh, no, sorry, here.
Can't take it anymore. Go to sleep. Forget it. Think pleasant thoughts. Think pleasant thoughts. Inhale. Exhale. The baby's coming in 2 months. I've never changed a diaper in my life. Do I watch the birth or film the birth? Shooting it would be better for the film. But how can I watch the birth of my child through a lens? Just relax. I'm too tired to relax. I'm gonna be a zombie tomorrow. I feel like a zombie right now. What was I saying? What if he wants to be an economist like Schreier? What if he becomes a doctor? That would be okay.
I think you get the impression here. It's endless ruminations. You can't control your thoughts. You can't stop your thoughts, which is happening during the night.
That reminds
me.
The
next
we have to get the applications early.
Shows you the behavior over the whole night. This is from our sleep lab. These are is a good sleeper and the poor sleeper. Just 8 hours, not 88 hours compressed to 30 seconds. And you see the difference here on the motor level. I think I don't have to explain you who is who's the good sleeper and who is the patient with insomnia. So it's just an increased frequency of gross body movements all across the night. Let's go on. What about sleep, polysomnographic sleep in insomnia? This is an own meta-analysis, first authored by Chiara Baglioni. And what we did is we looked at polysomnographic data from good sleepers and people with primary insomnia without medication. All the variables in red gave us a significant lower sleep onset latency is longer, total sleep time is shorter, number of awakenings is increased, slow wave sleep and REM sleep are decreased, whereas wake times are increased. So this is when you take together a huge number of studies. If we look at the absolute amount of time less in insomnia, we found it was just 25 minutes. And this is something which already was known in the literature, and it does contrast with the subjective experience. In this study, we looked at also at the sleep diaries, and usually you have a 2-hour difference in total sleep time in sleep diaries between good sleepers and poor sleepers. So what does that mean? Are the insomniacs, are they just hypochondriacs imagining this? I don't think so. This is a comparison of a good sleeper, and this is an insomnia patient. And you see here that overall, the macrostructure is rather unperturbed. What is striking and significant is the number of brief awakenings, the number of microarousals, very brief arousals. And what we also find is an increase in fast frequencies. So this would suggest that although on the macro level, sleep of insomniacs looks quite normal. On a micro level, it looks more different from good sleep. We also had a look at different sleep stages, and this is from a study in 100 patients. These are just the arousals in good sleepers and primary insomnia at the time, in non-REM sleep and in REM sleep. And you can see there are differences in REM sleep, but they are even stronger in REM sleep. And that prompted us to suggest an idea saying maybe it's especially an instability of REM sleep which characterizes insomnia. And the idea has also been replicated by others, for example, by Urs van Someren and his group. We thought, okay, when insomniacs have unstable REM sleep, might it be that they don't experience REM sleep as dreaming, but they might experience it differently as ruminating, because what they do prior to sleep is ruminate, and REM sleep might catch up or take up the topic, and if it's unstable REM sleep, you experience it as being awake and ruminating instead of being sleeping. We did a study in good sleepers and in poor sleepers, and here we have the difference here: non-REM, non-REM sleep stage 2, sleep, the awake judgment. And you see, if you're a good sleeper and somebody wakes you out of REM sleep, usually you are quite sure that you have been sleeping. And that is significantly less so the case in insomnia, which we consider as a further step supporting our hypothesis that not only the physiology is altered during all sleep, but especially in REM sleep, and leads to an of the sleep stage more as a rumination than as being dreaming. This nicely fits in the overall theory of hyperarousal, which is depicted here. The hallmarks are definitely the increase of EEG fast frequencies, the increased number of arousals during non-REM sleep, increased metabolic rate, increased heart rate and altered heart rate variability, and the higher output of the HPA axis, the higher output of cortisol, which reflects this hyperarousal. And also on the other CNS level, we took a look at published studies on neuroimaging that was 2015, and we described that in Lancet Neurology. And we think that the findings from the literature, neuroimaging literature in insomnia, indicate that they have something like a corticolimbic overactivity, which interferes with sleep-promoting structures. So some kind of inhomogeneous sleep or hybrid sleep. If you take that on a very simple level, and you will agree with me that probably sleeping and waking the regulation is much more complicated than depicted here. But we have like an activating system, the ARAS, the ascending reticular activating system, and we have a sleep generating system. And something's wrong with the balance here in insomnia. It's not perfectly regulated, and we think that especially the ascending the sleep system, and that this will be depicted here. You've seen that picture before. Put it on a simple level, and this is the so-called Saper flip-flop switch model. He suggested that usually waking and sleeping are distinct states. When we are awake, the wake system is driving us. Sleep-promoting areas are inhibited. The other way around when we are asleep. And we think that there's some imbalance going on during sleep in insomnia, that the sleep-promoting system either is too weak or the wake system is too strong, which gives us some kind of a hybrid sleep. Okay, that about insomnia. Now let's jump back to sleep and mental disorders. We replicated the Benka meta-analysis, again, first author in 2016, I guess. We looked at studies, PSG polysomnographic studies published in mental disorders, about mental disorders, and we looked at sleep continuity, sleep depths, and REM pressure. Interestingly, there still is a good signal here for increased REM pressure in affective disorders, but you can also see that it happens in borderline and schizophrenia. sleep depths, that means a reduction of slow wave sleep, is all present in many mental disorders. And there's almost one overarching change, and that relates to sleep continuity, which is prolonged sleep latency, increased number of awakenings, early morning awakening, which nicely reflects insomnia. And instead of now, as we did years ago, turning that down and saying this is unspecific, it's not interesting, we have a different point of view now, because we think it's especially interesting for mental health and mental illness because it's transdiagnostic. That also nicely fits in with an alternative diagnostic system to DSM. You all know DSM, the Diagnostic and Statistical Mental Manual for Mental Disorders, which is now the dominating force in psychiatric diagnostics for 40 years. But there's an alternative, the Research Domain Oriented Criteria, and they say maybe it's not a good aim to look to confirm diagnostic categories with biological markers, because the diagnostic categories are much too subjective. But let's have a look at units of analysis, at domains. And one domain would be arousal and regulatory mechanisms encompassing arousal, circadian rhythms, and sleep and wakefulness. So let's have a transdiagnostic view here and study mental disorders under this perspective. And you can do that on several levels, genes, moleculars, up to behavior and self-reports. I think that's a very interesting alternative to the classical biological psychiatric approach to use DSM-5 and then look for biological markers. Now, coming to the final part of my talk, summarize a few ideas. What's the clinical relevance of all of this? No psychiatrist or clinical psychologist has a sleep lab in his home or in his practice in order to do sleep studies. So this is something which is reserved for research. But the findings I showed you, do they relate to clinical practice? There is a study which is also quite old now, almost 25 years, from Michael Perlis. In this study, what was done? There were quite a few patients with depression, and they were followed up after discharge from hospital. They were discharged from hospital, they were in full remission, and then they were followed up, I think, for 18 months. And the idea was, can we define or find early markers of relapse? And what turned out to be, as measured by the Beck Depression Inventory, what was a marker of recurrence or an early sign was sleeping problems. So here, people with recurrence and people with no recurrence. And what shows up here as an early signal is sleeping problem, depression inventory. So clinically, it's a very important finding that you need to tell your patients with depression if they are discharged from hospital or from treatment. If insomnia starts again, come back as soon as possible. Maybe we can stop the full-blown depression before. Again, Chiara Baglioni, our master meta-analyst, published this very early, this is 10 years old now, and we did a meta-analysis of insomnia as a predictor of depression. Different viewpoint now. Initially, psychiatry always considered insomnia as a symptom. We say, could it be the other way around? Could insomnia be an early predictor? And this turned out to be confirmed by data. We found that these are all longitudinal studies, we found that if you have insomnia at a given point in time, it decreases your risk for becoming depressed later on by a factor of 2. We did a similar study a few years ago, now with Elisabeth Hertenstein, also published in Sleep Medicine Reviews. We had some stricter criteria here. We not only looked at insomnia, at depression, but also at anxiety, pain, alcohol, psychotic disorders, and so on. And please only look at the first 2 conditions. Again, very clear signals. If you have insomnia at a given point in time, this increases your risk for depression in the next years by a factor of 2.8 and for anxiety disorders by a factor of 3.3. So I'd guess and say clear-cut signals that it can also be the other way around, that insomnia per se is a risk factor for mental disorders in the long run. And this nicely leads to a concept which suggests that is insomnia first door which opens, for example, under stress, and you have a predisposition, you have short-time insomnia. If you try to cope with it the wrong way, with long times in bed, etc., you will develop chronic insomnia, you'll develop a state of REM sleep instability, alterations of emotional functioning or emotional coping, and in the end, this might also fire up or lead you in a way to become depressed or anxious in a clinical fashion. Now, the interesting question here you might ask then, or the important one, is could the treatment of insomnia be a preventive strategy for mental disorders? This still needs to be proven, but there are interesting hints in the literature. This is another meta-analysis from our lab where we looked at cognitive and behavior therapies for insomnia. What are the effects on daytime symptoms? Not just on sleep. The sleep effect is clear, it's very positive. What's the effect in these people who only have very minor, low subthreshold depression, anxiety? What is the effect there? And this effective treatment has a positive effect on symptoms as measured by with depression scales. But nevertheless, these were not people they became depressed. These were mainly insomniacs, but it has an impact. There is one leading study here published a few years ago in Lancet Psychiatry from Australia, and it did investigate subthreshold and insomnia, and half of them got the real treatment per the internet and half of them a sham treatment. What we really saw here is a positive effect of the real treatment shut eye on depressive symptoms, which was stable. So I think this is an issue really being worth to be pursued, because it would give us a very strong preventive tool, a tool to prevent mental disorders and to heal insomnia. I just like also to show you here just a genetic study, which I find very interesting, from the UK sources, and the authors here found from their genetic analysis with Mendelian randomization, which is a very sophisticated statistical analysis, there is probably a positive link between insomnia symptoms, coronary artery disease. In order to put it like this, there is maybe a source of variation in our genes predisposing us for becoming insomnia, maybe developing heart disease. So, I'm almost approaching the end of my talk. A few words about insomnia treatment. There have been several guidelines out now, and I just focus on the European one, where I was involved in very much about insomnia. And they all come to the same conclusion. Insomnia should be treated as a first-line treatment with cognitive behavioral treatment of insomnia. Here just about the diagnostic procedures. I'm not going into details here. Very important, insomnia should not be seen as a mere nuisance or complaint. One should really, in general practice, in psychiatric neurologic practice, one should have a closer look at it and not just discard it as not worth treating. I mentioned this before. Consists of relaxation, sleep hygiene, stimulus control, sleep restriction, cognitive restructuring. Here again, here the different factors we have: relaxation, cognitive techniques to reduce arousal, sleep hygiene, stimulus control, sleep restriction, and cognitive techniques to reduce sleep disturbing cognitions. And in the guideline, and that is paralleled by the US guideline, by the British guideline, we suggest that intervention may have its role if CBTI is not. Concerning availability, huge steps forward have been made with internet-based therapies. I'll mention here Sleepio from my colleague Colin Espy. There's Shatai in the US, there are German programs, and I guess there are also Italian programs out there. And in order to deal with the many, many insomnia subjects we have out there, Colin Espy suggested a stepped care model, meaning that not each patient should really be treated by specialists, but we need some different subthreshold levels, self-administered CBT books by the internet. We need group treatment, maybe delivered by nurses or by graduate psychologists. And in the end, only the most severe chronic people with insomnia would be seen by CBTI experts, mainly in sleep. I'm at the end of my talk now. I'd like to thank all my colleagues who worked with me. I'd like to mention Chiara Baglioni, she's here, Kai Spiegelhalter, Bernd Feige, and all of the others. It's not a simple thing to pursue such a career over 30, 35 years without a good team. And I also like to thank all the funders. There are typically, specifically German funding, the Ministry of Research, the German Research Council, but the EU and others. So that was my last slide, and I'd like to thank you very much for your attention. Thank you very much. And again, thank you very much for honoring me with the Pisa Sleep Award.
Okay. Thank you so much, Professor Riemann, for your really fantastic lecture. And I would like to thank you for your fundamental contribution to research on sleep and its disorders. When I was a young medical student, I mentioned in my dissertation in medicine and surgery all papers of Professor Riemann on cholinergic REM induction in depressive patients in particular, especially those with cholinergic agonists. In that period, together with Laura Palagini and under the supervision of our mentor, Professor Mario Guazzelli, we studied the effects of cholinergic rebound on REM sleep due to abrupt withdrawal of antidepressants with anticholinergic activity in depressive patients. Although the initial hopes of that these REM sleep abnormalities could serve as differential diagnostic markers for depression subtypes have not been met, the research of Professor Riemann remains groundbreaking. I would like to thank Professor Riemann for his research on insomnia. The study of insomnia from different angles as a transdiagnostic phenotype has opened many new perspectives for research on neurophysiological mechanisms as well as psychological correlates, but also for the clinical practice. And I would like to thank Professor Riemann for his precious collaboration and friendship with Pisa, in particular with the psychoside, mainly represented by my dear friend Laura Palagini. Dear Dieter, we are waiting for you in Pisa next year for a big party.
Yeah.
With wine and other stuff. So, and thank you very much, and my warmest congratulations.
Yeah.
Thank you so much. I'm really deeply moved, and I feel totally honored with this award. And actually, I really love this Italian connection I could develop over the last 12, 15. Now, actually, it goes back a long time. It goes back 30 years with Cristiano Violani and Ina Lombardo. Then we had in 2009, Chiara Baglioni came to our lab with the Marie Curie stipend, and she wanted to stay for 2 years. She stayed for 12 years. And she became our meta-analyst, and the meta-analysis as a tool became so important because, I mean, original studies are more important, but the meta-analysis has so much power. And, and the
I agree.
The Baglioni et al. 2011 is my most frequently quoted paper. And no original study alone would get this kind of attention. So I'm very happy that I could work with Chiara. And then 2011, I think we got to know each other, Laura. I think you got in touch. And I was in Pisa 2011, and I think we published a first joint paper, the Sleep Medicine Reviews on REM sleep and depression.
Exactly.
Yeah.
I was so happy about that. That someone the REM sleep idea, and I loved your concept. And since then we've published many papers together, and I think it's a very fruitful collaboration. And again, I feel so honored to be the recipient of this really prestigious award. And I would love nothing more than to be in Pisa next year and have, some wine, having good talks and everything.
Yeah.
And enjoying the Campo Santo and the atmosphere.
Sure, hopefully.
Of your beautiful city.
Yeah, hopefully.
Thank you so much.
Yeah, thank you so much, Dieter. Just very short from some words from me. Thank you so much. I mean, when we met 10 years ago, I think my life have changed, and we did together really a lot of work, and that is, you were inspiring for us and for our lab, and you really changed the life of me, but also of Insomnia, because before it was considered an EP phenomenon or something secondary to mood disorder, for psychiatric disorder. And now it's so important that the Pisa Sleep Award was for your study about insomnia, and that's really a good, achievement for us, for everybody for psychiatrists and for us in the clinical practice. So really thank you, Dieter, for everything you did, as I told before. So thank you so much. And so I was moved and of your presentation, and now I have to tell you that we will be back after the coffee break that we are not able to have to join all together, but we will be back around 4. So thank you again, Dieter, and see you later at 4. Okay?
Thank you.
So, good afternoon. If we are ready, we can start with this next session of the meeting. The title of the session is Sleep, Health and Cognition. And I am Gabriele Siciliano. I'm a neurologist from the University of Pisa. Together with my friend, is co-chair Bianca Maria Guarnieri from Pescara. We will share this session. Unfortunately, Luigi De Gennaro will not be here with us because of some coincidental duties. And now I think we can start. I wish to express my congratulations for this meeting. It's going very, very well. and hope this next session will be equally so interesting and stimulating. We will have 6 contributions, and we will maintain the same chronological scheme that Ugo Faraguna taught for this meeting since several years. And as you well know, 11 minutes for presentation, no more, and 9 minutes for discussion. So it's with my honor to introduce now my friend and colleague, Rosalia Silvestri. Rosalia Silvestri is Associate Professor of Neurology at the University of Messina, and she is responsible for a research study for sleep medicine, and also is the president for the Committee for Gender Issues and Female Sleep Medicine at the Italian Association of Sleep Medicine. The presentation from Rosalia is Insomnia and Depression as a Risk Factor for Cognitive Decline in Women. Please, Rosalia, and thank you.
My task today is to talk about insomnia and depression as a risk factor for cognitive decline in women. As you all know, depression is estimated to affect almost a quarter of women during their lifetime, with a risk double than men. And there is an increased prevalence of insomnia in this population, occurring in 75% of women with major depression. As for insomnia alone, a risk ratio of 1.4 is seen for female versus male, and the trend of female predisposition was consistent and progressive across age. As for the impact of benzodiazepines versus non-benzos hypnotics on the risk of cognitive impairment in men and women, we know that there doesn't seem to be a significant gender-specific risk for benzos use and developing dementia. However, we know that psychotropic drug use has been associated with lower cognitive scores in both genders. As for non-benzodiazepine hypnotics, women seem to have a higher risk of developing Alzheimer's dementia rather than men. If we consider several sleep disturbances and the risk factor conferred by those on the risk of developing dementia in different genders, some authors notice that chronic insomnia increases the risk of incident cognitive decline in older men, but not in older women. Circadian rhythm seem to have an important effect, in particular in women with decreased circadian rhythm and delayed sleep phase. These were more prone more likely to develop dementia. As for sleep-related motor disorders, patients with those seem to have a nearly 4 times higher risk of incidental cause dementia, and also female with RLS in particular seem to have greater risk to develop dementia rather than their male counterpart. There are indeed gender differences in insomnia between male and women, specifically a sleep efficiency reduction, wakefulness after sleep onset increase, and stage 1 increase prevailing with age in women rather than men, despite the fact that women have a protective effect of delayed modifications of slow wave activity occurring in men 5 years earlier than in women. Also, sleep circadian control seem to play a greater role in women compared to men. There is a gender-specific association of poor sleep quality expressed by the Pittsburgh Quality Index and gray matter volume of the hippocampus. As you can see here, in men there is no significant linear relationship, which indeed is present in women. And meta-analysis revealed that male outperform females in hippocampus-dependent tests, both in animal species, in rodents and in humans. Also, women are more likely to experience greater cognitive decline in Alzheimer's disease and depression, and both diseases, we know, are characterized by hippocampal dysfunction. Severity of insomnia does correlate with cognitive impairment. As these authors point out, the degree of learning impairment correlates with insomnia score. And also the score on depression test, Hamilton and BDI, has been elevated in insomnia patients, even in those who did not meet clinical criteria for depression. Insomnia did not differ in the immediate recall. However, the number of repetitions necessary to learn, as you can see here, the items of ASRT was greater in patients compared to controls. Now, this is a very interesting seminal paper correlating and addressing the role of brain-derived neurotropic factor in cognitive functions of people with primary insomnia, and in particularly stressing the evidence that within chronic insomniacs, those with short sleep duration had worse cognitive performance. You can see here the correlation of BDNF with several tests, performance tests, spatial span, brief visuospatial memory test, and identical pair test, and all of those only in the short sleep duration insomnia group were altered. As you can see here, you can see in particularly here on the right, compare with healthy controls, BDNF levels were lower in SSD group, whereas there was the similar result was not found here in the center in people with not objectively assessed short sleep time. And you can see here all these different tests, namely nonverbal working memory, visual learning and memory, all these deficits in these different areas, verbal fluency, information processing speed, emotion management, who were all attained in these subjects, but of note, impaired performance in this one in red, spatial span, fluency, and managing emotions were exclusively altered in patients with short, objectively short sleep time, but not in the normal sleep duration insomnia group. Here you can see this interesting image from an FDG PET comparing premenopausal women to perimenopausal and postmenopausal women. And you can see here that they exhibit the latter in hypospecific hypometabolism as indicated by the arrows in the same brain regions, which are typically attained by variations in Alzheimer's disease. At the same time, these women show correlated reduction in platelet mitochondrial cytochrome oxidase activity, which is known as the limiting step in the ATP production, just to show the prominent role of hormones in determining the risk of developing Alzheimer's disease, especially for women who experience early menopause. But now, is it only total sleep time which makes a difference, or also we may think of other qualitative variables such as sleep efficiency and sleep latency as making a difference? Both of these studies that you see here are conducted only in women population. Here on your left, you see this prospective study on 7,000 community dwelling women, and the authors conclude that habitual sleep duration predicts the future risk for cognitive impairment, including dementia, independent of vascular risk. In this paper, Diem and collaborators found that besides total sleep time, other variables such as lower sleep efficiency, variable in sleep efficiency, variance in sleep efficiency across time, and longer average sleep latency are important determinants on the risk of developing cognitive impairment. Here you see instead the different sleep disorders as distributed in different types of dementias. In particular, you see here chronic insomnia being very prominent in Alzheimer's dementia compared to all the other ones. And you see also how both in AD and also in frontotemporal dementias, unexpectedly, RBD has a prominent prevalence, even more so than in synucleinopathies such as Lewy body disease and PDD, as it should be expected. Finally, this paper, it's interesting because it poses the accent on the presence of functional aberrant connectivity in chronic insomnia, and how these values, which are all significant, have a role in correlation with specific index, such as Pittsburgh Quality Index, as for connectivity altered between the left orbital frontal inferior gyrus and the right supplementary motor areas, but also other areas, as you can see, the insomnia severity index correlating with this altered connectivity between the left amygdala and the left cerebellum, and also the scores from MoCA and the mini mental state examinations correlating with these widespread functional connectivity alterations. I hope I've been able to suscitate some curiosity in you, and I hope this would determine a debate. I'll be happy to discuss with you and possibly answer some of your questions. Thank you so much.
Thank you, Professor Silvestri, also for having been able to limit your presentation in 11 minutes. And the presentation is open to discussion. Please, you can use the Q&A area to put your questions. In the meantime, someone is going to ask some contribution to Rosalia. I would like to ask to make a question to you. And you mentioned that restless leg syndrome can be a factor related to both insomnia and the cognitive decline. In addressing this issue by, as you shown, the possible presence of biomarkers that, like BDNF, can act as a linkage between these two clinical characteristics. What is the level of knowledge about the possible effect of RLS in these conditions?
Hi, thank you for your questions. Can you hear me?
Yeah.
Yes. RLS is important because it may give insomnia, of course, and two types of insomnia: initial insomnia and also intermediate insomnia. And it's also a good model of delayed phase syndrome in a way, because people go to sleep late and they may have also behavioral alteration. This is very true in Alzheimer's, but has been even more true in Parkinson dementia and Lewy bodies disease, as you've seen by the report I showed you. And usually there is a cluster of symptoms that goes together: behavioral alteration, which include also sometimes getting up to smoke, and in Alzheimer it could be confused with alteration of behavior while they go to sleep. So the other important thing is that RLS is very common in women and can be so from the very beginning or after menopause. And so this would be additive to all the factors, the hormonal factors and other factors related to the deposition of amyloid that we were talking about. So several factors can really have to do with RLS. And RLS is exquisitely a gender prevalent disorder, 4 times more prevalent by this age in women with cognitive decline. So I think it's an interesting model to combine together, the different models for cognitive declines in women. Trying to answer your question, I don't think there are any specific data, at least that I'm aware of, about BDNF and RLS. If anybody in the audience know about, I'll be happy to know this.
Thank you.
I don't know if I answered your question the way
Absolutely, very clearly, and thank you, Rosalia. Coming back to the role of the BDNF in as possible biomarker that can be relevant in determining the cognition effects of insomnia in those case histories. Are there data also that show the effects of possible treatments of insomnia in maybe improving or leading this biomarker go back to the normal values?
You mean BDNF?
Yeah.
No, I really don't know about them. I'm very happy that Bianca Maria is here in the audience as a moderator, because she might know more about it. Generally speaking, all the interventions that are done are against the inflammation, generally speaking, that could interfere, as far as I know, with the BDNF and so on. So everything that goes, against cytokines, tempest, and things like that, we've been hearing a lot these days because of COVID about all of this. But I'm not aware of any specific trial about BDNF. You would think of monoclonal antibodies and things like that. But as far as BDNF is concerned, I didn't hear about anything so far. Did you, Bianca Maria? I mean, you're much more in this field than I am.
Peripheral biomarkers is a big challenging problem, actually, in dementia in general. And in particular, RLS is so young in dementia field, because not so many research, also epidemiological research, are interested in this or are exhaustive regarding RLS. Also for the difficulty to detect it in moderate severe cases of dementia, where the previous history is quite important to define, and comorbidities with iron deficiency and so on. This is a young field for dementia, and it should be augmented and more should be more important, and we hope in more attention from dementia world regarding this.
May I say something?
Sure.
Yeah.
There are some studies about the effect of CBTI on neuroinflammation.
Yeah.
Yeah, this we know. Then I look at a study in which CBTI could prevent from the accumulation of beta amyloid. There is just one study.
Yes.
But about BDNF, nothing, you're right.
Not so many. Oh, new studies for the future. I hope so.
To do that.
Yes. Thank you so much about this. And I was, before I was thinking, it escaped me the word, the sundowning syndrome could be very much related to RLS. And this is an important thing. Also, there seem to be a cluster of symptoms of women who have RLS and cognitive decline. And they include, interestingly so, nightmares. These women have nightmares. They usually have comorbid depression. And with the problem that most of the SSRIs and also SNRIs may precipitate an RLS and get it worse. So it is an insomnia and a comorbidity which are very difficult to treat. Yeah. And the other interesting thing is that these women with RLS and cognitive decline, very early on, even when they have MCI, they usually have excessive daytime sleepiness. And this is a marker, in my view, because usually RLS, unlike OSA, for instance, is not accompanied by EDS. It's not a formal feature of RLS. But RLS in third age with cognitive decline usually has excessive daytime sleepiness as well. So this is an interesting feature, many feature, collaborating to this kind of comorbidity.
Yeah.
Thank you. Maybe next year we will have a session dedicated to this topic, hopefully.
Sure.
Okay, thank you, Rosalia.
Thank you, Rosalia. Many thanks.
And
me.
Yeah,
that's me.
Please, Bianca Maria.
Okay.
So your turn.
With great pleasure, we introduce Professor Luigi Ferini-Strambi from Milan. What about him? Oh, he has held numerous important positions in several national and international sleep societies. So everybody knows him. Well, you'll talk about sleep apnea and cognition, beneficial effects of CPAP treatment. Thank you, Luigi.
Good morning. The title of my presentation is Sleep Apnea and Cognition, Beneficial Effects of CPAP Treatment. I would like just to start with this paper that has been published in 1985, and you can see the authors found that a cognitive impairment was found in 76% of patients with sleep apnea. There are several papers on this topic, but I think that an important point is that not every sleep apnea patient is affected to the same degree and this type of cognitive dysfunction. And we have to consider that sleep apnea patients with high levels of subjective sleepiness are more likely to report cognitive complaints. And also, cognitive complaints are not necessarily a sign of objective cognitive impairments in sleep apnea patients. In this systematic review, you can see that when we consider prospective studies, there is an association between sleep disorder breathing and risk of cognitive impairment. You can see the odds ratio is 1.26. And also in this review, you found that there is an association of sleep apnea with worse executive function, but not with cognitive or memory impairment. Another important point that we have to consider is that age seems to determine the cognitive consequences of sleep apnea. In particular, in young and middle-aged patients, sleep apnea is associated with cognitive impairment, while in older adults, the association is less evident. Another important aspect is the presence of sleepiness, because we know that cognitive complaints is greater in patients with sleepiness compared to the sleep apnea patient without sleepiness. And we are also to consider other aspects. Education and cognitive reserve may have a protective effect against neurocognitive deficit. Comorbidities associated with sleep apnea, such as depression, obesity, and hypertension, tend to increase the cognitive impairment. And also sleep apnea patients carrying the APO epsilon 4 show a more significantly cognitive deficit compared to the non-APO epsilon 4 carriers. What about the potential contributors of cognitive impairment? What is much more important, hypoxemia or sleep fragmentation? I would like just to show you this paper, this very recent paper that clearly show that lower mean oxygen saturation during sleep was associated with atrophy of cortical and subcortical brain areas with high sensitivity to oxygen supply. And in particular, the authors found that for each 1% decrease in the mean oxygen saturation, there was an expected volume loss of minus 0.63% in specific brain structures such as hippocampus, thalamus, putamen, and angular gyrus. The other respiratory variables, such as lowest oxygen saturation or the percentage of sleep time with oxygen saturation below 90, did not show any significant association with the brain volumes. What about CPAP treatment? What about the effect of CPAP? And I would like to show you this paper that we published 18 years ago, and we clearly showed that there was a partial reversibility after this treatment in sleep apnea patient. You can see the effects on supraspinal learning test, the trial making, semantic fluency, and not in other cognitive tests. In this paper, Apple's study, you can see a very, very large number of patients that have been considered. You can see 1,000 patients, 50% in under CPAP and 50% with sham CPAP. And it's very interesting that in this paper, there was an association between a positive effect, but just in a very severe sleep apnea patient. And also when the authors considered the learning and memory test, the working memory test, and the executive and frontal lobe function test, they found very, very, variable effects, but also the positive effect was just evaluated and just found in a very severe patient compared to the mild and moderate sleep apnea patients. This aspect has been clearly underlined. It's a very recent meta-analysis, and you can see when you consider the all sleep apnea patient, including the very severe patient and mild to moderate patient, you can see there was a positive effect on attention and speed of information processing. But the effect was clearly much more evident when the authors divide severe sleep apnea patient from the mild to moderate sleep apnea patient. You can see that the effect was greater in severe sleep apnea patient. However, when we consider the CPAP effect, I think we have to consider that the length of treatment, the duration of sleep apnea disease, and also the degree of adherence to CPAP therapy are very important. It may represent some limitation in the evaluation of the effects of CPAP in cognition in sleep apnea patients. Just to show you, I would like just to show you this very recent review. And if you consider, for instance, patient with the CPAP duration of 12 months, the effects was much, much, much larger, compared to the patient that was considered just after 2 weeks of treatment. Another important point is the problem of the optimal use of the CPAP, because you can see that normalization of memory abilities may be found, in 20% of poor users. This means that patients that use CPAP less than 2 hours per night, and in 68% of optimal users. This means patients that may use a CPAP for more than 6 hours per night. Another important point is the neuroimaging studies, because neuroimaging studies in the last years helped us to understand the profile of cognitive dysfunction in a sleep apnea patient, and also the possible changes after treatment. I would like just to remember this paper that we published in 2001, and you can see in this paper, we clearly show that there was a gray matter reduction in the pre-treatment condition in sleep apnea patient in different areas. And also you can see what happens, after 3 months of treatment. We found a gray matter increase after 3 months of treatment with CPAP. And I would like just to remember that this is very important because with neuroimaging study, you can compare the effects of the different results in different neurocognitive profile, and we can compare this test, with also specific areas, and we have to remember that executive function is important for the frontal lobe, memory for the hippocampus, and abstract reasoning for the parietal lobe function. This is another important recent study that clearly showed that there was a difference in regional cerebral blood flow in a patient that was treated by 18 months with CPAP. And you can see that the untreated sleep apnea participants showed a decrease relative, you can see in these slides in the middle, a decreased relative cerebral blood flow in the left hippocampus, in the right parahippocampal gyrus. And if you consider what happens in the treated sleep apnea patient, you can see that in this treated patient, you may see that there was a trend for increased relative cerebral blood flow in the same areas. Anyway, we know that there are not just CPAP. You have several treatments for our sleep apnea patient, but unfortunately, we have no data about the effects of all of this treatment, on cognition in sleep apnea patient. So in conclusion, we can say that sleep apnea pathology may affect multiple cognitive domains. Young and middle-aged sleep apnea patients, as well as patients with higher levels of excessive daytime sleepiness, are more likely to report cognitive dysfunctions. And hypoxemia seems to be more important than sleep fragmentation in causing cognitive dysfunction. Cognitive dysfunction in sleep apnea patient may be reversible, and severe patient may have a greater positive effects with CPAP therapy. Duration of sleep apnea, length of CPAP treatment, and degree of adherence to CPAP therapy are crucial for the reversibility of cognitive dysfunction. And finally, unfortunately, the effects of other treatments for sleep apnea on cognitive dysfunction should be explored, and actually right now we have no data. Thank you for your attention.
Okay. Well, thank you. Thank you, Luigi. Very nice presentation, Luigi. Any question from the audience? It's just a question from me. You showed us how complicated it is to aggregate this data. But what about different effects of CPAP therapy in men and women? Do you think that available data are informant about this topic?
Yeah, this is a very big question, because I think that the problem with in terms of gender is just a little complicated, because the problem is that usually, if you think that in sleep apnea patient in female, usually the degree of severity is less than the degree of severity that we can observe in men. So this means that probably the effects is lower in women because the starting point is different, and it's just related to the severity. I showed in my presentation that probably the greater effect that we can observe in terms of CPAP effect on cognition is much more important in severe patients. And so at the end, we can say that probably in women, the effect is lower.
Yeah.
Because the baseline condition is different.
Yeah, and probably Remosa has been less studied and more frequent in women, probably.
Yes, and also we have also another problem. I did not mention in my presentation because in 11 minutes, it's very difficult to present a lot of data. But anyway, I think that is a crucial point also is the effects of CPAP on EEG parameters. Okay. Because this is another important point, because we know that, for instance, CPAP may decrease the CAP rate also in the sleep apnea patient. We know that also when we think about the spindles, spindles activity, we know that CPAP may increase the sleep density, spindle density. So I think that we have to consider other aspects. And again, we have to consider that the baseline condition is different in relation to the gender. And so again, this is another important aspect. I think that we have to divide also our patient in terms of gender, because the effects probably is completely different. This is my impression.
Yes, thank you very much. Other questions?
Can I say something? I had tried to raise my hand.
Yeah.
I think an important issue is also that women have much more COMISA, insomnia associated with OSA. And this lowers the adherence to CPAP and also depression does. And women have more depression, even women with OSA. So this is an important part relating to cognitive dysfunction and the effect of CPAP on women. So
Yes.
this will be explored further, and the specificities, as Luigi is saying about EEG specific traits and so on. Women's sleep is different in old age.
Yes, absolutely.
And there are protective factors, but there are other things, circadian factors, which are different, many things. And this also impinge on the adherence to CPAP and the effect on CPAP. The other thing that we know about the literature is that usually CPAP is more effective and much more tolerated in people with EDS, excessive daytime sleepiness, which are people, as you say, with severe CPAP. This is usually not the case of women. They usually don't have, compared to men, a lot of excessive daytime sleepiness. And that is another reason why the CPAP doesn't work as much.
Yes, of course. I fully agree with you. The problem, again, the key word is the severity of sleep apnea.
Absolutely.
Because the key word is severity, because in a female subject, we can observe less severity in terms of degree. And another point is that, again, when we consider insomnia, I think that the problem is not especially related to insomnia, but especially related to the problem of depression. This is another important point, because as you mentioned before, the problem of the depressive symptoms are much more frequent in women. And so this is a very crucial point. And also, if you consider not just the problem of cognition, but especially the problem of excessive daytime sleepiness, we know that, again, depression may explain a great part of the excessive daytime sleepiness in our patients. So again, severity and depression are the two major words that we have to consider.
And a little maybe probably also at this moment a little delay in women in the diagnosis, maybe because women report different symptomatology, and that they can which can delay the diagnosis in women, so they suffer more the disease without treatment. And probably this is quite important also, so a risk factor for dementia, the timing of a risk factor. Nice, very nice discussion. Thank you very much, Luigi. Thank you.
Thank you too.
Well, according with Professor Siciliano, moving forward on ventilation for sleep apnea, we invite Dr. Claudio Liguori from the University of Tor Vergata in Rome. He is a young, big expert of orexin and the CSF biomarkers of AD and sleep disturbances, and more things. Okay, he'll talk about CPAP and dementia. Please, Claudio.
Good afternoon to everyone. I would thank the organization for inviting me to present you about CPAP and dementia. Considering the previous presentation by Professor Ferini-Strambi, I would exclusively underline the importance of considering the treatment of obstructive sleep apnea to avoid cognitive decline and dementia, considering all the detrimental effects by OSA on cognitive performances and cognitive abilities. We have recently reviewed and confirmed the detrimental role of sleep apnea on different biomarkers for dementia, neurodegeneration, and Alzheimer's disease, considering CSF, PET, brain MRI, and cognitive performances in those patients. One of the main questions about dementia patients is about the really need of CPAP machine to treat their sleep disorder. So I tried to resume data about the beneficial or not beneficial effects of CPAP on dementia trajectory and on MCI advances to dementia. So 1 minute, I will explain you the differences about yes and no responses of the literature. One of the main publication about the possible role of the treatment of sleep apnea syndrome to delay cognitive decline, to decrease cognitive decline in patients with Alzheimer's disease is this one by Trussier et al. Documented that MMSA in patients with dementia and treated by CPAP after 3 years of follow-up is less reduced compared to patients affected by sleep apnea and Alzheimer's disease, but not treated by CPAP. This first retrospective study documented the importance and the possibility to treat sleep apnea to delay the cognitive deterioration, the cognitive progression, and Alzheimer's disease moderate severe stages. Another study, retrospective study, was performed by our group and included patients with mild cognitive impairment and Alzheimer's disease, also documenting biomarkers for AD pathology in these patients. And although only 24 patients were included in this study, we found that patients treating sleep apnea by CPAP presented a lower cognitive, a lower mean change of clinical dementia rating at follow-up compared to patients not adherent to CPAP. So also this study confirmed the importance of treating sleep apnea in patients with Alzheimer's disease to delay cognitive progression, cognitive deterioration. The main finding and the main study regarding obstructive sleep apnea treatment and dementia in older adults is this one very recently published by Dunetz and colleagues who analyzed the Medicare 5% sample including more than 2,700,000 of subjects, considering those diagnosed with sleep apnea. They distributed the population in OSA diagnosis and PAP treated, OSA diagnosis and PAP untreated, and also the adherence to CPAP in those patients. The results of this study are really important since documented that not only treatment with CPAP can reduce dementia risk and mild cognitive impairment progression in patients with sleep apnea, but also the adherence to the treatment is important to delay cognitive deterioration, to delay MCI and dementia progression. Finally, the study by Richards and co-authors analyzed the CPAP adherence in patients with mild cognitive impairment and sleep apnea, documented that CPAP can slow the 1-year cognitive decline in older adults, considering in particular different cognitive performances such as psychomotor cognitive processing, global cognition, attention, daytime sleepiness, and everyday functions. So the importance of treating sleep apnea by CPAP was evident also in patients with mild cognitive impairment. Another study is this one, documented that the improvement in cognitive performances and in particular in declarative memory deficits correspond in the increase of stage 3 or non-REM sleep in patients with sleep apnea. So patients treating sleep apnea by CPAP can reduce and can improve declarative memory consolidation than patients not treating in this randomized controlled trial in these patients not treating sleep apnea. Finally, the last question is about to treat or not to treat patients with mild cognitive impairment, one of the main questions by sleep medicine experts. And also a secondary analysis of the study by Richards and co-author documented that also patients with mild sleep apnea can improve and can restore cognition if they are also affected by mild cognitive impairment. So the importance of treating mild apnea is underlined by this study. So not only moderate severe sleep apnea, but also mild apnea, sleep apnea should be considered as possible treatment in patients with cognitive impairment. On the other hand, a single study performed by Skiba and co-authors documented no beneficial effect of positive airway pressure use in delaying mild cognitive impairment or dementia. But if we consider the results of this study, although not achieving the statistical significance, authors found that patients with mild cognitive impairment and not using CPAP converted to dementia after 47 months. And patients using CPAP but with a weak use of it presented after 52 months the conversion to Alzheimer's disease. But patients compliant and using CPAP treatment converted from mild cognitive impairment to dementia after 77 months. Considering the difference of 30 months between patients not using CPAP and patients using CPAP, also the study, although not documented the statistical significance of the delay of dementia appearance in patients with mild cognitive impairment, documented that there is a huge difference between patients using and not using CPAP and dementia, and the conversion to dementia. Finally, I would also suggest you to consider these studies and these consensus conferences by colleagues treating and diagnosing dementia. Since the 5th Canadian Consensus Conference, recently published in Alzheimer's disease, documented that when cognitive decline is suspected, untreated sleep apnea should be considered, since the treatment by CPAP can possibly reverse cognitive deterioration, cognitive decline, or reduce the progression of dementia processes. On the other hand, considering this study, which that would analyze the prevalence of obstructive sleep apnea in an outpatient memory clinic, including more than 800 patients, authors documented that only 8% of patients with dementia showed sleep apnea PSG determinant. This is a huge difference considering the importance of treating sleep apnea in patients with dementia. So probably we have to learn more and to diagnose more, and possibly to use different instruments to diagnose sleep apnea in patients with dementia, since only 8% is a very low prevalence, and it is not equal to the previous studies by Ancoli, Israel, and her group. I would conclude considering that about the research agenda of our review, we underline the importance and the need for therapeutic studies on the effects of CPAP or cognitive decline in patients with mild cognitive impairment and early stage of Alzheimer's disease, using a larger population, longer follow-up periods, and different biomarkers, not only cognitive, but also the other biomarkers of AD pathology. Most of the studies assessed patients with moderate to severe sleep apnea, and it is also important to consider the earlier stages of the disease. And further study should also assess sex aspects in the relationship among sleep apnea, cognitive decline, and alteration in Alzheimer's disease biomarkers. About practice points, I would also underline that a screening for sleep apnea should be performed in patients with cognitive decline, in particular subjective cognitive decline. HIP and CPAP treatment should be started in MCI comorbid with OSA to reduce the progression of Alzheimer's disease. I can conclude my presentation. I will thank you for your attention, and I am here for your questions.
Bene. Molto bene. Grazie, Claudio. Any questions? Thank you, Claudio.
May I ask something?
Oh,
Bianca.
Good, nice.
Nice to see you, Claudio. I have several questions, really. One is already done by Professor Santamaria in the chat, so I read his question, but it's also my question. Some comments about the compliance of CPAP in mild cognitive impairment and Alzheimer's disease patients, because in the study it seems quite acceptable, but in real life, what is your opinion or your experience?
Thanks for this question, and I'm a little bit anxious because of your several questions. But the first answer, and I can limit on it, it's really different, the compliance in patients with MCI than patients with Alzheimer's disease. And I think that it is more important to treat sleep apnea in patients with MCI, because probably the problem of treating sleep apnea in patients with Alzheimer's disease can be reduced by treating them in the MCI stage. So we have to learn more about CPAP treatment in those patients, but I think that we should focus on MCI. Difference is about sleep apnea and moderate, severe, mild Alzheimer's disease, since the treating of by CPAP can also improve quality of life of patients, or caregivers can improve sleep, can reduce the use of antipsychotics or sedative drugs for treating sleep disorders, but also nighttime wakefulness due to apnea events. And we have to know more about the possibility to use software, CPAP software, or masks, or interfaces, more simple for patients and more compliant, suggesting more compliance in those patients. But I think that we are able to treat sleep apnea in those patients, since in the last study by Duñez, I was really surprised by the fact that the Medicare, this insurance system, underlined that compliance was in 74% of patients with sleep apnea and Alzheimer's disease. So if we look to the importance of treating sleep apnea also to reduce the comorbidity of patients, insurance are more far than us in looking at this aspect. So it can be really important.
It depends on the severity of Alzheimer's disease. Professor Santamaria underlined this aspect, I think so, because in mild and initial moderate cases, we have good, sufficient or acceptable compliance. And there is a work in geriatric population which says that also in older patients, the compliance doesn't reduce. It's not reduced in older ones. Probably more caregiver, more attention for the person, for the aged person. But I think that it's a field not so studied, I think. And in fact, my question was, which kind of study do you think are needed to address these aspects? The conversion, progression of AD, compliance, and so on, because you showed a lot of retrospective studies.
Yeah, I completely agree with your question, and I think that it is important to show that CPAP in patients with MCI or early AD can reduce the progression of Alzheimer's disease. Because if I think that FDA approved a drug reducing beta amyloid accumulation but not improving cognition, so it's a big problem, since CPAP can improve cognition and probably can reduce beta amyloid accumulation. So what are we looking for if we have probably one of the main responses for treating Alzheimer's disease in patients with sleep apnea? And so we need more data, and probably we, sleep medicine experts, should work more in combination with dementia specialists and experts to produce more literature, more randomized controlled trial in patients with MCI and longitudinal observation about the progression to dementia. I know that the big problem of sham CPAP treatment or the double blind or the possibility to not treat patients, but if we consider only 3 months of treatment, I think that we can achieve big results like Richard's for 1 year treatment of CPAP in Schreier.
I have a further question about that, Claudio. If you can comment data about biomarkers, I mean amyloid deposition or tau pathology in Alzheimer's patients. What do you think? If this can help just to have the results? I mean, if you treat Alzheimer's patients, you need a follow-up of probably more than 1 year. But do you think that this could be used as biomarkers, as in pharmacological trial? I mean, so why not?
Yeah, I think that it's time. It's time because we have a need to demonstrate that our observation by cross-sectional or longitudinal studies in patients with sleep apnea documented that beta amyloid is reduced in those patients in the longitudinal observation, and beta amyloid can accumulate, considering the studies by Rosalia group and Spira group, for example. But we have to assess better these aspects in patients controlled and included in a study with a study design, inclusion and exclusion criteria, explain in more details. It's really important.
Related to that, may I ask a question, Dr. Livorri? What do you think in future studies to consider also to include a group with risks at risk for vascular damage in the brain? I mean, vascular dementia could be a further group to be evaluated, as a number of mechanisms that are activated during sleep apnea are mediated by cardiovascular involvement, production of catecholamines, and damage to vessels, to endothelial vessels. What do you think about that?
Yeah, I think it's really important to understand more about the vascular impairment in patients with dementia, not only vascular dementia, but also neurodegenerative or Alzheimer's disease dementia. And we have to look not only to sleep apnea, but also to periodically movement disorder, since I think that it is more frequent than we expect in those patients, and also this aspect causes problems on the cardiovascular system and the autonomic function, and we have to study sleep in those patients. I think that one of the dreams of Professor Ferini-Strambi is to do a polysomnography in everyone, but I think that PSG should be planned in patients with subjective cognitive impairment or mild cognitive impairment to learn more about those patients and to learn more about the possibilities of treating the cognitive disorder in those patients.
Thank you.
Thank you too.
So, I think we can move on.
Yeah.
And shall we go to the next speaker? Eleonora Del Prete. Dr. Del Prete is a neurologist working in our group in Pisa, and she's now collaborating with Enrica Bonanni in studying some aspects of sleep medicine in extrapyramidal neurological disorders. She's an expert, despite her very young age, of deep brain stimulation, an argument to which she is going to defend her thesis for the doctorate in translational medicine here at the University of Pisa. So it's my pleasure to invite Eleonora for the next presentation, Sleep Modulation in Parkinson's Disease Patients with Deep Brain Stimulation, the role of frequency variations. Please, Eleonora.
Good evening. My presentation is about sleep modulation in Parkinson's disease patients with deep brain stimulation, the role of frequencies variation. Deep brain stimulation is an effective treatment for motor symptoms in Parkinson's disease. Subthalamic stimulation is able to improve tremor, rigidity, and bradykinesia in these patients. Subthalamic stimulation may also have an effect on non-motor symptoms as sleep. Papers in literature about the effect of stimulation on sleep parameters present important methodological differences. In the largest cohort of Parkinson's disease patients evaluated before and after subthalamic nucleus stimulation, the stimulation increased total sleep time and sleep efficiency, improved slow wave sleep and REM sleep latency, also reducing wake after sleep onset. About the effect of subthalamic stimulation on REM sleep, few and conflicting data are available. Only one study investigates the effect of frequency variation on sleep in subthalamic stimulation, and no data are available about CAP. In subthalamic stimulation, in Parkinson's disease, tremor, bradykinesia, and rigidity are usually improved in 130 Hz frequency stimulation. However, in some cases, low frequencies, as 60 Hz, are used to control axial symptoms as gait. The effect of low frequency of stimulation on gait is supposed to be related to an involvement of peduncle-pontine nucleus during subthalamic stimulation. A positive feed-forward circuits arise between glutamatergic effect of subthalamic nucleus and peduncle-pontine nucleus and peduncle-pontine nucleus cholinergic neurons. This projection, together with cortical and globus pallidus external inputs, modulate direct and indirect pathway of basal ganglia. These connections are considered responsible of different effects on gait disorder of high versus low frequency of STN stimulation in Parkinson's disease. In animal studies, 130 Hz frequency of stimulation of bilateral STN did not significantly influence the firing rate of PPN neurons, while stimulation with 60 Hz had a significant effect on the firing rate of peduncle-pontine neurons. Moreover, besides its role in gait control, peduncle-pontine nucleus, it is also well known for its contribution in sleep modulation, especially as REM generator. For this reason, the primary aim of our study was to investigate the effect of different frequencies of stimulation, 130 versus 60 Hz, on macro and microstructural sleep in STN DBS patients with Parkinson's disease. We also were interested in investigating limb movement during sleep, REM atonian spectrum profile, and slow sleep oscillation. Moreover, we explored differences in macrostructural sleep and CAP between healthy control, Parkinson's disease patients with and without subthalamic nucleus stimulation. The results of our study population was composed by 20 PD patients, 10 with bilateral subthalamic nucleus stimulation, 10 without stimulation, but with comparable age and disease duration, and 10 healthy control. Comparing Parkinson's disease stimulated patients at 60 Hz and 130 Hz frequency stimulation, we found that patients during 60 Hz stimulation presented a higher REM sleep expressed as percentage and duration in minutes, while no differences were found in non-REM variable in sleep continuity, neither in CAP. Regarding EEG pattern spectral analysis, we found that patients during 60 Hz frequency of stimulation showed an increased EEG activity within theta frequency range compared to 130 Hz in REM and in non-REM sleep. Moreover, we observed both for low and high frequency stimulation and lower power density in frontocental area currently for all bands compared to data in anti-control from liters. Detection rate of low sleep oscillation in both sessions showed the higher rates in central, but mostly in parieto-occipital areas. The comparison between 60 and 130 Hz showed that former study stimulation was characterized by a higher detection rate in large-scale areas, especially in frontal ones. However, these differences were not statistically significant. Regarding limb movement, we found a significant higher PLM index in non-REM stages in stimulated patients during 130 Hz compared to 60 Hz stimulation, while phasic EMG activity during REM sleep was not different in the two stimulation conditions. When we compared the stimulated patient with healthy control and Parkinson's disease without stimulation, we found a percentage of REM sleep significantly lower at 100 Hz in stimulated patient than in healthy control, and but not at 160 Hz stimulation. Moreover, we also found that patients when stimulated with 60 Hz showed a REM percentage and number of REM periods similar to healthy control. So the conclusion of our study, the analysis of sleep architecture showed higher REM sleep percentage in patients with 60 Hz stimulation compared to 130. This result corroborates the hypothesis of a possible involvement of PPN during low frequency of subthalamic nucleus stimulation. Non-REM sleep variables were not modified by frequency variation as well as CAP parameters. No autonomia variations were found in the two stimulation conditions. However, it is not surprising considering that a functionally segregated set of glutamatergic phone-time structures for cortical activation and autonomia are described. Then we can suggest that subthalamic nucleus low frequency stimulation can improve REM sleep in Parkinson's disease. However, further study with larger samples need to confirm our data. Thank you for your attention.
Thank you, Dr. Del Prete. Very, very interesting results. I'm sure that there is a very wide field in this area to be covered by further studies. So your presentation is open to discussion, please. In the meantime, I would like to ask to Eleonora, in your model, no? The low stimulation frequency is able to increase the REM sleep activity. And on the other side, muscle hypotonia related to REM sleep is not altered. How do you explain this discrepancy? And another question related to that, maybe I'm not sure if there are in the literature some data about that. In considering your results, do you think that also dream activity would be affected by this experimental model in Parkinson's disease patients? I mean, do you think that modulating the stimulation frequency could also affect dreaming activity during REM sleep, or this is maybe just a naive question?
Thank you. Good evening to everybody. Thank you, Professor, for your question. So the aim of our study was to investigate the effect of subthalamic stimulation on sleep. Especially we're interested in REM, because we know that subthalamic stimulation has an effect at low frequency of stimulation on PPN, because we know that low frequency of stimulation is effective in improving gait disorder in Parkinson's disease patients. So the hypothesis is a spread of the stimulation through PPN. So we know that PPN is pedunculopontine nucleus is a nucleus that is involved in REM generation, but we know that PPN is involved in the REM generation, either in desynchronization of cortical activity, but also in generating atonia. And the effect on the atonia is the muscle atonia is through the effect on the subcoeruleus region, that is a glutamatergic region, that together with the lateral dorsal tegmental region are areas involved in REM generation. And it's very interesting that in these cells, in pons, there is a sort of segregation in glutamatergic cells that are involved in EEG desynchronization and cells that are involved in atonia. And our hypothesis is that probably the different effect of the stimulation is related probably on a different effect of different cells on the pons. The effect of limb activity probably is related to the stimulation. Different frequency of stimulation has different effect on motor aspects, but in our patient we controlled the motor effect with an actigraphy, and patient in different stimulation had not a greater difference in motor aspect, but the difference was in specific part of sleep and in different stages. Yes.
What about dream? Maybe someone else?
Dream, we don't know exactly if they, we don't know exactly if they, I don't know. They have more REM sleep, but I don't know exactly if they have more dreams.
Okay, there is a question from Giovanni Santamaria. Previous studies suggest that high frequency do not change prevalence of REM sleep behavior disorders in PD with RBD. Were these changes in RBD prevalence using 60 or 130 Hz frequencies?
Thank you for your question. In our patient, we investigate especially REM without atonia in this patient, and it's not easy to investigate in this patient REM without atonia because we investigate the tone and not in mentalis muscle, because they have a great artifact of stimulation because the connector is in cervical areas. So we investigate atonia, especially in tibialis muscle. So we decide to investigate the muscle tone, and we investigate especially muscle, the REM atonia in this patient, and not all RBD evaluation. But it is not easy in this patient due to a lot of artifacts. So we read the recording, we do it manually because it was not possible to do it with the programs because it's not easy to investigate this kind of patient due to the artifacts. So no.
Okay, thank you. Any more questions? I'm not sure, Eleonora, you mentioned the relationship between the effects on REM sleep and the more cardinal clinical aspects of these patients. I mean, tremor and general motor activity. Were there relationships between these two parameters?
Thank you for the question. Yes, we know that in DBS, ST and DBS stimulation, 130 Hz is the frequency that is usually used to better control bradykinesia, rigidity, and tremor. And tremor is usually well controlled with frequencies that are 130 Hz and more than 100. So we usually use 130 Hz, 180 to better to control tremor. But tremor is not well controlled with low frequency of stimulation. And in fact, in our patient, we found that patient with 60 Hz of frequency of stimulation have more tremor, but this is something that we expected. But for we is very interesting that our patient have tremor during sleep, during non-REM sleep, but also during REM sleep. We know that Parkinson's disease patients usually reduce their tremor during sleep, especially in REM stages. But our patient had tremor in non-REM sleep and in REM sleep. So we are investigating this aspect in these patients.
Okay.
Okay.
Bene.
Yeah.
We can move on.
Yes.
So.
Okay, let's move on with Giuseppe Plazzi from Bologna, the actual president of our Italian Association of Sleep Medicine. His enormous expertise in narcolepsy is well known. He will deal with the narcolepsy and cognitive and cognition. His presentation is live.
Thank you, Maria, and thank you, Professor Siciliano. I am sharing the screen now. I try to share the screen. Okay. Can you see it?
Yeah.
Yes. Okay. So thank you very much for having invited me. And my talk is based on a review that we recently performed and is ready to be published on Accepted in Sleep Medicine, and is on narcolepsy and cognition. Sorry, come faccio? Okay. Before 2000, when orexin was discovered, narcolepsy was believed to be a pure REM sleep dysfunction model. Indeed, narcolepsy is characterized by a remarkable REM sleep dysfunction with remarkable sleepiness during daytime and disrupted nocturnal sleep and several manifestations of dissociated REM sleep wakefulness. And also by the quick entrance of the patient within REM sleep. And since the first description of narcolepsy cases, concentration and memory problems were reported in narcolepsy without cataplexy. But since 2000, with the discovery of the orexin and the discovery that hypocretin is, that narcolepsy is linked to an hypocretin deficiency, of course, the way to interpret also cognitive dysfunction, this disease, changed. Indeed, orexin are produced in a limited region of the dorsolateral hypothalamus and were thought originally to mediate specifically feeding and promote wakefulness. But growing evidence make clear that they participate also in a wide range of behavioral and physiological processes, indeed mediate behavior under situation of high motivational relevance, such as during physiological need states, exposure to treats, and reward opportunities. Many behavioral function of orexins reflect a fundamental integrated function of them in translating motivational activation into organized suites of psychological and physiological processes. Supporting that this adaptive behavior may reflect a common underlying function for these peptides. And there are several bases that allow us to suggest that hypocretin also have an underlying impact on the cognitive impairment that has been described in narcolepsy type 1, narcolepsy with cataplexy. Indeed, as I told before, since the early cases, concentration and memory problems are reported in narcolepsy cases. So this is the title of our review that has been conducted by Marco Filardi and our group, together with a group of Giovanni Corazza, who is the director of the Marconi Center for Creativity in Bologna. And those are the keywords that we use for this systematic review, and also the flowchart of the selection of the papers that we started from a huge number of papers, and we selected at the end 43 studies on that assessed the cognitive function in narcolepsy type 1. Sorry. 32 compare narcolepsy type 1 patient to healthy controls, 11 compare narcolepsy type 1 patient to healthy controls and patient with central disorder of hypersomnolence or other sleep disorders. At the end, more than 1,000 patients have been studied in these papers, and compared to more than 1,000 healthy control and more than 400 central disorder of hypersomnolence or other sleep disorder patients. This is the function that we assessed in this review according to the taxonomy. With under the domain of attention, we have several subdomains, memory, and executive functions. And this is a figure that demonstrates that most of the papers focus on attention and driving stimulation, but also on emotional processing, as we can see here, and decision making. So, concerning attention, that has been assessed with the short and simple tasks or with the complex reaction times and with an higher cognitive load. In the short and simple task paper, we found that narcolepsy type 1 patient often display a slower reaction time compared to control. This was expected. And the performance is more variable also in the narcolepsy type 1 patient group than in controls. The accuracy of this task is comparable in narcolepsy type 1 and controls. So the conclusion, all the paper conclude that the impairment at the temporal level of the attentive processing in narcolepsy type 1 patient. In a paper exploring complex reaction time task, with a higher cognitive load. Narcolepsy type 1 patient perform a slower reaction time times indeed than controls, and the performance again is variable, more variable in narcolepsy type 1 patient compared to control, and the accuracy also is reduced in narcolepsy type 1 patient. So the conclusion that we can load from these papers, so from the analysis of this paper, is that there is an impaired executive control of attention. Then memory. Memory is often reported as impaired in narcolepsy patient. However, memory, according to the experiment of the papers, memory performance of narcolepsy type 1 is comparable to that of control for most memory function. Memory span, declarative memory, visual spatial memory, and verbal learning. But only a slight alteration from one paper is reported for procedural memory, and indeed in paper exploring the working memory, there is a proven impaired in narcolepsy type 1 patient. For the executive function, we have to pinpoint that narcoleptic patient, the intelligence, explored in narcolepsy patient is compared to that of control. Narcolepsy type 1 patient display high performance in several neuropsychological domains and involving executive functioning. The response to inhibition that has been explored largely, despite the overall slowing of the process of speed, narcolepsy type 1 patient generally display an intact quality of performance, with only slight difference between narcolepsy type 1 patient and controls. The decision making, there is two papers that report a poor performance in the decision making under ambiguity. Is a report by the French group of Montpellier and from the Leiden group conducted by Gerti and Lammers. And but is an impaired performance in decision making under risk. So narcolepsy type 1 patients are less flexible in adapting their response to after a negative feedback, displaying a higher tolerance to uncertainty, and tend to opt more frequently for choices with high immediate reward, but leading to negative consequences in the long run. The emotional processing also displays several abnormalities in the neurophysiological responses to unpleasant stimuli. This has been explored by several groups, and who find an absence of the amygdala-dependent startle potentiation reflex, a reduced cardiovascular response, a reduced electrodermal response, and autonomic muscular reactivity. And they reduced also N2 and P3 waves. The altered activity of the amygdala has also been explored in functional MRI studies to both pleasant and unpleasant stimuli. The fluency in narcolepsy type 1 patients show a reduction of the verbal fluency in the half of the study explored. There are 5 studies, and there are no discrepancies between the semantic and phonemic fluency. Another interesting point that we are working on, but also the group of Paris of Isabelle Arnulf, is that creativity in terms of potential creativity, but also success creativity is increased in narcolepsy patients. So in conclusion, there is an attention impairment in narcolepsy type 1 patient that is confirmed by a slower reaction times, a significant decline of the performance across the time on task, and narcolepsy type 1 patient display the most compromised profile and impaired quality of performance in task with high cognitive load. Despite the common complaints of memory deficit and forgetfulness, narcolepsy type 1 cases overall do not show memory performance impairment, and the executive function, and in particular the inhibition, has been largely studied. Overall is preserved in narcolepsy type 1 cases, except for flexibility, which result impaired, and the impairment of higher order cognitive function in narcolepsy type 1 patient is also has been demonstrated by several papers. And very interesting, the creativity is increased in narcolepsy type 1 patient, and in particular this last point open to behavioral treatment in these patients. So I thank you very much for your attention, and I close. Okay.
Thank you very much, Giuseppe, for your presentation with very new data. Any questions?
May I, Giuseppe?
Hello.
Very interesting study in justifying or explaining the selectivity of the neuropsychological performances in these patients. Do you think that the hypothesis is related to the specific effect of the mechanism of action of the alterations in narcoleptic patients, or this is a feature that can be influenced by other factors?
Well, thank you very much. I think that the data are mostly convergent to a specific alteration in narcoleptic patient, probably due to the biological basis of narcolepsy, that is the orexin deficiency, the underpowered orexin network in narcoleptic patients.
Thank you.
Other questions? Did you find any differences according to age ranges?
Age ranges?
Different.
No, they are all the paper focus on adult narcoleptic patients, so they're not.
Perfect.
But the children is a very interesting point, because narcolepsy in most of the cases arises in children, and there are very much very few paper on the cognitive features of these patients.
Yes.
Where the psychological or cognitive intervention could be very efficacious.
I see. Thank you. Well, another? Okay. Another question from the audience?
There is a question: what hypotheses? What hypotheses are on the link between narcolepsy type 1 and the increase in creativity?
Yeah.
Well, the paper that has been published pinpoint that there is a relationship between creativity and lucid dreaming and hallucinations. So probably the component of the REM sleep dissociation is crucial for creativity in this patient.
Yes, sure. Well, no other no questions. Okay. Can go on if you want, Professor Siciliano.
Okay. Thank you. So we can move on to the last speaker. It's my great pleasure to introduce Professor Joan Santamaria. I'm sure that all of you know this colleague. Is very famous in sleep medicine. Professor Santamaria is a neurologist, is in the University of Barcelona and is responsible for the multidisciplinary Center for Sleep Disorder at the Hospital Clinic in Barcelona. He serves and has served in a number of positions into scientific organizations and associations for sleep medicine. And his research has encompassed a number of very relevant items in sleep medicine, especially with regards to relationships with neurodegenerative diseases and more recently with some neuroimmunological syndromes. So his presentation will be characterization of the sleep disorder of anti-Ig LON5 disease. Please, Joan.
Good afternoon. My name is Joan Santamaria, and I would like to talk today to this audience about the sleep disorder in anti-Ig LON5 disease. I want to thank you, the organizer, for inviting me to this interesting symposium. Anti-Ig LON5 disease is a recently described disease in 2014, which combines a prominent sleep disorder, signs of brainstem dysfunction, movement disorders, or cognitive impairment with antibodies against Ig LON5, which is a neuronal cell adhesion protein of unknown function. You can see that the protein is in the neuronal membrane, and the antibodies attack the protein and impairs their function, which is unknown, but it's impaired. So there is a tight association with an HLA, DRB1-1001. At the same time, there are pathological features suggestive of a neurodegenerative process, and there is neuronal tau deposits in the brainstem and hypothalamus. The thalamus is not impaired, and there is no inflammation. And this is an interesting link between autoimmune mechanism and neurodegenerations. It seems recent experiments show that the antibody damages the cytoskeleton of the neurons, as it's shown here. You compare this with anti-NMDA and this with anti-Ig LON5, and this could open the door for neurodegeneration. The symptoms in this disease are a combination of problems, and the reason for consultation in this large series of 72 patients is movement disorders, bulbar symptoms, or sleep disorders. But when you see the patient at the moment of diagnosis, sleep disorders are present in almost 90% of the cases. Now, what are these sleep symptoms in this anti-Ig LON5 disease? Well, it's a combination of parasomnia, abnormal vocalizations, movement, and sleep behaviors, 86%, reported normally by bed partner because the patient is unaware and has no dream mentation, and typically has all type of movements, but especially gesticulation, mimicking daily life activities, what we call finalistic. They also have stridor. They may have insomnia, but it's mild to moderate, it's not agrypnia, and this is excessive daytime sleepiness of mild to moderate that improves with CPAP. When we do a polysomnogram, what we found, we are summarized here. And it is surprisingly a combination of periods with extremely abnormal sleep architecture alternating with other periods of normal sleep in the same night. And sleep efficiency is moderately reduced. And the problem seems to be in sleep initiation. Now, there is an abnormal sleep initiation, either a sleep onset or following an awakening, and it occurs as undifferentiated non-REM sleep. I will tell you about this in a moment, and poorly structured NII sleep, with frequent vocalizations and simple or finalistic movements. But the interesting thing is that if sleep continues, there is a progressive normalization of non-REM sleep, with normal N2 and 3. When the patients enter in REM, they have REM sleep behavior disorder, and they also have sleep stridor. So we will see all these phenomena in a moment. One of the problems with anti-Aglon 5 disease, as in any other neurological disease, in many other, is that the standard scoring rules with parts of the recording are very difficult to apply. So we decided to be a little bit unconventional and use information not only from the three main variables, EEG, EOG, and chin, but also from synchronized audiovisual recording. The state of the eyes, open or closed, is important, body posture, vocalization, movements, the interaction with the environment. Respiration is also a very important variable. It tells you if the patient is awake, snoring, or with stridor, is asleep. And the graphic display of EEG power spectrum is also helpful. Everything that we can find is useful to understand what is going on in those patients. So the scoring process, we start with a single epoch and say if this is awake or asleep. Sometimes it's very difficult. But if we pay attention to the calibration part where the patient has behaviorally awake with eyes closed, with alpha rhythm, and when this disappears, we know the patient enters sleep. Then we say if this sleep is REM or non-REM with information from the EEG providing the most important reference. We think the EEG is important, very important. And then we say the REM sleep was scored in the presence even of chin EMG activity when the EEG was characteristic, and the EOG showed definite and recurrent rapid eye movements. Non-REM sleep was scored whenever the characteristic EOG pattern, the EEG of REM sleep were absent. If we had the typical waveforms, K-complex sleeps, we use the standard symptoms. If we didn't have them, we use an alternative definition, which is this. When we have a patient which is sleepy, but the characteristics do not correspond to REM sleep and have no non-REM waveforms, the typical spindles, K-complexes, etc., we say that this is undifferentiated non-REM sleep. And in anti-Aglon 5 disease, this consisted of consecutive epochs with diffuse moderate amplitude for 7 Hz, excessive chin and limb activity, and frequent vocalizations and movements. We also needed another particular stage in where we were able to identify minimal elements, K-complexes, sleep spindles, but associated with vocalizations, sleep movements, and non-REM sleep. And this was different from normal non-REM sleep because the typical waveforms were scanned, were occasional, were not typical, were difficult to distinguish, and because of the presence of motor activation. Let's review one of these patients, the polysomnography of one of these patients. Here is wakefulness, where we see a normal EEG with posterior alpha rhythm, no slowing, anything, nothing of this part of the recording is abnormal. But when the patient enters sleep, he enters through this undifferentiated non-REM sleep where we cannot find any element suggestive of typical N2, N1, or N3. And also it's not typical of REM, so we decided to call, as I said, undifferentiated non-REM. It is 30% of the total sleep time, and the first periods last about half an hour as a mean. And this is an example of an epoch of poorly structured N2 with a lot of movement, occasional K complexes, which are trains, which are not typical isolated K complexes, and it lasts about 50% of the total sleep time as a mean in a group of patients that we studied. Let's see what are the behaviors during this undifferentiated non-REM sleep and PSN2. Typical, in this case, the patient is having classical purposeful, finalistic, in the terminology of Bologna, and if they do gesturing, mimicking daily life activities with the eyes closed, totally unaware, without dream mentations, and without remembering anything of this. Okay? Then with the passage of time, sleep normalizes, and we find other epochs with normal sleep spindles and delta waves, the complexes. So we have this as a night of a patient showing the characteristic changes from an undifferentiated non-REM, poorly structured N2, normal N2, and normal N3. When the patient enters in REM, it does in a form of a REM sleep behavior disorder. You see the typical rapid eye movements, the EEG, and the discharges in the EMG of the limbs. And this is associated with the typical jerky and the movements of REM behavior disorder. It's different from the finalistic type. And finally, patients have stridor. Stridor, for those of you who are not familiar with that, is the very, very, and it's due to paralysis of the vocal cords. So in a normal night, we have this hymnogram showing the distribution. The patient starts in undifferentiated non-REM, enters in PS2 a little bit, then a little bit on N3 and arousal, and then goes from here, and at the end you have a normal REM and non-REM activity. So when we try to do clinical pathological correlation, as I said, in this disease, there are tau deposits in the neurons, in the hypothalamus, and in the tegmentum of the brainstem. So how can we relate these with the sleep alterations that we described? So we think that the abnormalities in non-REM sleep initiation could be in part due to the hypothalamus alterations. And most of the symptoms are probably explained by the brainstem, REM sleep behavior disorder, vocal cord palsy, breathing problems, and even what we don't have an explanation is for these finalistic movements. But it turns out that the abnormalities in non-REM sleep initiation could also be explained by alterations in the lower brainstem function of this medullary GABAergic sleep generating center that was described in 2014, the parafacial zone, which is a sleep center different from the hypothalamus and could be having a role in anti-IGLON5. So in conclusion, I think that to assess the sleep disorder of anti-IGLON5 disease, a scoring system that combines conventional staging with a descriptive approach for periods of abnormal sleep architecture is fundamental. It can be used in other neurological sleep disorders in which conventional scoring system cannot be applied well. And what is the significance? We think that in anti-IGLON5 disease, abnormalities in non-REM sleep initiation might be due to involvement of brainstem areas inducing sleep onset, like the parafacial zone I mentioned. It's like when we're trying to start a car, the engine doesn't start. We have a problem here. And with accumulated homeostatic sleep pressure, sometimes, normal sleep will enter via alternative ways, like we do in a car. So we cannot start with the normal system, but we can push and then start the car with alternative ways. I think it's something like that happens in anti-IGLON. And quasi-purposeful finalistic sleep behaviors may occur in different diseases. We know that in FFI, fatal familial insomnia, Morgan syndrome, and anti-IGLON5 disease, they look alike very much, and they probably have different mechanisms, but I don't have more explanation for that. Okay, thank you very much. And this is the IGLON5 team in our center. Thank you very much.
Thank you, Professor Santamaria. Very interesting data, and your presentation is open to the discussion. May I? Bianca Maria, please. Unmute your microphone.
Sorry, not to disturb. Exciting inflammatory tauopathy. I think this is an important paradigm for degenerative dementias. And my question is, we know that different tau give different tauopathies. And did you confirm tau 3-4 repeat in anti-GLon5, which is typical of AD, of Alzheimer's disease, and not PSP, for instance? And this, I think, is so important, I think, difference. Did you confirm it?
Yes, it is not the same as in Alzheimer's disease. It's a different tauopathy. In fact, before the description, the identification of this disease, there were pathological descriptions of unusual Alzheimer cases localized in the brainstem and hypothalamus. And our pathologist, LNGLP, brought together a series of colleagues and this review a series of cases that were published before the identification of this disease, and they have same characteristic, pathological characteristics, and there was even some information, clinical information, suggesting that there was a sleep disorder in those patients. But obviously, and this is published in Acta Neuropathologica 2016, it's a different tau. There are different taus, as you said, in PSP, in Alzheimer, and in anti-GLon5 it's a different type. But the pathology, it's similar, but in an unusual place.
Yeah, thank you.
We don't know if this is a late change, because well, these cases, the first one took a long time before they were diagnosed. Some patients spent 12 years.
Maybe.
So now there are more early cases that have arrived to pathology, and in some cases there is no tau deposition and there is inflammation. So it could be that there is an early inflammation leading to neurodegeneration via this neurofilament, the cytoskeleton changes, because we don't know what GLon5 does. Is in the membrane, but the function is totally unknown. But the antibody seems to be seems to injure the protein. It makes the protein disappear from the membrane, and it changes the cytoskeleton. This is how this eventually leads into a sleep disorder. I don't know, but
yes, okay.
Interesting association also, the association with HLA. Before this, many autoimmune encephalitis, people didn't look for HLA association. But it turns out that anti-LGI1 encephalitis has also an association with HLA. And we look for HLA because we are sleep people. We were interested in narcolepsy, obviously. And when we saw these patients, we tried to understand as much as we could. And we also looked for HLA. There was no previous assumption or hypothesis, but it turned out this is a very tight association. So the combination of an antibody with an HLA seems to lead to an encephalitis. And the neurodegeneration seems to lead to the tau deposit. So, but it's a very interesting. And now, I'm sorry because I'm talking too much. So it was described in 2014, and now it's the third most common encephalitis after anti-NMDA, anti-LG1, anti-Caspar2. Now it's more frequent than Morvan. Morvan, there are 50 cases, and I think there are currently more than 130 patients in 7 years. It was there, but nobody nobody identified. That's very, very interesting.
Thank you very much. Exciting. Any questions?
Professor Santamaria, just a couple of questions. How do you treat these patients, and which the characteristics of the wakefulness?
Yeah, the treatment unfortunately is not very effective in the published cases, probably because we identify them in very late phases of the disease. But there are few reports suggesting that the typical autoimmune treatments, especially rituximab, for example, all our patients were treated with all the treatments that you can imagine, no? Immune
globulins.
No, there was no clear effect. But I think everybody, when you see a patient like that, you should treat them, because there is a potential benefit. Rituximab is one option. Corticoids, high-dose corticoids, immunoglobulins, all these we have tried, and I cannot say there is one which is better or not. I mean, there is not enough information yet, but I think you should treat those patients. And the other thing you should do is treat the sleep apnea. That's it's interesting because the 3 first patients were previously diagnosed only as sleep apnea. So everything started with a sleep apnea because they have this noise, these apneas, and with CPAP, the respiratory findings were obviously cured, but not the neurological, the movements and all that. And that's why they were sent to us, because the apparently normal sleep apnea was cured with CPAP, but the other symptoms were not. And so every time I have a chance to talk to pulmonary doctors, they say, well, you have apparently no typical sleep apnea patient that moves too much during the night. This may be one, because CPAP is very effective in stridor. It eliminates that for some time, because with time, the respiratory problems may worsen, and then you need to do a tracheostomy in a late phase. It's like in multiple system atrophy. Same.
Thank you.
You said about the wakefulness. Wakefulness is normal. The EEG I show is typical, normal alpha rhythm at normal frequencies. And the symptoms they have during wakefulness are the ones I show you. Many patients come to attention because of movement disorders. And it's typically a combination of 2 or 3 different movement disorders, not a single one. Gait impairment with chorea or craniofacial dyskinesia. If you have a patient with a combination of these symptoms, you should ask about sleep problems in those patients. Well, you should ask about sleep in every patient, but it's difficult to convince our neurological colleagues not devoted to sleep. But in this particular disease, this is very important because this combination is very frequent. Or a dysphagia, craniofacial dyskinesia, bulbar symptoms, and a fraction of those patients come to you because of sleep problems, parasomnia, stridor, etc. But when you see the patient, whatever the reason they come to you, and you ask about sleep, sleep is very common. This is a review. It is going to appear in Neurologist, which is a review of 72 cases that my colleague Frances Graus have. It's a multi-collaborative, multi-center. Many centers have cooperated in that. I think it gives a very good view of the movement disorders in this disease.
Never appeared as a paraneoplastic syndrome? Never.
No, there are no tumors in this. Well, some patients have because
okay.
No, it's not a paraneoplastic disease.
Thank you very much. If there are no other questions, thank you again, Professor Santamaria, and I invite Bianca Maria for the closing remarks of this very interesting session. Please, Bianca.
I think Oh, many thanks, everybody. Nice presentation, nice discussion. I hope in the future to have other moments to discuss with you about these aspects. I think they are so important for neurologists and sleep specialists. Bye-bye, all of you. Thank you very much.
Thank you.
So now I thanks for all the moderators and the speakers for this wonderful section, for this wonderful meeting, and then I give floor to the last part of the 11 minutes of sleep, to the round table, mental and body health and sleep, red flags. So I give virtual floor to Professor Cirignotta and then to the others, moderators and speakers of this last part.
Okay, thank you, Michelangelo. Welcome everybody to this round table. The topic of sleep-related red flags for mental and body health is of great interest. And respect to the schedule, we are pleased to have one more speaker, Professor Wiaczowski. Professor Dieter Riemann now was the second.
Yeah.
Okay.
Sorry, may I have one suggestion?
Of course, Vlad.
Yeah, I was thinking that Professor Riemann didn't have a chance to answer questions. And I was wondering if he could use a bit of time right now to let Professor Riemann to address questions that panelists and moderators might have, if everyone agrees.
Yes, okay.
Yes, I'm happy to take questions, sure.
Okay, then who is the first speaker for...
There is a question from Pierre, I see.
Yeah, thank you very much. And Dieter, that was of course very, very interesting. And I was wondering your thoughts about the future and especially regarding insomnia classification. Actually, this is a very broad definition of insomnia, and you demonstrated that there is a lot of subtypes, in fact, of this insomnia, and you also show that there is pertaining factors and different solutions or treatments that can be proposed to patients. How do you, because there is this, of course, this useful transdiagnostic approach of insomnia, but also part of your work is a focus on depression, which is probably a more homogeneous type of insomnia. How do you think and imagine the future of this classification and maybe the transfer to clinical research? Because up to date, it is mainly the EASY, Insomnia Severity Index, which is used, but it's again something very broad.
Yeah, I think the field has evolved in the last 30, 40 years. We had with the ICSD, the ICSD-2, and the DSM-4, we had sophisticated systems postulating many different insomnia subtypes, like 11 or 12. And then came the change with the DSM-5 and the ICSD-3, and probably also in ICD-11, suggesting a very broad category of insomnia disorder. I think that was a necessary change, because if I asked people outside the field about, you know, the insomnia subtypes, 11 insomnia subtypes, they were just laughing at me and saying, you don't believe that. It's not what, I mean, I'm a GP, I'm a psychiatrist, I'm a neurologist. And I mean, these 11 subtypes or 13 subtypes, I don't, what shall I do with this? I have 5 minutes time or something. So I think moving to a broad category made sense, because it also maybe might move more attention towards the insomnia. But I'm fully aware of the fact behind what we diagnose now as insomnia disorder. Probably there are different subtypes. There might be insomnia with objective sleep duration, short sleep duration. There might be insomnia with REM sleep instability. There might be insomnia with a focus on psychological factors and so on. I think for the time being, it's okay like it is, but I think the field will further develop, and I think we'll have to think about the role of polysomnography for insomnia. I think most societies say, no, and most health insurance companies say, no PSG for insomnia, much too expensive and stuff like that. But to a certain extent, at least in research, we need it to define subtypes of insomnia, short sleep duration, REM sleep instability. And we need to prove that these subtypes are also predisposed to certain treatments, or that one subtype responds better to treatment A and the other subtype responds better to treatment B, and the other subtype responds better to treatment C. So I think that the next 10, 20 years should work with the insomnia disorder, but we should really use all the diagnostic capacities. We should use, you mentioned the IC. It's important. It's used as an outcome measure for many studies, but I also suggest sleep diaries to become an integral part of the diagnostic process. And I also suggest to use PSG, at least in research. Yeah, it's totally important to do that. Otherwise, we might also lose credibility versus the rest of the sleep field, you know. Or insomnia might be something, it's just psychological, and there's no, and I do believe there is something like a psychoneurobiology of insomnia. There is something genetic there. There is something on the hyperarousal level, and we need the PSG there, at least for research purposes, to check whether is there enough, how long do these people sleep? And there are some very important questions. We've seen thousands of insomnia patients also in the sleep lab. And interestingly, many of them sleep much better than they think. But there is a proportion of insomnia patients, they sleep worse than they think. They come to the sleep lab and they say, I might sleep 5 hours, and we have them in the sleep lab and they only sleep 3 hours. And the question is it okay to treat them only with a CBTI? Would they need medication? Would they need very intensive? Because 3 hours, if you see this 2 times in the sleep lab, it's probably it's not just an artifact, you know. And 3 hours, I think, is really not enough if you're 45 years old or something like that. So we also need to think about these patients. I guess we need guidelines, we need consortia agreement on what is the role of polysomnography for the diagnosis of insomnia, at least research-wise. What are the important questions for the future? We need consortia or guidelines to say, what are the questionnaire measures, sleep diaries, the IC, what are the diagnostic processes involved? And especially we need to translate that. I mean, we are here, the 100 people or whatsoever, I think we would agree on a lot of things, but we are just a tiny part of the clinical care of these patients. The usual process still is, and I hear this from patients, I mean, you have chronic insomnia, you see your doctor, it's a 5 minutes process, the diagnosis, and you may go home with a prescription, or you may go home with doctor saying, you know, I don't sleep good. I don't sleep good. I have insomnia myself, maybe try a glass of wine and stuff like that. And I think we need to penetrate the general medical sector. We are specialists and we agree on many issues. And I think that's more of a political question then. But I think there are really challenges on the research level, but also on the clinical level, on general care, because insomnia is, I mean, 10% of the population, let's say maybe half of them need help. Not everybody who has a diagnosis needs help. We know that. And but maybe 5%, and that's a huge proportion of the population. And at present, I guess I can only say for Germany, it's still a neglected problem, and still it's mainly, the main reaction is prescription of hypnotics. And many doctors say, I don't like the benzodiazepines anymore, but what else should I do? You know, I don't know what else to do. And I think really teaching medicine, and we should go very offensively teaching into medical curricula, psychology curricula, and I would suggest we should also go, the point is, if you go to school, if you are in primary school and secondary school, do you ever hear anything about sleep? No, probably not. And
no, you're right.
Yeah, and I think we should really also undertake every enterprise that in education, in primary school, in secondary school, and university, and not just for people interested in medicine, somehow a sleep education should be part of this.
Yeah, I totally agree with you. We need to educate even our, colleagues. For example, in Italy, we have this situation, psychiatrists still think that insomnia is related to depression. So they still think that it's just in this way. This is an EP phenomenon. So we have really to improve the education about sleep. I was thinking, what do you think about the role of actigraphic registration in the diagnosis of insomnia? And for example, what's about melatonin? I mean, the evaluation of melatonin for insomnia.
I think actigraphy can play a role. So actually, what we have now is that we have all these fitness trackers, and all of them offer actigraphy. And I would be very careful about accepting the results from a commercially available fitness tracker as valid. And I have one myself here, and I get sleep results every morning, and every morning they're more crazier than ever. And I don't think that my sleep is so crazy or so strange. It measures something here, something there. And actually, I think it should be really evidence-based actigraphy views, and we have these trackers in research. And I think they are very valuable tools to get information about sleep-wake rhythms, about the rhythm of people. And I can tell you, we do a lot of, we also do many studies in young people. And usually the text where we advertise is we're looking for good sleepers having a regular sleep-wake rhythm. And usually we just ask people to fill out for 2 weeks a sleep diary, and you get the strangest of results from the age bracket from 18 to 25. And these people think themselves they have a regular sleep-wake rhythm, and you would say, sometimes I've never seen something like that, somebody behaving like that. And I think that's really an educational matter. And I guess there's still lots of initiatives, but it needs to tie in probably with policymakers and health policymakers.
Yeah, sure. We wanted with the Italian Association of Sleep Medicine to create a program for schools. We wanted to go there, right? Giuseppe, do you want to discuss this project? We wanted to go there before the pandemic situation. We had a lot of projects, and hopefully we are going to start again and go in the schools and speak about the importance of sleep, especially during adolescence, and how to measure it. With the family and so on. So. There are other questions for Dieter. It's so important to have him here. So
I think Ugo Faraguna had a question.
Yeah, wonderful.
Yeah, but by the way, my question was about your fitness tracker. So I noticed that you had a smart band, and my question was whether there is a medical place for this fitness tracker. So since Laura asked you precisely this question, I will change it slightly, because one of the possible concerns about all these fitness trackers, including sleep trackers, is that you might pay attention to measures, to this quantified self, and in some patients this might does exactly the opposite, focusing on the issue. So what's your perspective on this?
Oh, you're absolutely right. I'm using this thing because I manage to do 10,000 steps every day. That's what I use it for. But it offers lots of other possibilities. And the thing is, the question is concerning sleep. That's very strange. I would almost say this is dialectic. It's good not to pay too much attention to your sleep if you're a good sleeper. If you're a good sleeper, you're using a tracker like this. And it happened, actually, my sister, I have a younger sister, she's 50 now, and she has a Google Watch, and she got it as a present for Christmas 2 years ago. And 4 weeks later, she phoned me and said, "Dear, the Google Watch tells me I'm a poor sleeper." And I said, "Well, are you a poor sleeper?" "No, I'm not aware of any sleep problems." I said, "Okay, then throw the Google Watch away." Because I think all of these trackers are in there for business, just to make money. So none of them really needs to hold up to scientific scrutinization. Some of them have publications, how they correlate with PSG, but I guess that's really, I mean, on the one hand, I say we need awareness for sleep and insomnia and all kinds of sleep disorders. On the other hand, I say that paying too much attention, if you have a sleep problem, if you have insomnia, probably is a major reason to develop chronic insomnia as a psychological reason. So you have one bad night, this is normal, but there are people who have like the 8-hour rule, like written in stone in their brains. And so they think, I got just 6 hours. Wow, terrible. What's happening the next night? I'm waiting for the next night. And you wait for the next night, and actually psychological factors play a role. And if you think too much about your sleep, if you are afraid of not getting enough sleep, your insomnia will be reinforced. So, but that's really very important to find a balance here. On the one hand, all of us would agree, we'd say it's important to pay attention to sleep. But on the other hand, and every adult person in Germany probably once in a year has an insomniac night. And I would suggest to all of them, this one night, take it easy, don't get nervous, don't get hyper-aroused about that. Things will usually regulate themselves. And I have also, if you talk about insomnia disorder, my theory is that basically basic circadian function and basic sleep homeostasis is not compromised in insomnia disorder without a neurological background, without a mental disorders background, which means that probably on average these people get, if we had polysomnography in all of them, like 6 hours of sleep or 6.5. But that usually people think they get less and you don't feel very well with it and you get focused on it, and the worse it gets. The more you focus cognitively on it, the worse it gets. So I suggest, and Ugo, I can follow you here. First of all, if you have a bad night, really don't worry. This is totally normal. I mean, the same as for a headache or a backache. Who never has a headache or a backache? But if you have a headache, it's not a sign of a brain tumor. Fortunately, in most of the cases, and if you have a poor night, it's mostly, in many cases, it's self-explanatory. You have stress, you have an examination, so you have a bad night. And but the problem really is, when should we suggest then when should people seek help? Yeah, and I guess not too late also on the other end. But I think some basic education about sleep in school and university, it would help. Yeah.
If I can comment very, very quickly. So what do you think about a strategy that makes data about sleep, actigraphic data, smart band data, available for physicians, medical doctors, with a degree of precision of certified, validated, but not necessarily to the subject. So to have a knowledgeable filter in the ability to read this data.
Yeah, that's an interesting question. I think it would collide with the European data protection rule that, you know, you self-produce data and you don't have access to it, but somebody else. Probably this would not work from a legal point of view. The interesting point is, I think I do believe in the actigraphic data of what these things generate. I do not believe in the sleep algorithms they have in there. And actually, I guess another problem is that all the commercial trackers are proprietary. So probably they would never give out their data to doctors. I don't know if you could negotiate, but they will never make public the algorithms they have in there. We tried so, and I know that also the Oxford group tried with big groups with Google and whatsoever, and it sounded like the data they will allow researchers to look at the data, but they won't, because, and the point is for them, the important thing is to sell the device. And if you put this under scientific scrutiny, it might make a dent in what they claim, what they can measure. So they are not interested in scientific scrutiny. But I think that these devices can do a lot. And if you could find a way, I guess it's really an important point you raise. But I think it would probably be prevented by legal reasons, because imagine you yourself generate data, you don't have access to it, but your doctor has access to it. This is probably...
But yes, but for instance, you know, in clinical practice, you are monitoring heart rate, breath, and it is the antiquity regarding sleep. It is, you know, in France, it is a nurse who is going in your room and 3 or 4 times during the night with a little light. And on the morning, she is saying to the physician, he was sleeping or not. And then you are talking to your patient, and the patients just say the total opposite. So there is a clear need to have a better recording on monitoring clinical practice. So maybe this could be a first step to better characterize and use this kind of actigraphy, because regarding polysomnography, we also know that one night for insomnia patients, this could be maybe not so good and not so accurate. You should have the habituation night. So what are your thoughts about maybe to integrate more of this kind of...
Yeah, I think what I really dream of is a situation where I could monitor an insomnia patient with EEG-like, you know, devices for 4 weeks, you know, not just, you know, polysomnography 2 nights, okay, maybe 4 nights in a research project, but and there are devices out there. There is in France, it's the Dream company, but I'm skeptical, really. But there might be, I mean, many people think about developing or develop devices, you know, with one EEG electrode and kind of helmet or band you wear. And I think that there will be a breakthrough in the next 10 years that we get not only actigraphic, but also EEG data. The thing is, actigraphy is good. It tells you something about the sleep-wake rhythm. It gives you an indication of if people are awake or not, or a rough indication. But actually, as we said in one article, somebody said in one article in Journal of Sleep Research, the wrist is not the brain. You know, and actually, we can imagine if you have your smartphone, you type in your sleep diary every morning and every evening, and you wear a small headband which transmits the data, and you have an actigraphy in there. And maybe this would revolutionize our view of what sleep looks like, because I think the sleep lab is also, as good as it is, and I love the sleep lab and the PSG, it's also a major source of artifacts. Because the sleep lab is a sleep lab, and it's always such a strange situation. If you think about it exactly, what you do there, your sleep is watched, you are filmed during the whole night. You may be in a nice hospital setting, you may be in a stressful hospital setting, and you may be forced to sleep or to 8 hours. Some sleep labs may throw you out at 6 in the morning because they have to clean out the beds or the rooms and stuff like that, and really see what people do over 4 weeks during normal working and weekend life. I would love, and I'm looking forward to the moment when we have these devices to do that.
Wonderful. What do you think, Giuseppe? You have your hands.
Yes, I raised my hand because I want to take the opportunity to have Dietrich here.
Yeah.
To ask, I would like to go back to Hugo's question, because we also use, we work on narcolepsy, and we record the patient with deep narcolepsy and CNS hypersomnia extensively for many days with EEG, PSG. Usually we keep the patient recorded continuously, day and night for 5 days. So we keep the patient in for a week, and we keep them recorded with the video PSG for 1 week. And this is not so difficult to perform with now with the telemetric system.
Yeah.
They are very, very easy to dress. And also we have this experience because we record with actigraphy almost all our patients. So we have hundreds of patients recorded. And well, my impression is that for narcolepsy, for example, actigraphy can be diagnostic.
Yeah.
So with and also the use of actigraphy in treated patients is crucial because it helps patient to have a better adherence to treatment, behavioral and pharmacological treatment, and also the physician to understand what's going on. If the patient indeed has a problem with the treatment, or if is the patient that has a bad complaint with the treatments that we suggest him. So the actigraphy open a window between the patient and the physician, and also for long period of monitoring can help a lot. Now, especially now with telemedicine, because we have we had this problem for more than 1 year, and we had the telemedicine protocol for narcolepsy, and we keep the patients from all the part of Italy monitored also by actigraphy, and we saw that it helps a lot.
Yes. I fully agree with you. I mean, in a 5-day program, EEG, etc., for narcolepsy, I think health insurance will accept that, because narcolepsy, it's such a drastic change to have the diagnosis or not. It needs to be really on the point. On the other hand, if take one insomnia patient in your sleep lab, suspected insomnia, and I think they will crucify you probably.
Yeah.
So I can understand that we need other ways for insomnia than for narcolepsy, and definitely actigraphy is a very important way here to measure outcomes. But the problem with insomnia is it's a bit unspecific, and it's huge. I mean, if you look at the population, so many people out there. So if you demand excessively expensive diagnostics, probably health insurance and policymakers, they will just ignore you. And on the other hand, I guess I would love to have repetitive, something like PSG. It needs not be as good as PSG, but I would at least like to see proper sleep stages, quite validly measured sleep stages, and to have this done over 4 weeks in the natural environment. And that would be very enlightening. Maybe we run 100 patients or 200 patients or 500 patients, and we see the information we get there is not worth it. You know, it's not necessary. It's just that maybe the subjective information is enough. But beforehand, we should have to do it. And we will not be able to do it with polysomnography probably because it's too expensive.
Yeah. Professor Cerignotta, do you have just unmute your microphone.
No, I have no specific questions, but only one. How is another argument is the measurement of sleepiness, excessive daytime sleepiness. This, I think, is an open problem because we have some methods to measure state sleepiness and trait sleepiness. And then this, I think it is not until now a problem, despite the fact that sleepiness is an important problem, not only the sleep during the night, but also the problem of daytime sleepiness. I suggest I ask us if the participants have some idea about this.
Yeah, I'm not the specialist on sleepiness, but I think we heard a talk about that. I think it's totally important. It's sleepiness, fatigue, I don't know, decreased attention, all of that stuff is also a major problem. And we know much less about these issues than we know about maybe sleep apnea per se or insomnia per se.
Someone else want to answer to this question? No.
Maybe I can say a couple of words. So, I think sleepiness is an interesting phenomenon because it may be totally unrelated from the homeostatic sleep pressure. So circadian influence was mentioned quite a few times at this meeting, but probably we need to give even more attention to the possibility that sleepiness can increase or decrease as a function of the circadian phase. But this, for reasons we do not understand, and for actually talking also about the biological significance of that, and this would be completely independent of you being actually tired or staying awake for a while.
Yeah, you're right.
I think David Schreier gave a talk on that yesterday. Is he still here?
Yeah, he's not. So that's pity because he did a really wonderful job. Yeah.
But what I really think, sleepiness to some extent even sounds easier for me than fatigue.
Yeah.
And we have fatigue. I think neurology can sing a song about that. Fatigue, how detrimental it can be. We have, well, we don't call it fatigue. We call it then decreased energy or motivation and depression. But what actually it's something like fatigue. People with insomnia may have fatigue. And I think, too, we need major efforts to not only to understand sleepiness, but also to understand what is fatigue. Because usually, you know, if you talk to laypersons about that, they say, oh, come on, I know what it is. And okay, the afternoon, and then I have my coffee and then it's gone. Yeah, okay, that's maybe the layperson's fatigue. But fatigue, I've seen patients who've been, who had to stop work at the age of 45 due to some kind of never understood fatigue condition. And it was definitely not a neurotic condition, but it was not measurable. But these people were definitely unable to work with, and they were not depressed.
If I could add something about sleepiness and fatigue, since I've read a lot about that. Probably in the sleep world, we have more clear idea about sleepiness. Sleepiness is a complex concept. They have several aspects, several way of measuring, and several conceptual framework in which we work. But fatigue is even worse. It's not a consensus about what is fatigue. And even the word fatigue, as you said, Professor Riemann, is quite not the same for different patients and not the same for different languages. So there is probably, you have to start from the definition of fatigue, which is not univocal. At least sleepiness in HESD, in the DSM-5, you have the definition of sleepiness, of what is sleepiness. You can accept it, you can criticize that, but we have a clear definition what we think when we speak about sleepiness. But as regard fatigue, so you have more things to do than about sleepiness. And the communication this morning of David Schreier opened us some part of the discussion. But as I said this morning, probably you can do a congress about sleepiness and fatigue, and you should not raise any conclusion. So it's a real big problem. And apart from that, as you said, there is the part of depression, of neurological disease, and many other health problems that relate to fatigue. And then there is a problem of the consequence of fatigue on daytime life, on daytime living activity. So probably this is the field bigger than us, I would say.
Yeah.
But I think it's increasing, and so we have to take this point on us, at least as regards sleep disorders and fatigue.
Yeah.
And what is very interesting from clinical point of view, I don't know if you agree with that, but for sleepiness, the treatment finally is to sleep. And for fatigue, it is not to sleep. It is to rest, and it's not working every time. So very different kind of treatment and physiological pathophysiology.
Well, I do not agree that the treatment for sleepiness is to sleep, because sometimes sleeping in a sleepy patient increases sleepiness.
Yeah, that's right.
So it's not for all the patients. So it's not also the way to measure if it's sleepiness, to mismatch sleepiness for fatigue. They behave with power nap is not for everybody.
Yeah, it's for only subtypes of sleepiness patients. You're right.
I mean, you all know there's a huge commercial interest in sleepiness. And I think many big car companies have their own research departments and have installed, I don't have any of these new fancy cars, but I think they have anti-sleepiness measurements now. If you buy, the high-end product, they have some kind of pupil measurement, or they just measure the way you handle the wheel, and then they just lops up and drink a coffee now or something. But Giuseppe, you know something about that.
Yeah.
Yes, of course. This is one of the dimensions of sleepiness, the attention task and the reaction times. But we could treat, in the future, you could treat insomnia treating sleepiness. Empowering wakefulness and
yeah, in fact, I have a question about the future of insomnia treatment. So what do you think, Dieter? Where are we going?
I mean, actually, I had a sabbatical not 200 years ago, 2 years ago, and I read a lot of historical literature. And actually, I went back 200 years in the historical literature, and I read many, there are dissertations and habilitations about the views towards sleep. And it seems that at least in Europe, for the last 200 years, there have been two major strategies to combat insomnia. And it's a waxing and waning. And the one strategy says it's sleep hygiene, and the other strategy says it's drugs. So every 20 years, there's new drugs out there. It was in 1800, Hufeland, the dean of Charité, published a book on how to live longer, and it has a lot of recommendations to improve your sleep. by sleep hygiene. 20 years later, the bromides were published. Then, and so you see, it's a waxing and waning. These fields are like going like this. And I've been around now for almost 40 years, and I've seen a few waves of pharmacology. So actually the BZRA, or the Z substances, then antidepressants, then DORA, orexin receptor agonist. And I've seen a strong growth in the CBTI. At present, CBTI, which in a certain way goes back to the old sleep hygiene, it has some elements. At present has the most evidence, but I guess on the other hand, probably we'll see hopefully novelties from the pharmacological field. And I think it's always a kind of these fields, it's like the reciprocal interaction model of non-REM-REM regulation. For 10, 20 years, you have psychological means, then you have new drugs, and that interacts to a certain way. And we'll see where that ends. I think both strategies, we should be open for both. And in a certain way, the conceptions of cognitive behavioral therapy, they make sense. You know, they are evidence-based. And if you have a long time in bed, it makes sense you shorten that time in bed, because the long time in bed, if you just have a sleep propensity of 7 hours and you stay 9 hours, you lie awake 2 hours. And if you shorten it down, this might improve your overall sleep quality or your perception of sleep. So that makes a lot of sense. But I guess that we will also see new pharmacological avenues probably in the next 10 or 20 years. I think they're not backing out totally of the field. And I guess we'll see maybe new other psychotherapies. We see a novel non-invasive brain stimulatory strategies. Probably, I guess that's probably what will happen in the future.
Yes, Vlad, I have just a comment, and then I can give you the floor. I mean, sleep deprivation is an important part of CBTI, and it is also an important chronotherapeutic approach. No, so maybe it could be something that may combine chronotherapeutics with CBTI and insomnia. I don't know. It's the most important part. And we know that CBTI and sleep deprivation as chronotherapeutic can have a role against the inflammations. So it could be that sleep deprivation is the important part of both, treatments on inflammation.
I'd say probably the most useful part or most powerful part of CBTI is, well, it's not sleep deprivation, it's sleep restriction.
Restriction, yes.
A kind of partial,
partial, yeah.
It's not the full night, which many people probably would not accept with insomnia when you're normally working. So it's in a certain way what you do, you have an impact on process S. You increase a sleep drive, and there's also a psychological background to it. If you have insomnia, and let's say for a year now you have long times in bed and you wait for your sleep and it doesn't happen, you feel helpless, and then comes this crazy psychologist or psychiatrist whatsoever and suggests you should shorten time in bed, which is very counterintuitive, first of all, and then it works, and then there is an aha effect, and then people also realize that, okay, it was not me who found this out, but I got the recommendation to do that, and I can do that on my own. I'm the captain of my own ship, and that's some kind of self-empowerment you give back to patients if they understand the principle of circadian and homeostatic regulation. And that's why with many patients, I also discuss these issues and explain them to them.
Thank you. So Vlad.
Dieter, I also have a question. So in the last years, there was really like an exponential growth of studies and clinical trials with psychedelics like psilocybin and some related 5-HT2A agonists. So I would be interested to hear in your opinion about this class of drugs or this approach in general as a treatment for depression, and whether it can be useful for sleep disorders like insomnia in some cases.
Yeah, I probably didn't hear the first part of your question. You said drugs, but which drugs?
Psychedelics, like psilocybin, LSD, DMT, this class of drugs.
I mean, you know, there's a huge history to that. In, I don't know, the 50s, the 60s, and also many, LSD was taken as a model psychosis. I don't know whether psilocybin was also used. And there's a renaissance of that. In a certain way, ketamine as a depression treatment. Ketamine it's a tranquilizer for big animals, but it depends on the dose you take. It has immense psychedelic effects. But it can also kill you if you take too much. And that's a very difficult question. But also, I mean, the biggest hype is cannabis now, THC. Yeah. And it can be prescribed now for medical reasons, for certain indications. And we have not many, but a few patients with insomnia saying, couldn't I get a prescription for THC, not for the stuff you get for free, but for the stuff, it's still a regulated substance, THC. So I think the only indication in Germany is real pain. It's not insomnia, so there is no, you can't prescribe it. And I know there was research in the 60s on cannabis and sleep with mixed results, whether it's, because it has a biphasic or a bidirectional effect, it can also agitate you. You can get really anxiety attacks and heart palpitations, which are not so well compatible with sleep. But, you know, now the synthetic formula should be more controlled, I guess. But as far as I know from evidence from meta-analysis about THC, there is no evidence that it should be active in insomnia. Yeah, and it might be relaxing, it might be not relaxing. There's no evidence. And the other drug, there is no evidence that LSD, psilocybin, mescaline would act sleep-inducing, but definitely GHB, for example, has its place, a certain place in narcolepsy. Ketamine has a place in antidepressant treatment. So does it answer your question?
Yeah, I'm actually amazed that very few studies have been done on this class of substances like psychedelics and sleep. So there were indeed some early studies a while ago, but recently there was only one paper from a Czech group in Czech Republic that was published, but it was a very weak design, so it was difficult to conclude much.
Yeah, it would be very interesting. I would be interested in that as well. Maybe also as a subject taking part. No, but actually,
it's a controlled substance determined.
in order to do such a study, probably you need a special government license. Probably.
Absolutely, yeah. You do. It's yeah. We are running a project, but in animals. So we tried psilocin in mice, and it very effectively eliminated REM sleep for a few hours. So it had some influence on process S. So we are still trying to understand what this means. And of course, to do studies with psychedelic in animals is you don't really know how does it work in animals. Is it just a pharmacological substance? Is there any psychological component? But I'm amazed there are these major clinical trials at Johns Hopkins, at the Imperial in London, running where psilocybin is used for, terminal cancer and smoking cessation and depression, probably to name just a few, but very little about sleep.
Okay, yeah.
Do you think that GHB could have a place for insomnia in the future?
It really depends on policymakers and on legal aspects. I think it has it would work. I guess so. It would work. The question is, what the risks would be with if you just have insomnia. Narcolepsy is a different story.
Oh, yes, of course.
It's
But
such a debilitating.
narcoleptic patient, the first thing that report when they start GHB, that at the end I had a good night after 10 years, 20 years of really bad nights. Of course, it works, but it works really in a strange way.
Yeah. No, I guess it would definitely dose dependently. It would help people with insomnia. But the question really is, what would long-term effects be? You a non-narcoleptic insomniac patient. What happens after 3 months? Would there be addiction? Would there be tolerance? Stuff like that. And I think policymakers would be very careful to even allow research into that direction at that point. I'm not sure. Yeah.
Thank you.
Yeah, thank you so much. And there are some other comments from Professor Cerignotta or Giuseppe. Do you want to say something else? Or?
No, thank you. No other comment.
Well, thank you so much.
Thank you very much, Laura and everybody. And
yeah, it was a terrific day. Wonderful. Dieter, thank you again for everything.
Thank you.
Now I'm asking...
There is Luigi. Luigi is online, so he has certainly something to say.
He's online?
Luigi, yes. Ciao, Luigi.
Oh, dear professor.
We cannot hear you. You're muted, probably.
Unmute your microphone. Thank you.
Luigi, accendi il microfono.
Where is he? There he is. Hi, Luigi.
We cannot hear you.
You cannot hear me?
Okay.
Oh, yeah.
Now we do.
Go ahead.
Oh, okay. No, sorry, but it was open. You know, I don't know what happened. So I say that we are collecting data on this topic, and next year we will present directly the scientific data. You know, because the discussion is good. You know, but sometimes the problem is that, and I know also with people like Dieter, we have to present data. We cannot just to discuss. You know, this is the.
Oh no.
No, Dieter, I'm joking. Okay. Very nice discussion. Anyway, very nice discussion.
Thank you.
Okay, so thank you so much for everything. And Dieter, can you show to us your
yes.
life? Is a kind of informal. Is the way pandemic way to.
Then next year can
give a prize.
You mean?
Thank you so much for showing. Yes, wonderful. Thank you so much for showing your prize. It's wonderful.
Thank you. I love it.
Yeah, wonderful. Thank you, Dieter, for everything. Really, you did a wonderful job, and we are so happy for this year with you. So, is Ugo, do you want to close? Thank you anyway for everybody for being here, and to all the speakers and moderator. Is Ugo going to say something?
So yeah, just to close it, thank you so much. Now we have also the proof that you got the award, so we feel better now. So, and on behalf of the organizing committee, I'd just like to thank all the moderators, speakers, participants, panelists, the technical support team, and all the general sponsors listed in the program. A special mention goes to 2 participants who also happen to be past Pisa sleep awardees who have been honoring us with their attendance throughout the meeting. So Taria and Irene, thank you so much.
Yeah.
And of course, I'd like to thank, as many did, Professor Riemann, and officially, this is an official invitation to the 2022 edition in Pisa. So we can celebrate you all together in the local, cheerful way we are certainly capable of, as Chris Nissen witnessed before.
Yes.
So despite this virtual modality that we tried to avoid by postponing and postponing as much as possible, but we failed. Given the empathic as well as challenging nature of this meeting, hoping for a full recovery of international mobility, we are nevertheless very happy with the successful result and the remarkable quality and of all talks and discussions. A little advantage of this virtual meeting is that if you are caught by sudden nostalgia, you can actually watch the recording again and again and again. So, Enrica showed us
just for 11 minutes.
Just for 11 minutes.
Yeah. No more.
Enrica showed us the list of prominent scientists who received the award. And on behalf of the organizing committee, I would like also to thank the honorary committee, the selecting committee, for selecting over the years such an important list of sleep scientists and clinicians who really shaped the field. As Enrica mentioned earlier, the current committee is trying to alternate between basic sleep researcher and more clinical areas, and between genders as well. So, waiting anxiously for the disclosure of the next Pisa Sleep Award, we will try not to spend sleepless nights in the meantime, because we noticed that it's not particularly healthy. So we'll see you all in Pisa for the 15th edition of the Pisa Sleep Award and the 5th edition of 11 Minutes of Sleep that we will enforce physically, 11 minutes, as Professor Siciliano did. So thank you all, and we wish you all a very good night. Thanks.
Good night.
Thank you.
Thank you.
Thank
you.
Thank you, Pierre.
Bye-bye.
Bye-bye. Congratulations.